higher is the intensity of the stroke. Then it is another scale is modified ranking scale. Higher the number of the ranking scale, more is the disability. So these stroke scales are to be considered while what are the goals of acute stroke imaging? So we have to look for parenchyma, pipes, the vessels, intracranial and extracranial, perfusion, and penumbra. Penumbra is one thing which we can say with intravenous or intraarterial thrombolysis or a thrombectomy. So a primary CT, non-contrast CT is enough to rule out a hemorrhage. If hemorrhage is not there, we can think of ischemic stroke and go ahead with the further treatment. So there are certain subtle signs in CT like obscuration of the lentiform nucleus, which is an early sign of infarct. Then other sign is a insular ribbon sign. This is the normal insula. The insula appears to be little swelled up due to edema. This is again an early sign of stroke on CT. So a CT stroke protocol is what is very simple and which is very early to do. So this is a non-contrast CT, which you can see a hyperdense artery sign. CT angiography consisting of intracranial and extracranial vessels to image completely all the vessels. And this is a perfusion studies which we can have infarcted core and the ischemic penumbra idea with this CT stroke protocol is more than enough to make any decision, and it takes very less time. So there is something other CT score like aspect score, Alberta system of CT scoring system. So aspect score less than 7 predicts a worse functional outcome at 3 months as well as symptomatic hemorrhage. According to the study done with aspect score less than 8 treated with thrombolysis will not do well. So it is done at ganglionic level and at a supraganglionic level. So what is diffusion MRI? Diffusion MRI is one of the important stroke imaging which you can detect early stroke which is not seen in CT scan. So we see a diffusion weighted MRI here. This is the area is hyper intense in a few hours as compared to a CT or a T1 sequence, T2 sequence. But T2 sequence will get hyper at 7 days. You will not be able to see in first 24 hours. Only a diffusion will be positive. So diffusion is very important imaging. So these are the various territories, in fact, seen various territories, so which you can determine which vessel must have been occluded. So investigations important are echocardiogram, blood test, carotid ultrasound, and cerebral angiogram, invasive or non-invasive. So various subtypes of ischemic strokes are large artery occlusions due to from internal carotid artery or a cardiac stroke due to a plaque ulceration. So you can see in the image is a large hemispheric stroke with occlusion of the large carotid artery on one side, evident on diffusion restriction MRI. A large hemispheric stroke in grave prognosis basically. Then 13 to 20% are lacunar strokes which are due to very small vessels of the perforating branches and which are mainly deeper, like in the internal capsule. The causes are small atheroma, lipohyalinosis, fibrinode necrosis, amyloid angiopathy, etc. Then embolic strokes are 20% of the ischemic strokes which can occur due to valvular thrombosis, like mitral stenosis, endocarditis, mural thrombosis, atrial myxoma. So can give rise to stroke in watershed area, posterior cerebral artery, or a ganglionic area. And there are certain things like thrombotic, so there are thrombogenic states like sickle cell anemia, fibromuscular dysplasias, hypercoagulate protein C, protein S deficiency. They are basically thrombotic strokes. Then there are certain watershed infarcts where there are various zones where hypotension or stenosis in the carotid or can lead to this infarcts. So others are flow disturbances. When there is a blood hyperviscosity, like due to sickle cell anemia, multiple myeloma, or polycythemia vera, these flow disturbances also can lead to this ischemic events. So this is just a grossly 52-year-old male with gradually deteriorating sensorium and right-sided weakness. You can see a central semivolus stroke with an external carotid pinching, hyperdense artery sign on CT, and on diffusion you can see a large MCA territory stroke. So how to manage this is a matter of discussion which will come later. So management. So pre-hospital management is having public education programs so that the patient will reach to the hospital as soon as possible, making of regional stroke centers, Every hospital should have a stroke team, so that and the patient should be transported to the nearest center which can give IV at the place. You don't need to transport a center where we essentially have a cath lab, and should have an organized protocol. If we are at a remote place, then some telemedicine, teleradiology can be used. Now it's the era of WhatsApp. You can consult and you can give IV at the place in your own center, which can be remote and can just save someone's brain. So some scales like NIHS scales can be used for rating. Modified ranking scale can be used for rating of disability. Imaging for IV alteplase therapy, plain CT is enough. If we rule out a hemorrhage, we can give IV alteplase. So MRI is not required for IV alteplase. Or further imaging, if we require planning for a thrombectomy or something like that, you need to do CT angio or CT perfusion studies. So other thing are, regarding mechanical thrombectomy. So if the onset of stroke is within 6 hours, you can subject the patient to a mechanical thrombectomy on the basis of CT angiography or a perfusion studies. So 6 hours is the golden period of a mechanical thrombectomy where outcomes will be better. Now the window period for mechanical thrombectomy is extended to 24 hours with detrimental effect. It has, as the time goes on, the mechanical thrombectomy is not also effective actually. So we will talk about IV alteplase. It is a tissue plasminogen activator. It should be given within 4.5 hours of the onset of the stroke. Intra-arterial can give till 6 hours. And the basic thing is like BP should be less than 185 to 110, and the blood, there should not be any hypoglycemia or hyperglycemia. Recommended dose is 0.9 milligram per kg. You should not exceed 90 milligram. 10% to be given in 1 minute, and the rest you can give in 60 minutes as an infusion. So major contraindications, like if there is platelets are low, if there is a seizure at onset, the blood sugars are deranged, if the blood pressure is too high, and there is a risk of hemorrhage after giving IV alteplase, you should not give IV alteplase in such cases. So tenecteplase is another alternative which people advocate, but according to the trials, it doesn't have any superiority over IV alteplase therapy. So there are mechanical thrombectomies of two types. One is a catheter aspiration thrombectomy, where blood clot is removed by a suction, and another is a stent retrieval. Stent retriever is there, which is just pull out the clot from the affected vessel. So we will certainly jump to case scenarios to what decision making we should take in certain cases. Like 45-year-old male, he came with a CT brain in outside hospital was normal. 9 a.m. he had right-sided weakness, slurred speech. MRI of brain was done at 12:30 p.m. So in that NIHS score was 10, and found a coronary radiata ischemia in that. So patient was coming in less than 4.5 hours. So we had had been given a TPA, and the NIHS score improved. So at 24 hours, the NIHS score improved 4, and on discharge it was 2. Another case scenario, 51-year-old male, he had onset of stroke at 5 a.m. MRI of brain was done at 8 a.m. Came to hospital at 11 a.m. NIHS was 14, so almost there was 6 hours gap. So further investigation, diffusion restriction was seen in the insular area. Angiography was done, a DSA, which showed right IC occlusion. So the patient was taken in the cath lab. In the same sitting, a stent retriever was put and the clot was taken out. Patient, the cerebral circulation was again re-established, and on table the NIHS improved, the sensorium of the patient improved. Another case, 80-year-old female, presented to hospital in 3 hours with left-sided weakness, known hypertensive. We can find there are some embolic stroke in the coronary radiata, and there is a cutoff from the right carotid artery at the intracranial part on MR angio. There was a cutoff in the intracranial artery. So the patient was taken from thromboaspiration. This was the clot which was aspirated. After aspiration, the blood flow was restored to the brain. So So the patient improved post-procedure NIHS to 8. And so age does not matter. We can do thrombolysis or thrombectomy at any age. This thing is 47-year-old female, right-sided hemiparesis. She was having COVID and diabetes. So MR angio was done. We can see there are multiple infarct, small cell infarct in the MCA territory, posterior cerebral artery territory, anterior territory. So on MR angio, non-contrast imaging was done, which was suggestive of stenosis at the at the left internal carotid artery. Intra-arterial circulation was normal. So there was quite pinching of the carotid artery here on the DSA. So the patient was planned for a balloon angioplasty. So, and further, with a distal embolic protection device, a carotid stent was put, which restored the circulation to the cerebral vasculature better than before. So this thromboaspiration was also done, which removed a small clot and plaque which was present in the internal carotid artery. The patient did well on discharge. At 6 weeks, they had no symptoms. This is one patient which 59-year-old male is presented with amaurosis fugax, that is had episode of transient loss of vision in the right eye, but there was no neurological deficits. Then the patient had a 90% stenosis in the carotid. So the patient was taken for again DSA. Tight stenosis was present, and the patient was stented, which restored the cerebral circulation. It is called as angioplasty, and a stent was placed in the internal carotid. So another 5 minutes, please. So other general supportive care like dysphagia needs to be taken care. Prophylactic antibiotics are not indicated. Pneumatic compression devices are important more than LMWH therapy. Blood glucose, sodium levels, hypotension, hypovolemia should be corrected. BP should be corrected to less than at least 180 systolic. Other complications like brain edema, seizures can be taken care by drugs like mannitol, anti-seizure medications. Corticosteroids doesn't have any role. If the patient has deteriorating consciousness, we are suspecting some herniation, then a decompressive craniectomy is indicated in such cases. Further, moving to the hemorrhagic stroke, just 2 minutes. Large hemorrhage is seen in the CT. So this volume we can measure. If the volume is more than 60 ml, the prognosis is grave. So there are various sites of hemorrhage like lobar, putaminal, thalamic, pontine, cerebellar. So and certain hemorrhages can occur due to AV malformation or aneurysm. They have different modality of management. So surgical management of this is decompressive craniectomy. So I'd like to show one video. A 58-year-old male with uncontrolled hypertension, diabetes, vomiting, once episode of seizure. Then the patient was planned for right FTP craniectomy with ICP monitoring. This is a FTP incision. This is the temporal bone, it's the parietal area. So this much part of the about 15 centimeter by 13 centimeter of the bone flap is removed. ICP monitor is connected. 25 is the ICP. Normal intracranial pressure is 20. You can see the brain swelling. And post decompression, the ICP decreased to 3. So the bone flap to 2, see, post decompression so this is a good scan, and the patient also improved afterwards and was tapered from the ventilator. So you can do another way is endoscopic evacuation. These are the endoscopic materials. And further, they have complications like URTI, UTI, thromboembolism, cardiac complications, heart failures, psychiatric problems, pressure ulcers, post-stroke fatigue syndrome. Certain secondary prevention of stroke comprises of antiplatelet, anticoagulation, blood pressure control, exercise, statin use, treating obstructive sleep apnea, And top foods, one of the top foods that has been thought to prevent strokes are this: oats, almonds, soya, strawberry, cornmeal, banana, blackberries, etc. So rehabilitation is very important for any stroke management, training of motor skills, spasticity, depression, activity, speech therapy. So conclusion that time is brain. You should report to earliest to the any higher center and try to prevent or modify the lifestyle so that we don't land up with this mess. I thank, these are my references. I thank JRH to give me this opportunity. Thank you very much. I would like to have any questions, if any, from the audience.
Hello. I thank Dr. Yogesh Savkare for beautifully explaining the fine intricacies of stroke management, whether it is assessment by improved scoring system or management of emergency patient or the window period of thrombectomy. So I invite any questions if you have the audience.
Suppose there.
Sir, if there is no question, I have only one request. Whosoever presents this topic, there are multi-specialty people. They do not know your field of, they do not have your field of expertise. So I will request you to give some take-home messages which are really important so that patient gets to you as fast as possible. So from the lecture, I took only 3 points. One is time is important. Second is to differentiate with hemorrhagic and non-hemorrhagic stroke. CT scan is important, MRI is not required. Third is on the basis of report, MRI, CT scan report, you can decide the treatment. Once you have done thrombolysis, after that you will decide what further course of action will be taken. And last point was also equally important, the rehabilitation. That is my take-home message, but you tell on your behalf.
Yeah, correctly said, sir. So, yeah, take-home is like earliest detection of stroke is very important, and earliest moving to a center which it can be managed is very important. Of course, you don't move to a center where a cath lab is there. You move to a center where at least IV altiplase can be given and where imaging is available. So early movement is very important, and of course rehabilitation therapy. And further neurosurgery comes at a very later stage. First is prior to, prevention is more important than cure. Basically, you should not land up in this mess. Nowadays, a lifestyle problem is there. So prevention is always better than cure. Thank you very much for the...
Thank you, Dr. Yogesh. Please give him a big hand.
Now
I request document.
Now I request Dr. Rajkumar sir to hand over memento to Dr. Yogesh. Next speaker for this session is Dr. Siddharth Murlidhar, Senior DMO Cardiology, Perambur Hospital. I request chairperson to introduce the speaker for today's session.
Good morning. Our next speaker is Dr. Siddharth Murlidhar. He is MBBS, MD, and DM Cardiology. Presently working as Senior DMO Cardiology at Southern Railway Headquarters Hospital at Chennai. His field of interest are structural heart interventions, PAMI, heart failure. Received Best Abstract Paper Award in 2012 in JRHCON, multiple publications in Index Journal. I welcome Dr. Siddharth Murlidhar to give his deliberation.
Thank you, sir, and thanks for inviting for this conference. Today I'll be speaking on a very important topic, worsening heart failure. We regularly encounter patients with heart failure and we know what to do, what is the management. But this is a new entity which was first discussed in the 2022 and 21 ESC and ACC guideline respectively. So what is worsening heart failure? It's a distinct entity. It is underdiagnosed and often undertreated. And each worsening heart failure event is associated with further worsening of cardiac function, and also it indicates the disease has entered a new phase. It has a poor long-term outcome with mortality seen in up to 1/5 of heart failure patients within the 2 years of diagnosis of heart failure. So coming to the Indian scenario, only 25% of patients who have heart failure with reduced ejection fraction receive guideline-directed medical therapy. There is often a lack of awareness regarding guideline-directed medical therapy among the physicians, cardio-physicians, and even some cardiologists. And also there is a poor tolerability among the patient is seen. This results in inability to reach the target dose of the guideline-directed medical therapy, and we need an innovative solution for this. So now coming to the definition of worsening heart failure, it is defined as a deterioration of heart failure signs and symptoms in a patient with chronic heart failure despite previous stable background therapy, and requires an urgent escalation of therapy, which includes both hospitalization or emergency department visit, or outpatient IV diuretic therapy, or outpatient oral therapy, or both. So this is a flow chart, just shows the traditional and the new theories of heart failure clinical course. So the blue line, as you can see, it represents the traditional view of the course of the chronic heart failure with episodes of acute decompensation. However, if you see the red dotted line, it's a new theory that the worsening heart failure is preceded by gradual, progressive, subclinical worsening. And there's a subclinical high-risk state that follows an apparent clinical recovery and discharge. So there have been a lot of trials being done on heart failure, and these are the summaries of heart trial failures. But one important is the Victoria trial, which I want to stress about. It is the only trial which dealt with this worsening heart failure. And patients selected were of very severe disease, NHYA class 3 and 4. And so what it shows was that adding the novel drug like Vericiguat will improve outcomes in the patients, especially in the severe heart failure patients. And these are the newer trials, like Solistit, worsening heart failure and impulse trial. And now coming to the goals of management. Basically, the goals of management is to reduce heart failure hospitalization. Prevention of progression to advanced stage requires advanced therapies like ultrafiltration or even LVAD and even heart transplant. Reduction in CV mortality, which should be the aim, and improvement in signs and symptoms, and improvement in the ejection fraction. So what we should done is early, simultaneous, rapid initiation of foundational therapies in hospitalized patients to provide an early clinical benefits. Initiate multiple therapies early and optimize therapy in hospital patients with an early follow-up, preferably within 1 to 2 weeks. The ACEs, ARBs, and ARNIs should be initiated when the BP is more than 100 millimeters of mercury and the patient is off IV diuretics and inotropes. And after mobilization patient, beta blockers should be started who are off inotropes and diuretics. And in my practice, I start SGL2 within the hospitalization, apart from escalation of diuretics, which is mostly 2 times the normal which patient is receiving. And we should check for the eGFR after starting the SGL2. So this is the Vericiguat which I spoke earlier. It may be added in the following condition. The worsening heart failure in event which when a patient first comes to us, despite treatment with GDMT, it may be added in this condition. And when the patient is unable to tolerate other drugs, even including SGLT2, and this can be added, and it is to be also during pre-discharge and soon after. And it can be also used in patients who have eGFR less than more than 15 ml per minute. So this is an approach to how to decongest patient in a, when he presents with worsening heart failure. So as you know, sorry. So first step is rapid sequence of simultaneous initiation of disease modifying therapy. So generally what the guideline says to start a quadruple therapy of ARNI or ACEs along with beta blockers, MRA and SGLT2. But what I practice is to start the Vericigut as a part of quintuple therapy. And if the patient has iron deficiency, so give him an iron infusion of basically FCM. And initially starting with the low dose, then rapid escalation till the patient tolerates. So the strength of recommendation, as you know, is it improves the heart failure outcomes, including mortality. And Victoria trial has summarized the advantages of using Vericigut. So in summary, the worsening heart failure event is a time to optimize the heart failure therapies, and if needed, add novel therapies like Vericigut. A personalized approach is needed for especially with patients with heart failure with reduced ejection fraction, with guideline-directed medical therapy as a cornerstone in the management. Initiating early multiple therapies during the worsening heart failure event should be optimized and improves the outcome. Thank you. Questions?
Thank you, Dr. Murthy, for your nice presentation. Sir, I will request the same thing to you also. Please mention the take-home messages.
Sir, that is in the summary. That is the.
You'll send. Okay.
Yes, sir. Final is a summary of whatever I spoke.
Okay.
That is the take-home message.
Thank you. And if there is any question, please.
Sir, we have dapagliflozin, which I have used, and the results are good. But before starting any drug, we should tell them about the side effects. And if they don't have UTI and any infection. So first I do my routine urinary examination. If it's normal, then I start him. That is easy in patients who are admitted. But yeah, irrespective of diabetes, it is the it is now the class 1 indication even in patient mildly reduced also, sir. Yeah, 430 का तो नहीं रहता.
Thank you, Dr. Murthy again. Please stand here.
Yeah, I request Dr. Chakravarti sir to hand over a token of appreciation to Dr. Siddharth. Thank you, Dr. Siddharth. Our next speaker is Dr. Avinash.
Ladies and gentlemen, as I told you, we have a galaxy of speakers today lined up for the sessions. So I invite Dr. Avinash Arke, who is basically pediatrician but with experience in cardiology and currently working as senior DMO at Jagjivan Hospital. He has also worked as assistant professor cardiology at AIIMS, Raipur. And he has special interest in congenital and structural interventions with special skills of fetal, neonatal, and pediatric cardiology. So he is also joint organizing secretary of this conference. So please give him a big hand. And he is going to speak on big enemies around baby's heart. Over to Dr. Avinash Arke. Thank you.
Thank you, sir. Good morning. I thank our DG ma'am, our PCMD ma'am, our GM sir, and our MD ma'am for organizing this conference and helping us to share our experience with all of you. So today I'm going to talk about big enemy around baby's heart, and I will be talking about congenital heart disease. So overview, in this topic I will be covering about the magnitude of this problem, the risk factors for congenital heart disease, their various types, early diagnosis, management, and prevention. Here we will not go into details of chest X-ray, ECG findings, or details of clinical examination and all. So, as we all know, the incidence of CHD is around 1%, from 0.8 to 1.2% of all the live births per year. And we also know that in children, the most common CHD seen is ventricular septal defect, and whereas in adults, it is atrial septal defect. About 1 in 4 babies with CHD have critical CHD, and that requires urgent interventional or surgical intervention in the first year of life. And if we consider the incidence as 9 per 1,000 per live births, the estimated number of children born with CHD every year in India is approximately 240,000 and in India, and in 1.35 millions globally. So before going to CHD as such, this is the normal circulation of a heart. So we know there are 4 chambers. The right-sided chambers, that is right atrium and right ventricle, they are connected to the pulmonary arteries, and we receive deoxygenated blood on the right side of our heart. When circulated into the pulmonary circulation, the oxygenated blood comes to left side of the heart in the left atrium.
Welcome to our DG ma'am, PCMD, MDs, all PCMDs. Morning, ma'am. Please settle down. Dr. Avinash, you can continue.
Thank you, sir. So from the left side of the heart, we get oxygenated blood supply. And as we saw, the circulation here is in series. So what are the risk factors for congenital heart disease? So usually, less commonly seen in Indian setup, but still it is seen, that is smoking during pregnancy, excess alcohol consumption during pregnancy. These are the major risk factors. Then diabetes during pregnancy, either it can be gestational diabetes mellitus or type 1 or type 2 diabetes. So sugar has to be controlled. Certain genetic syndromes, they are associated with congenital heart disease and other structural anomalies. Rubella infection during pregnancy, and certain medications consumed during pregnancy, like lithium, isotretinoin, phenytoin, valproate, they are all associated with congenital heart disease in babies. So what are the types of CHD? So basically, on the basis of presence or absence of cyanosis, CHD can be categorized into acyanotic heart disease or a cyanotic heart disease. If there is a cyanosis, it is cyanotic heart disease. And this acyanotic heart disease further can be categorized into, based on whether it is a shunt lesion, regurgitant lesions, or obstructive lesions. They can be among the shunt lesions. If the shunt is at the level of atria, it can be atrial septal defect or PAPVC. If the shunt is at the level of ventricle, it is ventricular septal defect or atrioventricular septal defect. If shunt is at the level of aorta or pulmonary artery, then it is PDA or AP window. Among the obstructive lesions, we have valvular obstructions like mitral stenosis, aortic stenosis, then coarctation of aorta, pulmonary stenosis, double chamber right ventricle, where we have obstruction just below the pulmonary valve. Then among the regurgitant lesions, if the same valves, if they are regurgitant, so like mitral regurgitation, if it is, if anterior mitral leaflet, if it is cleft, it can result in regurgitation of the mitral valve. Similarly, aortic regurgitation. If patient has a bicuspid aortic valve or a unicuspid or quadricuspid aortic valve, it may be leaking valve. So patient can get aortic regurgitation. Similarly, if there is a dysplastic tricuspid leaflets, then it can result in tricuspid regurgitation. And similarly, pulmonary regurgitation, that is too rare. And among the miscellaneous conditions, we have coronary cameral fistula, where the blood flow from the coronary arteries is going to any of the chambers, either on the right side or left side or the pulmonary artery, anywhere. And then if coronary arteries are arising from arising not from the aorta but from the pulmonary artery, so that is ALCAPA, anomalous left coronary artery from pulmonary artery, or anomalous right coronary artery from the pulmonary artery. And similarly, if there are some cardiomyopathies are there, which can be from birth. Among the cyanotic CHD, This we classify based on whether the pulmonary blood flow is increased or if it is decreased. Among the increased pulmonary blood flow situations, we have truncus arteriosus, TAPVC, total anomalous pulmonary venous connection, detransposition of great arteries, single ventricle without pulmonary stenosis. And among the decreased pulmonary blood flow conditions, it is tetralogy of Fallot, DORV with VSDPS, DTJ with VSDPS, CTJ with VSDPS, single ventricle with pulmonary stenosis, or atrioventricular septal defect with pulmonary stenosis. So, how to approach the child? What are the symptoms that baby may have? So, these babies can be not growing properly, there will be failure to thrive, or they will be short or thin for their age. They may be rapid breathing, or they may be having difficulty in breathing, becoming tired earlier. Some babies will have excessive sweating. Those babies who have increased pulmonary blood flow situation, whether it is cyanotic or acyanotic, they will be having excessive sweating while feeding. They may get fatigue early. They may have rapid heartbeat, increased precordial activity, and most important is cyanosis. Some babies may be cyanotic. So this is a one diagnostic approach for babies. So if we see two things, one is heart failure and cyanosis, we can almost arrive at a diagnosis clinically. At least some differential diagnosis we can give. So if baby is having cyanosis, definitely it is a cyanotic congenital heart disease. If there is no cyanosis, but saturation is still less than 95%, that also it is a condition which is cyanotic heart disease. So if saturation is low, but patient is not in heart failure, then it can be a pink tetralogy of Fallot or TOF-like conditions. Then if patient has low saturation cyanosis, but patient presents with heart failure, then it is a admixture lesions. And if there is no cyanosis and patient presents with heart failure and there is murmur, so conditions can be VSD, PDA, that is post-tricuspid shunts, complete AVSD, severe MRTR or severe AS. And if there is no cyanosis and heart failure, but no murmur, so it can be cardiomyopathy, tachycardiomyopathy, myocarditis or Al-Kappa. So this is something about atrial septal defect, which is the most common CHD seen in adults. It is around 15 to 20, it constitutes around 15 to 20% of the CHD. So this is the ostium secundum ASD, where the defect is at the level of foramen oval. And among all the ASDs, ostium secundum ASD constitutes around 75% of the 75%. So these are the indications for closure. If baby is symptomatic, usually seen in seen in less than 10% of the cases where babies will be symptomatic because of ASD and they develop symptoms in first year of life. So if we find the symptomatic baby, they should be closed earlier. And if babies are asymptomatic, closure should be done in 2 to 4 years of age. That is before going to school. And if they present beyond the ideal age, then it should be closed whenever it is diagnosed. And the mode of closure is either it can be a surgical or a device closure. So next type of ASD is ostium primum ASD. It is seen in 15 to 20% of the babies with ASD. And usually it is associated with inlet type of VSD and a cleft AML. So ideal mode of treatment is surgical. So there is no intervention for this kind of structural heart disease. This is a sinus venosus type of ASD, which is seen in 5 to 10% of the patients with ASD. If they are asymptomatic, again it can be closed in 2 to 5 years of age. And if the ideal age of, if they present later than the ideal age, then it can be closed electively at any age, provided there is no cyanosis, there is no severe PAH. And mode of treatment, mode of closure is surgical. So this is a child which is undergoing ASD device closure. So this is a deployment of the left atrial disc and followed by the right atrial disc deployment. And this is the device in situ. So something about ventricular septal defect, which is seen in, it is the most common CHD seen in children, around 20 to 30% of the cases. And these are the types of VSD. Depending upon the location of the ventricular septal defect, either it can be membranous defect or the muscular. Among the muscular, it can be inlet defect, it can be outlet defect, or it can be trabecular muscular VSD. So this is a child with ventricular septal defect. Here the defect is in the perimembranous septum, and it is associated with mild aortic regurgitation because of prolapse of the right coronary cusp. And since there was prolapse and aortic regurgitation, the ideal treatment of choice for such babies is surgical closure. And this child has undergone VSD surgical closure. So these are certain indications for ventricular septal defect. If it is a small VSD, we don't prefer closure. We just follow such babies and follow this for development of any prolapse of the aortic cusp. And if there is a prolapse, we have to follow very closely. If they develop even mild AR or less than mild AR, we have to close this VSD surgically. In case of moderate VSD babies, if they are symptomatic or with pulmonary hypertension, they should be closed. And large VSD, they should be closed in 3 to 6 months of age. Usually they will be having heart failure symptoms. So this is a child with a mid-muscular VSD where this VSD has been closed with a muscular device, VSD device. So this is something about patent ductus PDA, patent ductus arteriosus, which is seen in 5 to 10% of the cases. So these are certain indications for PDA. So usually PDA, it is a communication between the aorta and pulmonary artery. So in this echo image, you can see this is the descending thoracic aorta and this is the pulmonary artery. And this is the communication between the aorta and the pulmonary artery. So this is the communication between the aorta and the pulmonary artery, that is PDA. So here this patient is undergoing PDA device closure. This is the descending thoracic descending aortogram where injection of the contrast into the descending aorta is showing filling of this PDA and filling of the pulmonary artery. This is the here is the pulmonary artery, and that is PDA here. And this is the PDA device being deployed, and this is the PDA device in position and with no residual flow. This is coarctation of aorta, which is seen in around 6% of the cases. Here, this is the echo image, where coarctation is a narrowing in the descending thoracic aorta, usually at the level of ductus arteriosus insertion, and it will be around the left subclavian artery. So in this echo image, you can see there is a turbulent flow, and when we put a continuous wave Doppler, there is a huge gradient. It is more than 60 mmHg peak gradient. So this is a severe coarctation. These are certain indications for intervention. So whenever the gradient is more than 20 mmHg, it is indicated to do either coarctoplasty or put a stent in the coarctate segment. And these are, if gradient is less than 20 mmHg and the patient has left ventricular dysfunction or upper limb hypertension, left ventricular hypertrophy, significant collateral formation, and more than 50% narrowing on the imaging, then it should be closed. It should be corrected. So this is a child patient who presented to us with accelerated hypertension. He is undergoing coarctation of aorta stenting. So this is the descending aortogram, which shows tight narrowing just after the left subclavian artery. So, and here the stent is being deployed, and this is the angiogram after putting a stent. So there was no residual gradient after the procedure. This is about aortic stenosis. So again, this is a child with severe aortic stenosis, which is undergoing balloon aortic valvuloplasty. This is about pulmonary stenosis. Here you can see in this angiography, this is a lateral view of the right ventricular angiogram, where you can see the tight narrowing in the pulmonary valve. So here this child is undergoing balloon pulmonary valvotomy, and this is after the procedure. So these are certain procedures which can be done in patients who are cyanotic, because cyanotic CHD is a emergency. So those babies who are having duct-dependent circulation, either it can be systemic circulation or pulmonary circulation, they can undergo PDA stenting. Initially, we have heard about BT shunt. So it is just like a BT shunt. BT shunt is done surgically, but it increases the mortality and morbidity. So to prevent that, PDA stenting can be done. Then in this next image, here you can see this is the RVOT stenting. This RV angiogram shows severe infundibular stenosis. But this patient with top with severe infundibular stenosis can undergo RVOT stenting. But this is just a palliation. It is not a corrective procedure because still that VSD is still there. But this is indicated when, because of certain other comorbidities like coagulopathy of cyanotic CHD, if patient is inoperable because of coagulopathy, in that case, for initial improvement of the pulmonary circulation and saturation, this RVOT stenting can be done. So, next question comes, whether this can congenital heart disease be prevented? So, answer is yes, but not always, but we can try to prevent them. How it can be prevented? So, if we administer rubella vaccination to all the ladies, it can be, and to prevent them get rubella during their pregnancy, it can be prevented. They have to avoid alcohol and smoking. They have to control their sugars very nicely during their pregnancy, and then folic acid supplementation, avoiding unprescribed medications, prevent infections, prevent preterm deliveries, regular antenatal follow-up and care. So these are certain steps which can help us in preventing congenital heart diseases. So apart from the institutions or doctors, what government can do in this? So government, we know that the number of MBBS seats are increasing, number of pediatric cardiologists, cardiac surgeons, cardiac anesthetists are increasing, the well-trained nurses are increasing. So that is a step which can be help us in reducing the mortality. Then those who are unprivileged, if we extend our help to them, it can be, this mortality can be prevented. So we have different programs. So from at the level of central government, state governments. So I would like to tell you about one program. This is Hridayam. It is run by the government of Kerala. So in Kerala, the infant mortality rate was constant from almost around 2007 to 2015. It was around 12 to 13. So all the preventable causes of mortality in infant mortality, they used to take care of those infectious diseases. So in 2017, they implemented Hridayam program where all the patients with congenital heart disease, they got treatment at government as well as certain empaneled private hospitals. And they channelized it in on the website. And after that, after implementation of Hridayam program, they found that the infant mortality rate drastically decreased to 7 and 6 in 2018 and 19. So to summarize, congenital heart disease is a common cause of morbidity and mortality in children. So early diagnosis and treatment can save many lives. Routine implementation of SpO2 monitoring in a normal looking neonate before they get discharged from the hospital facilities, early detection, it can help in early detection of drug dependent circulation. And as I said earlier, the government commitment can have major role in this. Thank you.
I thank Dr. Avinash RK, who has beautifully explained the complex issues of big enemies around baby's heart. And his presentation, he has nicely shown how to deal with them. Now, any questions from the audience is welcome. Please give him a big round of applause for his this rare and nice topic. Thank you very much.
Yes, ma'am. Antenatal fetal echo can be done and it can detect. Usually this fetal echo, during ANC checkup, if radiologist or gynecologist find some abnormalities in the heart, they refer for fetal echo. So that can be done.
If any other question is not there, I will ask one question. Sir, you said that BHD is the most common. Yes, it is correct. But the preventable and the most disturbing is PDA. You can take care of that in the neonatal period itself after birth.
Yes, sir.
Most of the premature babies, and that can be taken care of by our own pediatricians, those who do not have expertise in your, I think, pediatric cardiology. That is with medicine also. So I think that should have been highlighted. You just can have
Yes,
few
sir.
words about that.
Sir, as sir has rightly pointed out, the preterm babies born at before usually 34 to 36 weeks or before that, they are more prone to get ductus arteriosus, and it will remain patent, and they can present to us with heart failure. In those babies, there are certain other issues of the prematurity like hyaline membrane disease, HMD, or tachypnea of neonates. So it will be little difficult for a pediatrician to differentiate whether that baby is in heart failure or it is due to HMD or neonatal pneumonia. So, but any baby with any preterm baby with PDA, we should go ahead with a trial of medical management. Earlier, they used to give indomethacin, but this indomethacin used to have some toxicity like NEC and renal failure and all. But nowadays, a safe drug, that is paracetamol. Simple paracetamol also can be given for this purpose. So dose will be, if we give 20 mg per kg per dose QID for 2 days, so it will help in closing the PDA medically. So that is a very nice point that sir has pointed out.
Thank you so much.
Thank you, sir.
I request Dr. Chakravarti sir to hand over token of appreciation to Dr. Avinash. So our next speaker is Dr. Savita Gangude.
Okay, our next speaker is Dr. Savita Gangude. She is HOD Department of Medicine and Nephrology at Jagjivan Ram Hospital. She is also Secretary Railway Chapter of Association of Physicians of India. And she is also working as practicing nephrologist for last 19 years. She is co-editor of API, DNB teacher, guide and examiner. And hold your breath, she is a fitness enthusiast. She has completed 26, I repeat, 26 half marathons. My score is only 9 half marathons, but she has completed 26 half marathons. So I present to you Dr. Savita Gangude, and she is going to speak on management of anemia in heart failure. Thank you very much.
Thank you, Dr. Rajkumar, for updating my information. And good morning, ma'am. Good morning, all dignitaries. I'll be speaking on a topic which is very dear to my heart, anemia in heart failure. So anemia is very dear to my heart, but in heart failure, how we are going to tackle it, that I'll describe in next few minutes. See, this will be my scope of discussion. Actually, anemia is a very common problem, and according to National Family Health Survey, at the age group of 16 to 49, it is found in 57% of females and 67% of adolescents. This is our own India's fact. That's why Ministry of Family Welfare has started the program Anemia Mukt Bharat. And coming 21st March, we'll be observing that anemia day, National Anemia Day. WHO data is also very big, 40% in adolescents and 30% in females. This is about anemia, heart failure in anemia. So WHO study, which was done with 15,000 people, ERIC study, which showed anemia in heart failure patient 9%, where the age group was 49 to 60. ASGO study in 2006, quite big study, around 60,000 population, and anemia prevalent was 43%. And another one study in 2003 showed anemia prevalence 17%. So anemia is one of the big enemy as far as heart is concerned. This is meta-analysis done, presented in Circulation 2006, which showed that these are 15 papers, and all the studies showed that the anemia prevalence 30% in inpatient and 20% in outpatient patients. This is again stamina registry, which showed that anemia prevalence increases as the NYHA class increases. And this was one study presented with Horvick et al., where showed that anemia, heart failure, death in mortality in anemia is increases as the hemoglobin decreases. So we have to know that anemia is one of the biggest enemy for heart. And what are the causes of anemia? 40 to 50% have concomitant CKD, and diabetes is one of the problem for these patients. Inflammation and cytokine also help in, they are cofactor or the culprits for anemia. Aspirin use is one of the biggest thing which you all know, that many patients of us present with GI loss because of aspirin-induced gastritis. ACARB, which is one of the 4 pillars of anemia, heart failure treatment, is also one of the enemy. And decreased iron absorption due to many reasons is one of the hemodilatation and nutritional. These are the various factors. This is a nutshell pathophysiology. Heart failure is there is pneumohumoral activation, the release of cytokines which will increase hepcidin, which prevents iron absorption. There is renal changes, and then decreased erythropoietin secretion or erythropoietin resistance. There is GI loss, there is malabsorption, there is anorexia. So these are various factors which lead to ultimately anemia, and we have seen these studies that anemia is one of the predisposing or cofactor which is present in heart failure patient. In diabetic, there are few other mechanisms, and 40 to 50% of the patients who are presenting to us with heart failure are diabetic. So nephropathy, diabetic nephropathy is present around 40% of the heart failure or diabetic patients. Diabetic neuropathy, which reduce erythropoietin level, is also one of the factor. Then hyperglycemia itself decreases erythropoietin resistance. When there is insulin resistance, at the same time there is erythropoietin resistance. So though the erythropoietin is secreted, it is not effective. Then there is RBC abnormality, where there is reduced survival of RBCs. This is also one of the cofactor in diabetic patient. We had our own study which was done in 2016-19. We have selected 100 patients who are diabetic and non-diabetic CKD patients, and we have found that anemia prevalence was more in diabetic CKD as compared to non-diabetic CKD patients. And in stage 4 it was 36% versus 23%. This was statistically significant, 42% versus 67% in stage 5 diabetic CKD. So what is the rationale for anemia correction? We have seen that this is one of the predisposing factor. What are the benefits of if we correct the anemia? There is improved oxygen delivery, improved exercise tolerance, improved quality of life. There is attenuation of remodeling, which is one of the pathophysiology of heart failure. It is anemia correction anti-apoplectic. So reduction will with the death of cardiac myocytes and reduce hospitalization because of heart failure. But what are the risks? There is increased chances of thrombosis if we are doing overzealous collection. There is platelet activation. There may be hypertension, especially if we are giving erythropoietin, and endothelial activation. So how do we do diagnosis? We all know that hemoglobin correction, but we have to see RBC indices, whether it is microcytic, hypochromic, hyperchromic. Accordingly, we'll know roughly what type of anemia, and we all know that anemia of chronic disease is normocytic, normochromic. Then serum iron level, transferrin saturation, then serum ferritin level, which will indicate whether there is any inflammation or not, and folate B12 level also to find out whether it is nutritional deficiency. But one of the most important investigation which we usually don't do is bone marrow iron. That will tell us the patient's iron status as well as the need of iron therapy. So we have 3 treatment options here for treatment of anemia of heart failure. One is iron therapy, another is erythropoietin, and the third is blood transfusion. As far as iron deficiency is concerned, there is one article presented in a journal recently, 2019. Iron deficiency anemia has prevalence of 50% of heart failure. It is independent risk factor for functional capacity and survival of the patient. Risk factor for anemia, which was found in this meta-analysis: female sex, advanced heart failure, increased pro-BNP, and definition of anemia in heart failure. Here the transferrin saturation is very important, which is less than 20%, or ferritin saturation between 100 to 200. This indicates iron deficiency anemia. If the ferritin saturation is more, that indicates it is increased inflammation, so anemia of chronic disease will be there. And IV iron therapy is preferred route for administration, as many trials have proven that IV iron therapy improves heart failure with preserved ejection fraction. And oral iron therapy has limited role because I said there is decreased absorption, or there are many things, and it will take more time to improve the anemia. So in these patients, we have functional iron deficiency where the iron absorption is reduced because of epsidine or because of gut wall edema, which is when the patient has heart failure. So functional pool is reduced, and this is further reduced with absorption is further reduced with cytokines. So here the IV iron therapy will be useful. This is one trial which was presented in 2021, just 2-3 years back. The analysis is done, which have showed affirming heart failure. Iron deficiency is common, negatively impact functional capacity of the patient. IV iron deficiency, treatment of iron deficiency in acute heart failure using FCM, ferric carboxymaltose, reduces future hospitalization by 25%. This is a big thing because we will be spending small amount of giving IV iron therapy, but 25% reduction in hospitalization will decrease our cost of further treatment, and it does not reduce 1-year mortality in acute heart failure with iron deficiency. This is one catch there. This is again 9 RCTs which have proven it favors FCM, IV FCM. So it will reduce hospitalization by CV death in 60%, 25% hospitalization because of heart failure, no significant difference in cardiac mortality or GI event or infection, but it was consistent in all the trials. It is favoring the same thing. So this is the formula for the freshers, that this is the way we'll give IV iron therapy. This is the formula by which we'll calculate how much IV iron is to be given for the patient. And next is erythropoietin therapy. It was found in, one study was published in 2005. They said that it will decrease experimental infarct size, it will reduce hypoxic injury, it will prevent myocyte apoptosis, mobilize endothelial progenitor cell to improve the lining, it will improve endothelial dysfunction, it will increase neovascularization of heart muscle, so circulation will improve, it will reduce oxidative states, inflammation, so it is all goody-goody. So we thought it is a panacea for the patients who are having anemia and heart failure. So this was analyzed by various studies. There were 8 meta-analysis was done for 8 studies. They have found that erythropoietin is beneficial, and larger studies were needed. So large study was done, which was a RED-FF study, which was published in NEJM 2017. But what they have found with 2,000 odd patients, it was used for mild to moderate anemia. It was monitoring deaths and hospitalization heart failure patient. They have found no benefits. And risk was more. Risk was, stroke was increased, risk was fatal, non-fatal stroke increased. So they have to prematurely discontinue this study. Erythropoietin use in heart failure. So what was wrong? What went wrong in that? We have found that it was beneficial. The wrong was the patient selected were non-CKD patient. The target hemoglobin was more than 12 gram. They have targeted 13 grams, 13.5 gram, and according to KDICO guideline, this is kidneys guideline, it says that for pre-dialysis patient, for patients who are CKD, the erythropoietin should be used when the target hemoglobin should be kept around 10 to 11.5. Maximum up to 12 in males, 10 to 11 in females in stage 5 CKD patients on dialysis. And we are using non-dialytic patient, non-CKD patient, keeping the target of 13. So that's why the risk of thrombosis, stroke was more. So we have to keep reserve erythropoietin for the patients who are having DKD only, not for all the patients. So it should be reserved for anemia of CKD, target hemoglobin 11, long-acting ASA will improve the things. Blood transfusion should be kept reserved only for the patients where severe anemia, hemoglobin less than 5, when there is ongoing blood loss, or the patients are planned for urgent intervention, or there is ongoing ischemia. So in nutshell, what we should do for prevention of anemia in cardiac patient: proper nutrition, keep watch on hemoglobin on every 3rd month, prompt treatment of anemia, find out whether there is any GI loss by doing stool occult blood, ask patient to keep watch on stool, color of stool, look for other causes of anemia and treat accordingly. So this is one thing which recently have come, last month it is published in the journal, that we can give away aspirin in patients who has undergone coronary angioplasty. We can use only clopidogrel, thereby we can prevent GI loss and we can stop the anemia. That's all. Thank you very much.
Ladies and gentlemen, I told you in the beginning that little nuggets of wisdom that will be shared by our expert speakers during these sessions will go a long way in improving the patient care. So I thank Dr. Savita Gangude for bringing a very common topic of anemia and its role in heart and how to prevent anemia.
Thank you.
Any question? The house is open.
Yes, true. And fortunately now in urban area it is less. But for any anemic patient, I think we should give one course of antihelminthic. Thank you.
Madam, I have some 2 or 3
Yes.
questions. Please,
Welcome,
please bear
sir.
with me. First one is, madam, this hemoglobin is said for male 12 gram and female 11 gram. Yesterday was, madam, International
This-
Women's Day. Madam, please wait.
Sir,
This is a very,
Sir, this is
cannot be taken.
scientifically, we have less circulating volume.
No, madam.
And it is internationally said. I cannot come.
That is also
comment on.
incorrect. That is also incorrect. The original idea was because of this menstruation, they lost blood, and that was the reason. But that we have some period. After once menopause is achieved, hemoglobin level should be same.
Sir, guidelines
Please.
are not saying so.
No, this is not a guideline. We have never objected to that guideline. No one has actually seen that. So this is one point. And second is this serum ferritin value I said. 0 to 20 is the normal. More than 20 you may not give. But in CKD patient, the limit is bit higher. You can
It
go
is
up to
more.
150.
More than that, sir. We have seen more than
yes.
500.
That point should have been highlighted. That is my
Sir,
point.
100 to 200, up to 100 to 200 means you can give safely iron.
Right.
That is cut off given by various guidelines for the anemia in heart failure patient.
Right.
In CKD patient, it is always inflammation, so ferritin is high. So we give erythropoietin. Unless we have the other parameters
But
saying that iron deficiency.
the nephrologist says initially you have to correct iron deficiency or ferritin deficiency. After that, give erythropoietin. That is my take. I do not
Sir,
know.
ferritin is not taken. It is iron deficiency, T saturation, T-sat and serum iron.
Okay. About erythropoietin, this has become a very big issue with divisional hospitals because the nephrologist will have a specific brand of erythropoietin. Is there any difference between the different
Sir,
brands?
there are only 3 types of erythropoietin. One is short acting, which come erythropoietin by this name. You can use any company's brand.
Right.
Another is darbepoietin, which has longer half-life, which can be used weekly or fortnightly. Third is pegylated erythropoietin or sera, which can be used fortnightly or monthly. There is no significant difference in brand, but one thing we have to find out, we have to keep in mind that we have to maintain cold chain to have the efficacy of erythropoietin.
Thank you.
Thank you, ma'am. I request.
Anyway, give her a big round of applause.
Yeah, I request to give a token of appreciation to ma'am. Our next speaker is Dr. Shishir Kumar Raul, cardiologist, Jagjivan Ram Hospital.
Dr. Shishir Rawal does not require any kind of introduction. He is well known. I know Dr. Shishir personally. He is from Baroda division. Hi, Dr. Shishir. So he was in health unit Godra. After that, he was shifted to health unit Anand. After that, he had gone to Central Railway Hospital to complete his DNB medicine. And after that, he completed his DNB cardiology and got posted in Jagjivan Ram Hospital. See, he is our product.
Thank you, sir.
His qualifications are MBBS, DNB medicine, DNB cardiology. Currently working as HOD cardiology and director cath lab of Jagjivan Ram Hospital. Performed more than 3,000 complex angioplasties, hundreds of pacemaker implantations, peripheral vascular and varicose veins interventions. Teacher and guide for DNB cardiology, live case operator in national and international forums, multiple national and international publications, awarded with CMD Western Railway Award, GM Award, as well as Railway Board Award. I welcome Dr. Shishi to give his deliberation.
Thank you, ma'am. Good morning, one and all. I will start with acute coronary syndrome and ends with asystole. What next? What the guidelines tells. So everybody is not lucky having a coronary like this. Your beautiful coronary. Sometimes God is not good, kind enough. So you may present with acute coronary syndrome, which composes three components. One is unstable angina, one is NSTEMI, that is non-end elevation MI, one is elevation MI. So I'll take you starting from presentation and end with prevention. So I'll deal with my invasive way, non-invasive way, then how prevention. So coming to the basic angina is nothing, it is restorational discomfort, which is precipitated by the exercise, cold weather or emotional liability, and relieved by the sublingual nitrate. Usually it lasts 2 to 10 minutes. So we have a very old but genuinely a good guideline and criteria. So we have, when you have a 3 out of 3, that is discomfort, any precipitating factor, relieving factor. If you have 3 out of 3, then we are having a classical angina. If you are having 2 out of 3, we are having a atypical angina. If either 0 or 1, then we are done non-cardiac chest pain. So going on unstable angina, the other worst form of the angina, it may be precipitated, it may have a prolonged chest pain, new onset chest pain, or sometimes it can have a longer duration or never bloom. The worst form of what we don't want, anybody want any myocardial infarction, MI, which is the damage of myocardium, and the pain may last more than 30 minutes. So what happened? The chest pain around me, it is found that around just 10% of the person visiting to the casualty, they do have chest pain. Among them, 15% having acute coronary syndrome, and 2% of that we can miss by our negligence here. So this is the dream of everybody who need to have a coronary artery, 3-layer, beautiful, that is externa, media, and intima. But sometimes you can start with a simple injury in the form of stress, you can have a tear. So going to stress, you are going to gym, so little of the stress can, high surge stress can lead to MI. Further, it can go, you can have a other form, the atherosclerosis. Finally, starting from normal coronary, you can have a big thrombosis, you can have rupture, you can have further erosion, or you can have the dreaded complication in the form of MI or heart attack. So what happens? This is heart attack. You can think there is a rupture, erosion. You can have any blood coming from anybody or anywhere in your body can lead to dying muscle. So the pathologists tell we don't have time, years and years, what we take. No, only 6 to 7 hours is sufficient enough to give a transmural myocardial infarction. Starts from some endocardium, goes, and you can have throw. So when they found what is exactly the main 3 mechanisms we are dealing with, you can have a plaque erosion only, you can have plaque rupture, or you can have a calcium nodule, which is very rare form, 5%. So 3 form we can. So how does it look when your plaque ruptures? The rupture plaque is a plaque, gut rupture, the platelet comes here. So your RBC comes in, get a red thrombus, and you can have a large lipid core. So the more lipid, it's going to get a rupture. And when you have a many macro-inflammatory marker or fibrin-rich thrombus, so in the other form, when we eroded plaque, you have erosion, you will have white thrombus, when your platelet will be there, and you will have a white thrombus, and you can give MI also. So how you think, do we need everybody to have this amount of blockage to get MI? No. Answer is simple, no. So you have a stable plaque in the left side of my slide and a vulnerable plaque. I'm least worried of this. I'm worried of this vulnerable plaque. So any small plaque can rupture you. Anybody going to the gym with a healthy heart can lead to MI. How? If you have a thin fibrous cap, thin less than 65 millimicron, thin fibrous cap, big necrotic core, big lipid, intraplaque hemorrhage, or any inflammation, that is a danger sign. Any time and any moment it can rupture, it can lead to MI. But however, in the other side, we have a thick fibrous cap, less lipid, less inflammatory, is a good is a stable plaque. So how does it look in the OCT or imaging? So we have come with a beautiful diagram. You can see this is the thin fibrous cap, only less than 65 millimicron, has a large lipid core, and microbe has infiltration, so can lead to MI. So this is not the coronary is only responsible for MI. You can have a coronary embolism, thrombus, what I told, rupture, urogen, whatever. But sometimes myocardium muscle can, in the form of cardiomyopathy, myocarditis, stress-induced cardiomyopathy. So anything you can have, that is also. And more unlikely, you can have non-cardiac causes of MI. So any sepsis, any stroke, inflammation, pulmonary embolism. So you have a large enemy around our heart. So what happened? Now I got a chest pain. What I need to do in my initial assessment, only 10 minutes I do have to get ECG, and 10 minutes you need to have your blood sample in. So nothing, don't take a, so what my area of interest, I'm worried about to diagnose ST elevation MI and non-ST elevation MI, and which is very high risk because they can anytime can take you away from us. So going ahead, so I have only the triage. I have to diagnose persistent ST elevation. ST elevation for 1 minute, not ST elevation MI. It has to be more than 20 minutes. ST elevation and more than, and if non-persistent, this is non-ST elevation MI. But ongoing chest pain, acute chest pain with ST elevation, STEMI. So this is, I don't want to, there is a guideline. When you tell ST elevation, only one lead? No. There is a guideline how to know V2, V3 separate guideline, and more than other leads, you have other guidelines. And if non-ST elevation MI, you have a T inversion. That is also significantly 0.1, whatever. So in one slide, I am showing to both ST elevation and non-ST elevation. You see the ST elevation is the baseline ECG, starts here, so much so. ST elevation is anterior MI. At the same time, there is ST depression, anti-inversion. So this is the variation form for everybody. You see the ST elevation, ST elevation. So for the moment you see the ECG like this is alarm clock with you. So what in ST elevation MI, how does the ECG behave like? Don't expect everything will have ST elevation. Sometimes you can come with only Q wave. You can have a T inversion. So starts with ST elevation and hyperacute, ST elevation, T inversion, then Q. So on the triage basis ECG, now they have come with a new guideline. The ST elevation, now if you are having a new LVB, ongoing chest pain, new LVB or new RBB, that included this time, this new, you have to treat the ST elevation MI. At the same time, when you are taking the history, this is a gray score, what usually help, whether how you are going to deal the patient, how much risk you are having in hospital death or post-hospital this 6 months. So more the score, this is age, heart rate, ST elevation, cardiac muscle, then this is the class, so all include. So the more the score, more chance you are getting to have a MI, death in hospital or 6 months. So ECG, only 10 minutes. So you can have a repeat ECG if you are having doubt. At the same time, blood sample, or that too within 10 minutes. And within 60 minutes, the sample should be available. And you can, that helps into ruling in or ruling out of MI or any ST elevation. And sometimes it helps in the gray score also. And the most importantly, this is the message I need to give audience. The ambulance has to have well equipped with ECG to diagnose acute coronary syndrome, having a defibrillator and fibrinolysin. So our ambulance, I don't know, we don't have that. And so every ambulance should have a well-equipped machine of defibrillator and MI like that, because time is the muscle. And more importantly, transthoracic echo, not always necessary, but when you are suspecting patient is having cardiogenic shock or mechanical complication in the form of MR or VSR, the emergency TE has to done. However, by doing so, you should not waste your time in diagnosis. So what happened then? My patient comes to my casualty. I got a ECG, ST elevation. Am I what? Oxygen? No, no, and no. It's class 3. If your SpO2 is more than 90, rather if vasoconstriction may lead to, don't give. So if more than, less than 90, then you can class 1 indication. What about your intravenous OPD? You can have to, if patient is anxiety, or your IV blocker, if there is IV beta blocker, when your systolic blood pressure is more than 190, and there is no sign of heart failure, acute heart failure. Again, my patient having chest pain, come to me, that is fast medical contact. You see, this is the ischemia time. That means to patient with ST elevation MI, landed to a hospital like JRH, where primary PCI facility is available, I have to open my artery within 60 minutes. we have achieved more than the, only 20 minutes we have also open artery. But when if landed to a hospital where primary PCI facility is not available, put a question. Can you shift the patient? Can you give justice to the patient by opening that within 120 minutes? Whether you are a referral hospital where primary PCI facility 120, yes, then don't thrombolize. Don't thrombolize the patient. Shift the patient to the nearby primary hospital center where primary. If within 2 hours you cannot give the revascularization, then thrombolize, and the time to you with thrombolize only 10 minutes. And more importantly, this is what the ischemia time, this is what the patient delay reaching to you, and this is what we delay. So we should think, we should decrease this. This is our patient call, this is our delay, that is known as system delay. So we should have that amount of system, we should give respect to our myocardium. And more importantly, after the thrombolysis, you do not allow the patient to be here. Has to be referred immediately. Remember, transfer the patient to PCI facility immediately. Again, and the same time, I will go ahead how to deal. So now, what is the successful thrombolysis? When we think there is a successful thrombolysis, patient chest pain free, no arrhythmia, no chest pain, and ECG has settled more than 50% of the ST, and unsuccessful in otherwise patient having a chest pain, electrical instability, worsening the heart failure, and so on. So reperfusion, again, no indication of thrombolysis more than 12 hours. Repeat, no indication of thrombolysis more than 12 hours if you are documented, and no routine primary PCI more than 48 hours. So after 2 days, nothing, because all the myocardium is irreversibly damaged, or no thrombolysis more than 2 hours. Then what the thrombolytic agent we have with us? No doubt, tenecteplase. This is the old story. Don't think, if you are giving these streptokinase, altiplase, reteplase, injustice, we cannot think of giving. This is well proved, because 90% patient occurs, more than 75%, we can have 90% patency of the myocardium, and grade 3 TIMI flow we can have 63. And these are so I don't want to read unnecessarily, I don't want to waste my time. So this is one, you see, this is totally completely occluded artery. This is only 34-year male. This is 2 artery get completed, and we do one angioplasty. You can see there are some perforation. You can see this artery. So how badly, how you can think how worrisome can be in primary PCI. You can see one more angioplasty. You can see this near total occlusion. When angio, they can again you perforate. So sometimes when you get calcium nodule or plaque of that is vulnerable, sometimes it can rupture, but we do the justice. Now we have well equipped to deal with all type of complications which have the patient. Now what about STEMI? On STEMI also you have to treat like STEMI. If they come with hemodynamic instability, cardiogenic shock, recurrent chest pain, arrhythmia, mechanical complication in the form of VSR, MR, ongoing and dynamic ECG changes. So you have to treat as a PAMI, you have to take the patient immediately to the cath lab, and in other way, we can deal the other patient in the 24 hour having the lesser form of the disease. Then what thrombotic agent we are having with you? What the antiplatelet? This is cornerstone. This is the enemy around who. So we have aspirin, we have P2Y12 inhibitor, we have anticoagulant, neuroanticoagulant, we have that is GP2-3B inhibitor also. So aspirin. Load with, we have to load with 150 to 300 milligram aspirin, then 75%, 75 to 100 milligram as a maintenance dose. Then other P2Y12, ticagrelor, prasugrel, and clopidogrel, and more importantly now, we are having the prasugrel should be considered over other 2 antiplatelet, that is ticagrelor and clopidogrel. However, if you are giving prasugrel, load with 60 mg, then 10 mg, you are giving ticagrelor, load with 90 mg, then 190 mg, then 90 mg BD, then no clopidogrel. Clopidogrel is given, no more is given now. So this is antiplatelet. Now this is the new thing has come up recently in this guideline only. If you are dealing ST elevation MI, load with both iscosprin and P12. So P2Y12, usually it was in class 1 indication. Before taking angioplasty, you have to load with ticagrelor prasugrel. Now they have come with 2B indication. And if you are NSTEMI, and if you are thinking now I have to do a emergency surgery, early invasive, don't give, because the moment you will give clopidogrel, ticagrelor, prasugrel, so you may delay. For example, you have some mechanical complication. I may need emergency CVG, so don't give it. So 2B now, if you are thinking ST elevation, NSTEMI who are not expecting to undergo early, we can give now. So anticoagulant, all patients should be anticoagulant in the form of heparin or clexine, all patients. So ST elevation MI, you have to give heparin, endoxaparin, bivalodin, and NSTEMI as I told. And the default strategy is you will have to give dual antiplatelet for 1 year, then subsequently only aspirin. Now the recent, only January, we get a paper on the January only. Now we are coming with aspirin-free antiplatelet. Do you think, can you stop aspirin? Yes, they are telling 1% is stable enough. Then you can only 1 month or 2 months, then stop aspirin, then only P2Y12 receptor. Now that thought prasugrel is better than ticagrelor. Now in the unstable presentation is to know, this is again one more guideline that has come. If somebody is out of hospital cardiac arrest and you found STEMI, now is the patient stable. Initially it was done, you have to take the angiography urgently. So their primary PCI. But if patient is having non-STEMI, and now patient stable, they are telling the routine angio is class 3. It was class 1. So patient cardiac arrest, now stable, and not ST elevation. You can think of you should not hurry to the primary PCI. Same thing I told. Then cardiogenic shock. This is an important slide. Patient present with cardiogenic shock, hypertension, multi-organ dysfunction, how to deal with immediately coronary angiography, and you have to deal with infected related artery. For example, usually cardiogenic shock may have multiple artery block. So you do not need to intervene all artery. You have to deal with infected related artery. Which artery is culprit now? That we will see in the ECG, echo. So you have to deal the infected related artery and early CVG if you have bypass, mechanical complication, or when you are not able to do angioplasty properly. So cardiogenic shock, infected related artery, then other artery has to deal before the discharge. STEMI, you have to deal either in the same setting or the 45 days. And non-STEMI, non-ST elevation means complete revascularization. No need, has to deal the all the artery to now. Now they are coming with what we think of ischemic versus bleeding risk. So whose patient is having more ischemia? So this is the total major criteria, minor criteria I am not going to have. So this is the ischemia. The more the patient CKD, patient having multiple vascular disease, multiple stent, at least 3 stent has put, a total length of the stent is 60. So these patient has to have more aggressive way of antiplatelet management, and you can think more than 1 year also. In the other way, if patient is having, you can think of extended. This is known as extended, more than 12 months you can have antiplatelet, dual antiplatelet. But if you are having more bleeding risks, then you have to cut out your, like you can have 1 month dual antiplatelet, subsequently only aspirin or clopidogrel, like that, okay? This is the score who will guide us how to. And if somebody having anticoagulant, then only 1 month, initially they are 1 year anticoagulant. So now telling, give anticoagulant, that is warfarin, then subsequently dual antiplatelet, and then remove one antiplatelet, that is then finally you will have to have after 1 year only oral anticoagulant. So this is, and now we have come with beautiful imaging, that is IVOS OCT, which guides us what type of lesion we are dealing with. So this is the SCC complication. In remind the friends, 33% of people what we are losing from MI is due to arrhythmia. So what happened? Now Dr. Saurabh will take you the arrhythmia part, so I'm not going to that. But only thing, the ICD is indicated, that is when you are having less than 35% of EF, and you have treated the patient 3 months or more than 3 months and still not achieve the bradycardia. So how to prevent? Yes, 80% of the prevent. 7S, remember before you leave this hall, smoking, salt, stress, sedation, saturated fat, sugar and sleep. I'm not going to, because there are all speakers will speak regarding this. They remember less than 55, is the LDL should be our target, and this is the exercise you do. You have to manage the stress, because the stress can lead, if the unmanaged stress can lead to emotional, psychological, physical, and that lead to heart disease, blood pressure, and MI. So this is a beautiful slide I love to have. Don't think my children are naughty. Think of the person who do not have such child who can play, or who even do not have child also. So you have to reduce the stress. Now this is the only one slide. So do you have any problem in your life? Yes, I have a problem. Can you do something about it? Yes. Then what do I do? If you are having some problem and you are having the capability to solve that, then solve. Then why you are worried? Yes, I do not have any solution for it. Then you have to accept. If something has occurred irreversibly, you have to accept. Then why you are worried? And if you do not have any problem, it's okay. So nothing is permanent in life. This is what एक बार अर्जुन ने कृष्ण को बोला, एक दीवार में कुछ लिखो, जो खुशी हूं तो पढ़ूं तो दुख होगा, और दुख में पढ़ूं तो खुशी होगा. So nothing is permanent life. The effect of anger, this is important. The effect of anger is more painful than the cause of anger. For what you are getting anger, you think uski effect is more danger than the cause of fear. Two meaning: forget everything, run, or face everything and rise. So use your heart to know your heart, because ever someone somewhere is waiting for you to return. Thank you.
Thank you, Dr. Shishir, for excellent deliberation.
Thank you.
The forum is open. Anyone can ask any question related to the topic.
Yes. Yeah. As I told, the stable plaque has a thin fibrous cap. You don't know that, that has to be done by imaging only. And large lipid core, that also you cannot. Only thing you can know, if your lipid profile is not good, you are having inflammatory marker in the form of CRP, ferritin, whatever, and more, and you are having tachycardia, some sign of inflammation going on, and you are having chest discomfort on moving or taking stairs. So it's some sign, and more importantly, you do not need always the invasive way to do it. You can have non-invasive, either form of ECG, stress echo, your TMT. That will also help you sometimes how every person does not do coronary angiography to know, because this is the imaging. They have found that, for example, somebody comes with ST elevation MI, I see a plaque which is not that amount is blocking my coronary artery. And then I thought, why get ST elevation MI? So that is known as vulnerable plaque. So we do the imaging, then if see if the vulnerable plaque, then even if that is not 70% blocking, then we also stented that, because thinking that this can lead to any MI or ACS at any more time. So your physical activity, your no chest pain, you having chest discomfort, ECG, echo, treadmill will give some guidance. Thank you.
I have 2 or 3 questions.
Sir.
First of all is that PCI, what you are recommending. So for my knowledge is concerned, PCI does not reduce mortality. That is my take. Second is, even doing fibrinolysis also, I do not know whether this does have any effect.
Yeah. So
और एक साथ बोल देते सब question, बाद में आप answer करते रहिएगा. Anything white is bad. Anything white. You mentioned salt, sugar, or I think there was another white.
7S.
So anything white is bad. The reason being, white is reflecting the energy from your body, but black is also not good. Colorful clothes are good. That is my take. This is recommended in, you can find it in YouTube also. This is recommended. Only colorful clothes are black and white are not recommended. White is because the sun energy is being reflected, but you are not getting energy. And one of the source of energy, we think this food is the source of energy. Please, sun rays are the most useful source of energy. Second is space, air. Third is water. And last is food. And food is also for nutrition purpose, not for taste. This is my take. You can object. And another thing, life saving. Any person having chest pain, he may not get any help. So if I give a packet of aspirin, clopidogrel, and atorvastatin, and tell that person, if you have this type of problem, you just take it. You need not have to take help from others because the helps are not available. People pass away and then they will not notice you. So that way we can help some people. So that is my take. You can.
One thing, sir. First question is whether the PCI is having advantages over mortality. So two things. When you are dealing, what type of disease you are dealing, whether you are dealing a chronic stable angina or acute coronary. So they proved that chronic stable angina on optimal medical therapy is equivalent with angioplasty. I'm not dealing that. If you are having chronic stable angina on optimal medical therapy, there is no deterioration of the symptom, you are having well your daily activity, you are having antiplatelet, whatever guidelines tell, don't do angioplasty. So I'm okay. And sometimes we advise also the stress test to the fatal ends. Second question is, what do you tell, sir? Anything. So what I mentioned, this sugar, I'm not telling you don't take any sugar. Excess of anything. I'm not taking the salt. Salt, not excess salt. You have to have 3 grams of salt you can have. So no added salt. No added. And more importantly, if you are not hypertensive diabetic, you can. Taking sugar does not lead to diabetic. Diabetic is a person advised not to take sugar. If I'm taking 1 kilo sugar daily, I'm not going to have diabetic. My pancreas is good enough to do the insulin. But if you're even diabetic, already you are diseased, then we advise restricted sugar, number 2. Number 3, sorry, intervention,
So sugar was not originally from India, that is one. And second is, please recommend the salt that person can take. Most probably sodium chloride is not
if you are not taking salt, then your running aldosterone system will further activated. That again lead to your hypertension and again vasoconstriction. So you have to have a normal salt with your diet. No added salt. Repeat. No. Yeah. No.
There is a common perception in the public. This white salt is not good. Even iodized salt is not good. But they can take black salt and sendha namak. Please clarify that also.
What?
Yes, people do take.
No, sir, any salt, I am telling you, don't take extra added salt, that much. And third one, sir, as you told, whether somebody has a pills in the pocket in the form of ecospin, clopidogrel, and it's absolutely wrong. So, not all chest pain are MI. It has to be done. So, there's some contraindication of aspirin also, outidixation, you can lead to death. Peptic perforation can lead to death. So, any chest pain not MI. However, not all chest pain is not of MMI. That means it has to be, so any patient of the unstable, already PTC is done, high risk patient, you can think of putting aspirin. However, aspirin is also some contraindication also. That's it.
Please do popularize CPR.
You want?
CPR. No, CPR. Everyone should.
Yeah, everyone should not take. The CPR is the only thing in the world. If you share knowledge to everybody or other person, they will help you. The moment you will having MI, you cannot do your CPR. So by sharing the knowledge, if I am sharing my angioplasty knowledge, yeah, he may take my one patient. But if I am sharing my CPR knowledge, then you are more like, I have taught CPR to my kid, my daughter, my son, and sometimes they do practice when I am sleeping also. Thank you. Absolutely wrong. Absolutely wrong. So message clear cut. 150 increases bleeding risk without any antithrombotic efficacy advantages. 75. Only 75. In JRH, he sees there will never purchase 150. Never. Never.
Sir, yes, this last question.
Thank you, sir.
And another question is that this CTOL continues. One aspirin and clopidogrel continues for 4 years, 5 years together.
No.
What he says, aspirin can be stopped after 1 year.
Yeah, we can stop. If
Can
patient
be
is,
stopped. But
if patient is,
it continues.
no, that's not clear. If patient is not having a high risk event, patient having all the artery has been taken care, no symptom, TMT is okay, ECG is okay, after 1 year, 2 years, we can stop.
So, ladies and
Actually,
gentlemen,
Shishir, I
please
just
give a
wanted to clarify the point.
big
because
round of
81 milligram of aspirin was all the studies done in the world. That is why people actually, there is, in India, the aspirin available is 75 and 100. That is why most of the people prefer to use 150. But as Shishir told, all the studies and all the documents now telling 75 is more than sufficient for the people who have.
Sir, he is Dr. Pratap Kumar, he is going to have oration. Thank you, sir, welcome.
Dr. Shishir deserves a big round of applause for generating so much interest. And two things before I close. First thing, I would like to sincerely thank DG ma'am, all PCMDs, all CMCs, and all delegates present here. And secondly, myself and Dr. Mani Ratnam thank the organizing committee of JRH for selecting us as chairman for the first session. Thank you very much.
Thank you, sir. Kindly hand over a token of appreciation to Dr. Shishir. I request Dr. Atul Sharma sir to hand over a token of appreciation to both of our chairpersons. Thank you. Now we are moving forward with the session 2.
Very good morning to the DGRHS madam, PCMD madam, MD madam, and all other dignitaries. I, Dr. Preeti Gupta, feel privileged to welcome all of you on behalf of the scientific committee of the conference. We feel immensely honored to have with us our honorable chief guest, Director General Railway Health Services, Dr. Sugandha Raha madam. Thank you so much, ma'am, for being here today. Now we shall have our traditional auspicious lamp lighting ceremony as a tribute to Goddess Saraswati, the goddess of knowledge. I request our esteemed chief guest, DGRHS madam, PCMD madam, MD madam, and all other dignitaries to light the lamp and symbolically inaugurate the conference. I welcome all of you on the dais.
Thank you, ma'am. On behalf of Scientific Committee, I, Dr. Anuja Kulkarni, now welcome you all with second session. For second session, it's our pleasure to invite Dr. Ashish Mukherjee, PCMD, East Coast Railway, Bhubaneswar, and Dr. Krishna Kumar Sir, Chief Health Director, Western Railway, to please come on dais as chairperson to chair the next scientific session. Thank you, sir.
Good morning, everybody. We have the speaker, Dr. Nagesh, who is a consultant intervention cardiologist, and he is
I think Dr. Ashish Mukherjee is not there just now. So I call Dr. Man Singh, PCMD, NWR Railway, to chair this session. Thank you, sir.
Thank you, sir. I would now invite Dr. Nagesh Wagmare as a first speaker for second scientific session. He will be talking to us on cardiac illness in pregnancy. I request our chairperson to please introduce briefly about Dr. Nagesh Wagmare. Thank you.
Good morning, all. Dr. Nagesh Wagmare, he is a consultant interventional cardiologist. He is MBBS from Grant Medical College, Mumbai, MD KEM Hospital, DM PGMER Kolkata, and has got 11 years of experience. He is ex-professor of cardiology, Grant Medical College and Sir JJ Hospital, Mumbai, and attached to Bombay Hospital, Jaslok Hospital and Breach Candy Hospital. He is expert in complex PCI, imaging and rotablation, BMV. He has a special interest in structural interventions with experience of procedures like TAVI, left atrial appendages, closure with devices, and he has received many national and international publications. He is a national faculty for conferences like India Live, IJCTO. Welcome, Dr. Nagesh.
Thank you. Thank you so much, sir, for the lucid introduction. So, when we talk about heart diseases, this one subgroup is very special to us because there are two lives at the center of the interest, and two lives matter a lot with one issue. So during this presentation, I would like to talk about the physiologic changes that they are happening during the pregnancy and its implications for a normal as well as person with heart disease. What we need to prevent when a lady is pregnant and we find that she has a heart disease. This prevention is something different. We are not talking about primordial prevention. Here we are talking about preventing a morbidity, preventing a mortality related to a natural process. So we have to understand this difference. And once we understand what is at stake, we should know how to achieve that goal. And what are the interventions? I am going to talk very briefly about interventions because more important is risk stratification. So these are the cardiovascular changes happening during pregnancy as a normal physiological event. And they start as early as 12 weeks of pregnancy. So at the end of first trimester, the changes are there in place. Blood volume is increased by 30%, so it is an extra afterload as well as preload for the heart. Plasma volume, in that blood volume is 45%, which is on an increasing side. Cardiac output has to be increased by 30 to 50% because heart has to support two lives, the mother and the fetus. Stroke volume is increased by 25%. Heart rate increases in later stages of pregnancy, after end of the second and third trimester. It is by 15 to 25%. The PVR goes down, so diastolic BP starts remaining on lower side, and the CVP remains unchanged. So these are the physiological changes. So how they affect the heart when a person is having borderline diseases? You look at these issues. Dilated cardiomyopathy, the contractility is less. How can it is going to increase the stroke volume when the contractility is less? So already the preload is increased. Pulmonary pressure is on higher side. HCM, it cannot relax. The end diastolic pressures are high, so it cannot take the increased preload. Restrictive similarly. So there is a tachycardia also. So these are all the changes are going to affect adversely, and the magnitude of affection is more than a normal person, normal lady, as compared to these ladies with the issues. So this is about the physiological changes during pregnancy. So what we are looking at when a lady is pregnant and has a heart disease? As I just discussed, the cardiovascular system undergoes significant changes. It is to adapt and to accommodate the increased metabolic demands of the mother as well as the fetus. These adaptations are an important hemodynamic burden on patients with underlying heart diseases, and they confer an increase in morbidity as well as mortality for the mother, and in some scenarios for the child also. So it may cause specific cardiovascular disorders which impose a risk to pregnant woman and to her fetus. We'll discuss what these specific disorders are. And it is estimated that in the Western world, up to 4% of all pregnancies are complicated by cardiovascular diseases. This risk is in ascending order of age of first pregnancy. Unfortunately, we are witnessing a demographic shift of delayed pregnancies. People are getting married, they are career oriented, they want to finish their studies, want to secure a job. By that time they are 27, 28 years of age. They marry by the age 30, and they are looking at first pregnancy after 30 years of age, which itself is a risk factor as compared to a younger lady. So this one age, as it goes on increasing, the risk of having heart disease or having complication because of heart disease increases. And as the risk factors increase, so in our society, another bad trend that we know because of sedentary lifestyle, junk foods, lot of other things, increasing smoking, there are the additional risk factors to have sufferings during pregnancy. So the most frequent cardiovascular event relate to hypertension. So PIH, one thing which is the most common, but there are other cardiac issues. So in Western world, the data says most common cardiac disease other than hypertension is the congenital heart disease. So at early stage, the children get treated in those countries, and they come with adult grown-up congenital heart diseases. But in our country, even today, after hypertension, rheumatic heart disease, mitral stenosis, aortic stenosis, mitral regurgitation are the common disorders we see in young ladies with pregnancy, and congenital heart disease percentage is on the lower side. It is there. So in pregnant woman with heart disease, maternal death is estimated to be around 1%, but it again depends on the underlying CVD. Unfortunately, in our countries, the rheumatic heart disease affects lower middle class or lower socioeconomic strata. And believe me, we are diagnosing mitral stenosis, which is at severe level, first time during the pregnancy because the lady develops symptoms. So this aspect is also lacking. There is no awareness, there is no early detection so that we can prevent a complication during pregnancy. So we have to deal with what we are seeing. We have to still take efforts to make the outcomes better. The neonatal complications occur in 20 to 20, almost 1/3. The mortality is in the range of 1 to 4%, and again depends on what we are looking at, whether it is cyanotic or acyanotic heart disease. And in pregnancy, it is a hypercoagulable state, and there is a mechanical obstruction to the venous return. So we are seeing venous thrombosis also during the pregnancy. And there is a lot to prevent. If we look at this data, almost the cardiac events are 15.8% in one of the studies. This is a Western data. Believe me, our data is worse than what we are looking at this chart. maternal death is to the tune of around 4%, then cardiac arrest is 0.4%, and there are so many things. So we are looking at nasty complications if we don't start counseling the patient, start monitoring the patient, and take proper steps to prevent these things. So another issue, suppose a lady with heart disease gets pregnant, gets delivered, the thing is managed properly, what happens next? So if you look at the 20 years data, the ladies with heart disease persist to have new cardiac issues. They are more at risk of hypertension and diabetes as compared to those pregnant ladies who never had any heart disease during the pregnancy. And on follow-up, the hazard ratio though goes down, the incidence of heart disease is more frequent in ladies with heart disease during pregnancy. This is all applicable to heart disease group. If we look at all the other parameters of new hypertension, therapeutic procedures, and heart diseases. So this is what we see when a lady is pregnant and there is a heart disease. So how to prevent a morbidity and mortality? So we need to understand and have the knowledge of common cardiac disorders. As I told, rheumatic heart disease is one entity which we are still seeing in our country. Another entity is the congenital heart diseases. Other common conditions are arrhythmias and cardiomyopathies. Postpartum or peripartum cardiomyopathy is a real disease, and we need to tackle smartly so that we prevent deaths related to the PPM heart failure. We need to understand the natural course of the disorder so that we can triage the patient and act in time to salvage the condition with minimum of the resources. We have to stratify the risk of a lady and triage based on that, and at appropriate stage the interventions. So if we look at the data, so there is a risk stratification method. One of the latest and most advanced is the CARPREC-2 risk score, and as per this, cardiomyopathies are falling into the high risk group, then arrhythmias and the ischemic heart diseases. So this is how the distribution of disorders is. If we look at, compare the arrhythmia and congestive heart failure, during first trimester, it is the arrhythmia which is the more worrisome reason. But as the pregnancy progresses, heart failure becomes common. The hemodynamic changes become more prominent during later stages of the pregnancy, after delivery, immediately, and within few weeks of delivery. So this is where the peripartum cardiomyopathy hits. This is again the incidence of the maternal cardiac events based on the CARPREC risk scoring segregated as per the WHO classes. So we'll go through what these stratification methods are. Again, I want to compare. Fortunately, the incidence is decreasing over a period of time. If we compare the two groups, one is of ladies delivered between 94 to 2000, another is 2001 to 14. This is the 94 to 2000 group. Any cardiac event is on lower side, arrhythmias slightly gone up, pulmonary edema is reduced, as well as the maternal cardiac death. So science is improving as the delivery of the care is improving, and we are seeing a heartening trend towards reduced morbidities as well as mortalities. So how we stratify the risk in a lady who has heart disease and pregnant? So as I told you, one of the latest and most advanced is the CARPREC-2. Then Zahara score is there, especially if the lady has congenital heart disease, and the modified WHO score. So this is the CARPREC-2, which uses various parameters to predict the risk. Look at the history, whether there is a prior cardiac event or arrhythmia, 3 points. Baseline class of the symptoms, NYHA 3 and 4, or cyanosis falls in category with 0.3. Mechanical wall, having a mechanical wall itself is a high risk thing because anticoagulation is very difficult to manage, and it has 0.3. Then ejection fraction, any below 55%, score of 2. High risk wall disease or LV outflow obstruction with area below 1.5, 0.2. Pulmonary hypertension is 2. This is one entity where pregnancy is prohibited. Severe PH, no pregnancy. High risk aortopathy, coronary artery disease, no prior cardiac intervention, and late pregnancy assessment. So almost all of our patients will be having this point because we are usually diagnosing. And based on the score, the risk is, if score is 1, the risk is 5% of having a complication. Risk 2, 10%, 3, 15%, 4, 22, and more than 4 is upwards of 40%. This is Zahara score. Again, it is very objective way of assessing the risk. This is important. WHO risk class. One is we can manage as a routine pregnancy where the diseases are simple, uncomplicated, small or mild PS, PDA, MVP, and successfully repaired ASDs, PDS, VSDs. Then class 2 risk is here is patient is well, uncomplicated, small increased risk of maternal mortality or moderate increase in the morbidity, unoperated ASDs and VSDs, repaired TOF and most arrhythmias fall in class 2. Class 3 is depending on the individual disease and LV dysfunction, cardiomyopathies, valvular issues, native or tissue wall, Marfan syndrome, aorta with dilatation but less than 45 millimeter and repaired coarctation fall in this class 2 or 3 watershed zone. Then class 3 is mechanical wall, systemic right ventricle. So these are the complex heart diseases. Majority are congenital. And class 4 we have to by heart. Pulmonary hypertension, severe LV dysfunction with ejection fraction below 30%. Previous PPM, that is peripartum cardiomyopathy with residual impairment of the LV function, severe symptomatic or mitral or aortic stenosis. So these are the obstructive lesions. That patients don't tolerate obstructive lesions because there is increased volume of the blood as well as plasma as well as increased heart rate. What we need in obstructive lesions is the slow heart rate and less volume of the blood, but it is exactly opposite which is happening in the pregnancy. Marfan syndrome with dilated aorta, aortic dilatation of more than 5 centimeter and native severe coarctation. These are the strict no for having pregnancy. So either we have to correct them or we have to tell the patient not to get pregnant, find other way like surrogacy. And this is the risk of mortality or morbidity as per the WHO classification. It starts with 0 to 10%, but it is upward of 40% for class 4. And severe PH is something which is irreversible. We cannot take the chance of having the lady pregnancy to be continued till the end. And this is how the odds ratio in study cohort and the event rate in the. So this is what the validation of these points is. And there are lesion specific risk also. So risk they have defined for mother, for the obstetric during the delivery, what is going to happen, and how many times the delivering obstetrician is going to face the ire of relatives, and what is the fetal and neonatal risk. So these are the disorders where the risk is still manageable and acceptable. These are the conditions where the risk is on higher side, especially for the babies. These are the obstructive lesions and the cyanotic lesions where the growth of the baby is not happening as per the norm. These are the conditions where the risk to mother is very high and we have to admit the patient or hospitalize the patient during the 3rd trimester. So another aspect of pregnancy is if a mother having congenital heart disease, what is the likelihood that the baby or the fetus is going to have a heart disease? So we have to counsel the patient. ASD patient is going to have a baby with heart disease to the tune of 4.5 to 6%. So this is what the data tells us, that there is a recurrence of risk of congenital heart diseases to the baby if mother is having heart disease. Something about peripartum cardiomyopathy. This is considered to occur during last month to 5 months of postpartum period, but it may happen before that also. It is due to the cardiotoxic effect of subfragment of prolactin. Prolactin is increased during pregnancy and that is what is the damaging. So nowadays we have realized there has to be a substrate in the lady. The myocardium is responsive to this toxic subcomponent or the subfragment, and that is what leads to development of PPM. More common if the women are more than 30 years. Sorry. There is a strong correlation with PIH and twin pregnancy. Bromocriptine is the medicine that we use to treat. Again, valvular heart disease is the most common. RHD in India that we see during pregnancy. Isolated MS followed by combination of ASMS is a common lesion. Tolerance of pregnancy is influenced by, a level of pulmonary hypertension. So having MS and AS is important, but if there is additional PH because of this mitral stenosis, then it becomes very serious issue for the pregnancy to be continued. In our practice, we have done intervention So what is best is to diagnose before the lady plans a pregnancy and treat it. Usually in young age we can treat with balloon, do the BAV, BMV, give some years of risk-free life to the lady, complete the family, 1 or 2 kids, and then finally once the disease progresses, go ahead with the open heart surgery, because prosthetic wall itself is a disease condition. It is difficult to manage during pregnancy. We need to be careful not to cause new, so when we plan BMV or BAV, we have to be less aggressive. What is our idea is to let down the PA pressure, come down to normal, have some gain in the area, but in this process avoid causing complications like regurgitation. Again, it will be added disorder and patient may not tolerate it. Preferable time for intervention is during the 20th week of gestation, not before this. We can go up to 24 weeks, but then the uterus is increased in size, it may hinder. So 20 to 24 weeks is the best time to intervene for the minimally invasive procedures. We need to continue the penicillin prophylaxis for the rheumatic heart disease patients. And mechanical valves, we know it's challenging. As the issue of anticoagulation is there, we have to keep the patient on heparin during the first trimester. Nowadays the guidelines are advising to continue warfarin till 36 weeks of pregnancy. When we are planning elective delivery by doing cesarean, then you switch to injectable anticoagulation and stop warfarin. So ISD, the incidence is on the rise. We are seeing more frequently now. The number is less if we compare the whole pool of the heart diseases. We need to continue aspirin and beta blocker where it is indicated. Metoprolol is the preferred beta blocker in pregnancy, proven to be safe. Even we can give to lactating mothers. It's very challenging to manage because we cannot give the statins, radiation risk if intervention is needed in emergency. So this is the medicines. As we can see, majority of the medicines are contraindicated. Metoprolol and maybe carvedilol can be considered, but no attain. MRI is contraindicated. Diuretics as and when required if there are congestive signs, but there is a risk of oligohydramnios and we need to monitor the lady frequently and so many things. So this is the algorithm to manage cardiomyopathy patient postpartum, how to manage. So my take home message is heart disease in pregnancy pose a risk to life of mother as well as the fetus. We need to take it very seriously. Risk stratification is necessary so that we can counsel the lady, the parents of the hopeful parents of the baby at right stage, and we can triage. We can decide which lady to be sent to a tertiary care center where institutionalization is necessary during the 3rd trimester. The modified WHO class 4 are a strict no for pregnancy if it is not rectifiable. We need to counsel as a team. So there is a need to formulate cardio-obstetric clinics. This area we are not thinking, we are not focusing on. This is a very need of the hour, and there have to be clinics where a cardiologist and obstetrician are sitting together and managing, gaining experience, and it is improving our, widening our knowledge base. And intervention has significant role to play in prevention. So this is one condition where intervention works as prevention to prevent the complications of the related disorders, and it should be done, the intervention should be done by high volume centers and high volume operators to give optimal result to the patient. Thank you. So any questions are welcome. Yeah, it is a stormy onset.
And there are not many features with which you can predict it during pregnancy. And retrospectively, then they will tell, yes, she was having fatigue, she was having palpitation. But usually in pregnancy, what happens? These are ignored.
They're common symptoms, ma'am. Yeah. Common symptoms, fatigue. And so one thing I have observed is, if the heart rate is too fast, unusually fast, then we have to keep the close watch. Nowadays, there are studies which are advising use of a biomarker, the NT-proBNP level. Just check it. If we are suspecting, there are certain criteria, though we are not confident and experienced about use and interpretation of NT-proBNP in this particular subset, but I think we should gain knowledge by using it, that one thing is there which will guide us, whether it is increasing excessively or no. Yes, ma'am. Too much, yes. Yes, ma'am. Even in this case, even if there is a tachycardia, the heart pumping goes down suddenly. Why this happens, we don't know. Heart tries to compensate and there comes a tipping point where all controlling mechanisms fail. But maybe there is a role of strain imaging in 2D echo. So we have a special feature where we look at the strain changes of the myocardium, and it is helping us to understand the high risk patients, especially those who are undergoing chemotherapy in oncology, cardio-onco group. There we are able to predict whether a particular patient is going to get LV dysfunction or no. Maybe that will also help us in near future. So we need to study. So that is the area where we need to come together, collaborate and work on.
It is suggested to set up cardio-obstetric clinic. I would also like to request you, the people usually do not approach such type of clinic. Only the adolescent girls who are likely to be the future expected mothers, they are to be counseled directly. Without that, this is not going to be effective. That is my take. You can comment on that.
No, very good idea, sir. But India is having a vast population and our resources are mere. So maybe in future with strong government, good amount of money expenditure on the health sector, why not? But sir, if you look at these things, mitral stenosis, these are the preventable things. Except the congenital heart disease, rest all groups should be prevented. They should be screened at appropriate stage. So there has to be criteria in place so that we can optimize our resources and give best to the society. So it is all based on the clinical parameters. So we have to look at how the pregnancy is progressing, how the heart rate is increasing with that. It is a gradual process. Second thing, we have to auscultate. Ejection systolic murmur will be there in each and every pregnant lady from second trimester onward because of the increased flow. But something unusual, extra sounds, getting ECG is not a harm. It is safest investigation, and based on that, echo also. So maybe we can, as our resources become better, we can use echo and ECG as a routine tool during pregnancies. Yes, second trimester onwards.
So, just a point, sir. Would you like to recommend cardiac screening in the second trimester in people who are elderly, more than 30, 35?
As a
when
blanket.
Would you recommend second trimester or third trimester? When would you like to recommend the cardiac opinion?
Sir, again, it depends on the clinical judgment, the tolerance of the lady for the pregnancy, and assessment of the obstetrician. If something is unusual, it is better. We cannot generalize it for each and every pregnancy. Maybe high-risk pregnancies, why not?
You said valvular heart diseases, ischemic heart diseases may occur during pregnancy. But what about the congenital heart disease? I don't understand why there should be congenital heart disease during pregnancy.
So those girls who had congenital heart disease, they survived without even getting diagnosed. They get married, they become pregnant, and that time we face the challenges. So we have seen PDA with PH, and the lady is pregnant. We advise them not to carry on the pregnancy because it is something which is irreversible, difficult to manage. But our country is something where we have a very minimum influence on the parents.
If you diagnose congenital heart disease during pregnancy, will you allow pregnancy to continue?
It depends on what we are looking at. If I'm looking at ASD, VSD, MR, I will allow it. But if it is anything where there is a severe PH and irreversible, I will not. Mitral stenosis, I will allow. I will do BMV at right stage. I will do BAV if there is aortic stenosis. But something is there which is uncorrectable. Suppose there is a severe tetralogy of Fallot. Saturation is 75%. It is difficult to carry on the pregnancy. There is a risk of abortion at later stages. as well as there is risk to mother also. So it depends whether we can offer correction with minimum effect on the fetus or no.
Okay, thank you, Dr. Wagmare.
Thank you, sir.
Thank you, Dr. Nagesh. Now I request our chairperson, Dr. Mansingh sir, to present a memento to Dr. Nagesh Wagmare as a token of appreciation. Sir.
As you are running the short of time, I request the chairpersons and all the delegates not to take any question. We will discuss in the lunch hour only. Now the next speaker will be Dr. Saurabh Deshpande. He is eminent cardiologist, electrophysiologist, and he is our honorary electrophysiologist also. He will be speaking on the ventricular tachycardia, the most dreaded complication of any acute coronary event, that is ventricular tachycardia, and he will take us through the his slide, that is ventricular tachycardia appearance to ablation. I request Dr. Chairperson to introduce Dr. Saurabh, please.
Dr. Saurabh Deshpande. He had graduated from Nair and then did his MD from Cheyenne and cardiology from the reputed Trivandrum Chittathirunal Medical College. And he has done post-doctoral fellowship in electrophysiology, cardiac failure, pacing from again another reputed institute, Sir Jagjivan Institute of Cardiovascular Disease, Bangalore. Currently, he is the consultant electrophysiologist at Fortis Global, Jaslok, Holy Spirit, Apollo, JRH, Sushruta Hospitals. He has got multiple national and international publications. Welcome, sir.
Dr. Saurabh, stick to the time, please.
Yeah.
Thank you.
Good morning, everyone. Thank you, chairpersons, for the sweet words that you have said about me. It's good to back at JRH. I have a long association with Jagjivan Ram. Many of you might recognize me. So we'll try to be as fast as possible. It's a huge topic, but then I have tried to cover it in some common scenarios that we encounter in our clinical practice. So what exactly is ventricular tachycardia? So any rhythm which is exiting, so we call it exiting or originating, in the ventricles, that will be, so what is a ventricle? Which is distal to the bundle of His, and the rate should be more than 100. So all these things, if they are there in any of the tachycardia, that will be termed as a ventricular tachycardia. This is a slightly busy slide, and we don't have to remember all these things. The ventricular tachycardia can be classified based on a lot of things, and these actually are helpful for us in our management of the tachycardia. I would highlight only something called as the morphology, because that helps us in day-to-day practice, and I will be more focusing on that while you are deciding the management. Obviously, rest of the things also come into play sometime or the other. So the clinical scenario, so whenever we talk about any ECG change, so ventricular tachycardia is actually a ECG change. But always remember, do not treat ECGs. Try to treat patients. So we have to know the clinical scenario behind any case that comes to you. So if an ECG looks like VT, there should be the clinical correlation behind that particular thing. Otherwise, it can be an artifact. So clinical scenario is important. It depends on how the VT is presenting. Most commonly, everyone might have seen one VT patient. They come with hemodynamic collapse. So they will have, such VTs will have a myocardial origin, they will have some scar, they will have some structural heart disease, minor or major, whatever. And most of the times, these VTs, which come with hypertension, have very fast heart rates. So these are some of the scenarios where you will get the patient in hemodynamically collapsed state, and you have to act immediately. There are some slower VTs which present to your OPD. They can come walking. So most of the times you have time to evaluate such patients. So the first and most common scenario that you encounter is emergency setting VT in sudden cardiac arrest. A word was spoken about sudden cardiac arrest by Shishi sir earlier this morning. So everybody should be aware about the cardiopulmonary resuscitation whenever such an event happens. But then the patient should be DC cardioverted for the rhythm. So if you diagnose a patient with sudden cardiac arrest with ventricular fibrillation or ventricular tachycardia, only treatment is DC cardioversion as fast as possible. And highest energy available. So the first question which I get every time when I ask for DC cardioversion is how much energy. So never think about energy in an emergency situation. Just whatever highest energy available in your device, just put it on and shock the patient. It does not matter. Second scenario is it can be a patient who is walking to your clinic. So most of the times those are slower VTs. It can be monomorphic or polymorphic. Monomorphic are more common. And they present with palpitations, sweating, and there will be some angina, dyspnea, maybe associated ACS is there or not there. So such a scenario, we have to find out the cause of VT. Patients give you time. So DC cardiovert, start the patient on some medication. Most of the times the safest is amiodarone, and then evaluate for the cause, and then go ahead from that to the final management. The worst scenario in a VT patient is something called as electrical storm. So how do you define electrical storm? Is a condition where you have multiple episodes of VT. So by definition, there should be at least 3 or more VT episodes in a span of 24 hours. And they should be treated VT. So it can be treatment in the form of DC cardioversion, or a patient has ICD inside already and the patient has received anti-tachycardia pacing, that is called ATP. So either of these things have happened, 3 VTs, 24 hours, that is called electrical storm. Whatever stable you find the patient, that patient is not stable. Just consider it as the highest emergency in VT, and we have to have a multidisciplinary team in place to manage such patients. So what do you have to do? You have to correct the electrolytes, the ischemia, specifically in case of polymorphic VT. We have to start the patient on combination medicine. So avoid amiodarone if there is long QT evidence, but then other than that, we have very few medications available for VT. So one of the medication is mexiletine or lignocaine that you can give. Then you have intubation and ventilation. Such patients are very, very prone for going into worsening storm if we don't correct the underlying neurohormonal problem which is going on. So to cut that cycle, you have to intubate and ventilate the patient and get him VT free as fast as possible, him or her. Then autonomic modulation has been found to be very useful in VT storm or electrical storm. So we have to know what is sympathetic ganglion block, sympathectomy, and they are very useful for these patients. Hypothermia is not practical in every scenario, but then that is one of the things which is found useful to stabilize such patients. So investigations in the patient of VT, the most commonly and easily available is ECG, because that is how you diagnose VT. So how does VT help, ECG help you? It helps, the event ECG also helps you to give some clues as to where the VT is coming from, what is the patient having, whether the patient is having the ECG which has some clues which tell you that it is an idiopathic origin or a scar VT origin, or whatever the cause or mechanism of the VT. And the baseline ECG, that will again tell you whether there is any structural heart disease in that particular patient. So this is how the ECG will help you. Echo, the main thing we have to find out is whether there is any structural heart disease in the form of congenital or scar or whatever you want. You just have to find out if there is any abnormality which can suggest that this patient is prone for VT. If you have a completely normal echocardiogram, that is not an uncommon scenario in a VT setting. You have to go for specialized imaging, like a CMR or PET CT. I'll be coming to these later on where it is useful. As cardiac MRI, now what is happening is the field of cardiac imaging is going into specialization. So you have some cardiologists specializing into imaging, or some radiologists who are specializing into cardiovascular imaging. So it is day in, day out, it is giving us more and more information. So in this particular scenario, in a patient who is presenting with VT, some of the specific parameters are to be looked for, that is like inflammation, or look for amyloid, or look for iron. So I have not included everything, but these are some of the common things which have to be looked for in MRI. And we should have a specialized imaging like extravascular volume, T1 mapping, which are the newer form of imagings which are there in a cardiac MR, that the technician also should be aware and the radiologist or the cardiologist who is reporting the MR should be aware. So that is why I wanted to highlight these points in setting of cardiac MRI. And in case everything is normal, this is one investigation which helps us in finding out if there is any latent inflammation anywhere inside the heart, that is a myocardium, or extra cardiac, that is like a lymph node or anywhere. And if those lymph nodes are actually accessible, you can just get a biopsy from those lymph nodes and find out the cause. Blood investigations, all of you are aware, all of you are doing all these investigations. The most important thing in any VT patient is electrolytes. Electrolytes are most essential, like potassium has to be between 4 to 4.5 milliequivalent per liter. Magnesium has to be more than 2 milligram per deciliter, and the calcium has to be normal in order to correct the VT. So first, the correctable causes should be treated. Rest of the things we can manage later on. As I said, there are some highly specialized investigations like genetics or the tissue biopsy that we spoke about, which can give us a pinpoint diagnosis in a patient whom otherwise we are not finding any cause. So coronary angiography has been spoken about a lot before, and it is one of the reasons for patient presenting with VT. But then, so whenever you have a patient with VT with coronary abnormality, first treat that. Most of the times they are linked. So the traditional thinking is only polymorphic VTs are associated with ischemia, but that is not the case. Even ischemia can present with monomorphic ventricular tachycardia, and that can be actually cleared with coronary angioplasty. CPR I'm not going to talk about a lot, but everybody should be aware of all these steps. So any patient of ventricular tachycardia has to be stabilized. So first step is DC cardioversion. Second step is essential medication. So if there is an acute coronary syndrome, treat that, or electrolyte imbalance, treat that, or do SOS angiography and angioplasty. And the medications which are commonly used are amiodarone, which is the safest, mexiletine, beta blockers. So those are the common medications which are used. And specific management, I'll come to these in my subsequent cases. So I'll have 4 or 5 scenarios in which the patient presents to us, mostly with ventricular tachycardia. So one of the scenarios is a young male with a structurally normal heart, presents with such type of ventricular tachycardia. There are some clues like a capture beat, fusion beat in between, which tell us that this is not a supraventricular tachycardia, this is a ventricular tachycardia. Patient did not have syncope, but had a lot of palpitations. So this particular patient was evaluated, found to have no structural heart disease. So taken up for EP study and RF ablation for definitive management for these PVCs or these VTs. And we actually found out that it was coming out from something called as left posterior fascicular muscle. And we had to ablate that area. So if you see this, this part, the white thing, is the area which was the earliest activated, and that was ablated there. And this was the ECG post-procedure. Patient almost 3 years down the line now, completely VT-free or PVC-free, we can say, and doing everything. Then the second scenario, which is very common and very easily mistaken, is polymorphic VT-VF. So this is a scenario, in this particular case, it is a 47-year-old female who had RHD, recently underwent a surgical procedure, post-op developed a complete heart block. And unfortunately, that complete heart block was associated with a long QT. A long QT can be there because of multiple reasons, and this is what happened to her in post-op day 1. She went into ventricular fibrillation, and it was shocked, obviously. We could not get a 12-lead ECG. No, most of the times we don't get time to get a 12-lead ECG. After that, obviously, there was panic. Everybody started the most favored drug, that is amiodarone, and then patient was referred for ICD. So I would say this is a common scenario. I think many of you might have faced this particular scenario. Amiodarone in this situation is completely counterproductive. It will worsen the situation. And ICD also will cause more problem than benefit in such patients. So actually we have to find out the cause, which was the QT prolongation. And this patient was treated for the complete heart block with long QT with a dual chamber pacemaker, nothing else. And we have to avoid all these medications. So there are very good sites coming up every day to find out which are the medications which cause long QT, and they should be avoided in such patients so that those polymorphic VT episodes do not happen in future. sometimes these patients will have to be paced for a faster rate. This particular ECG is 60 beats per minute, but the earlier follow-up, we had kept the patient on 90 beats per minute and then decreased it later on. So the approach, it should be remembered that ICD is almost never the first line for these patients. We have to treat the most common causes, that is the electrolyte imbalance, the ischemia, long QT, and treat the channelopathies if the patient already have some evidence of channelopathy, and manage as a primary cause, and the temporary pacing might be useful in acute condition. Another scenario where the patients can present to us is something called as non-ischemic cardiomyopathy. So as I told you, a patient presenting with VT, do the coronary angiogram and surprisingly find out that there is nothing on coronary angiogram. It's completely normal. So if you see this fast VT, patient will be completely hemodynamically collapsed. Patient was shocked and to find this particular rhythm. Surprisingly, on the baseline rhythm, there was nothing. It was completely clean, and as was suggested by the normal coronaries as well. But this is what was found on the cardiac MR, and this is what was found on the PET CT. So cardiac MR itself showed some features of inflammatory cardiomyopathy. So it was suggested to rule out sarcoidosis or tuberculosis. And we have subsequently done a PET CT, which actually showed similar findings, and we got some lymph nodes which were metabolically active. And those nodes were actually biopsied via, so it can be done through the respiratory tract. And then we could find that it was a sarcoid, and agreed, the treatment did not change much, so we just have to rule out the COX first, obviously. In Indian setting, none of the patients are ruled out of COX unless it is completely negative. So you have to be really through with those investigations. Then treat the patient with steroid and steroid-sparing agents. These patients are indicated to put an ICD, that is class 1 indication. But then antiarrhythmics also has essentials for these patients. I'll not go through this whole thing because this is what we have done in that particular patient. But this is all we should be aware of whenever the patient presents like this. Monomorphic VT, fast, we can't explain anything, then we have to go by that line. So unfortunately, I have two more cases like this. One of these you might know, this is a typical scar VT. It has to be bombarded with ablation for such patients to get rid of that. There is something called as epicardial VT, which is outside the heart, and we have to ablate in the epicardium. So if you see these red dots was where the successful ablation was done. And there is a scenario where patient has a channelopathy. So this particular patient presented with Brugada syndrome with some VT episodes on TMT, and surprisingly had a shock on follow-up also. And this patient was actually started on something called as quinine. So quinine is the drug of choice, but that is not available in India. So we keep the patient on quinine in India, and then that actually got rid of those PVC and VT episodes. So to summarize, ventricular tachycardia is an emergency. Stabilization is very important, and always look for the specific cause. Avoid ICD in polymorphic VT like CPVT also, and you need a multidisciplinary management in cases where you have a VT storm situation or a channelopathy situation. Thank you.
That was a very nice presentation. Just one point. What will be the role of EP study in such cases, electrophysiological study?
Sir, actually, as I highlighted in 2-3 of my cases, I could not go through the other 3. It depends on the cause, sir. So whenever you are suspecting an idiopathic VT, it is better to go ahead with EP study as early as possible, because that is a very good treatment. Patient don't have to take medicine lifelong. But whenever you have a scar in the form of non-ischemic or ischemic cardiomyopathy, you have to think of EP study if you don't have any other options left. What I mean to say by that is the EP study in such situation or the RF ablation in such situations is not curative. It is something we call as bulk reducing strategy. So if you have a patient with scar VT, you have started the patient on amiodarone, mexilatine, beta blocker, you can whatever highest dose you could give, you have given. Still the patient is having shocks. So you don't have any other treatment available with you. Or a patient you have started on amiodarone, started having long QT, you have to stop the amiodarone. You don't have any other medications left with you. So such patients actually can undergo RF ablation. You reduce the bulk of the VT so that your patient on follow-up can be managed with minimum medications which are there.
Thank you very much. Thank you.
Thank you. Thank you, Dr. Saurabh. Now I would request our chairperson, Dr. Krishna Kumar sir, to present memento to Dr. Saurabh Deshpande as a token of appreciation. Thank you, sir. Our next speaker is Dr. Harshvardhan from JRH. He will be talking to us on cryptogenic stroke approach. I would request our chairperson to briefly introduce our next speaker. Before that, I would just like to make one announcement. In view of shortage of time, I would request all the speakers to stick to the time, and the bell will be ringing at 15 minutes and subsequently at 20 minutes interval. Thank you.
Dr. Harshvardhan is batting on his home pitch. Please give him a round of applause. He has been a physician par excellence in the earlier times and now a neurologist. So he is continuing his very good work. So I would request him to continue with his, to initiate his presentation, please.
Thank you so much, sir, for the kind words. At the outset, I would like to welcome and thank you, DGRHS madam, respected DGRHS madam and respected PCMD madam, respected MDJRH madam and SAMO to give me this huge opportunity. So I'm here to shift gears, okay? So now that I'm amongst so many eminent cardiologists, and because without cardiologists, a neurologist feels incomplete actually. So, but because heart and brain, as we all say, दिल और दिमाग दोनों भले ही एक दूसरे की ना माने, but साथ ही चलते हैं. तो let me take you to a different world. Now that we are into world of cardiology, we'll try to take up this topic. So my topic today is cryptogenic stroke. I'll be discussing an approach. So there'll be a lot of slides which I'll try to enlighten you as much as I can because this topic is huge, but I would try to make it as interactive as possible and utilize my last 5 minutes for a few questions, if that is allowed, because I'll not cross my 20 minutes. So, stroke as a healthcare issue, almost more than 7 million, almost 8 million new recurrent strokes yearly we get. Out of all the stroke cases, 87% cases are ischemic stroke, 13% cases belong to hemorrhagic stroke, out of which 1% belongs to subarachnoid hemorrhages. It is the 5th leading cause of death globally and a leading cause of serious long-term disability. So what we lose when we have a stroke, in each minute during a stroke, 1.9 million neurons are lost, 14 billion synapses are lost, and 7.5 miles of myelinated fibers are destroyed. So without prompt treatment, a part of brain the size of a pea dies every 12 minutes following a stroke. So taking you to the current topic, so cryptogenic stroke incidence. So as I told you, majority of the strokes are ischemic strokes. So amongst the ischemic strokes, 77% strokes warrant to non-lacunar, 23% strokes are lacunar strokes. So amongst the non-lacunar strokes, the other etiologies that have been classified are cardioembolic, large artery atherosclerosis, cryptogenic, and other causes of either determined or undetermined etiology. So more than 690,000 ischemic strokes every year in the US are leading cause of disability, and cryptogenic strokes account for about 1 in 3, almost 35% of ischemic strokes. And embolic strokes of undetermined source, ESUS, account for almost 50% of cryptogenic stroke cases. So once we get a case of stroke in our ER, so we run a battery of diagnostic tests, out of which from basic to specialized tests, ECG, rhythm monitoring in the form of continuous telemetry or cardioscope monitoring, what we do in ICU, or a Holter study, CT or MRI brain, which is the backbone of stroke diagnosis, vascular imaging in the form of cervical carotid imaging, in the form of carotid Dopplers, CT angiographies, MRI angiographies, intracranial arterial imaging, which identifies stenosis, dissections in the form of digital subtraction angiography in the cath lab, blood testing for various risk factors, and echocardiogram. So primarily, when we get a stroke case, we always, as a part of the workup, one of the vital investigation modalities becomes transthoracic echocardiogram. So this is a very busy slide. So this gives us a summary onto how we generally approach. So tier 1 level of investigation. So we do a non-contrast CT or MRI in the brain, a TT, transthoracic echo, plus or minus a bubble study, ECG followed by a 24 hours Holter where indicated, CT or MRI of the head, CT or MRI of the neck vessels with or without carotid ultrasound, basic labs to rule out the other risk factors. Tier 2 is transesophageal echocardiography. If a PFO is detected on echocardiogram, DVT ultrasound of the extremities to rule out to prevent a paradoxical embolism. Prolonged cardiac monitoring, MRA with carotid plaque protocol or fat suppressed images to distinguish whether the plaque is stable or unstable. Evaluation for occult malignancy, cerebrospinal fluid analysis that comes into tier 3 when all these routine investigations fail to get us the etiology of stroke. Cerebrospinal fluid analysis, advanced lab studies like autoimmune pathologies, infectious pathologies, a conventional DSA, genetic testing, because lots of cryptogenic strokes, there are genetic etiologies to it. And finally, if nothing works, then brain biopsy. What are the treatment implications of cryptogenic stroke? The ability to more clearly define the etiology of cryptogenic stroke and previously unknown risk factors has implications for subsequent treatment and risk for recurrent events. Secondary prevention strategies should be tailored to the ischemic stroke etiology subtype. Most cryptogenic strokes patients receive antiplatelet therapy for secondary prevention, treatment that is not effective in preventing strokes of cardioembolic origin. Long-term patient monitoring reveals atrial fibrillation in up to 30% of cryptogenic stroke patients. So how do we define a cryptogenic stroke? So according to the AHA guidelines, American Heart Association, American Stroke Association, a stroke and a TIA that defines cryptogenic stroke as an imaging confirmed stroke with an unknown source despite thorough diagnostic assessment, like what we mentioned in tier 1 and tier 2, including at a minimum arterial imaging, echocardiography, extended rhythm monitoring, key lab studies such as lipid profile, HbA1c. So these are the classifications based on which we classify strokes, out of which most commonly used is the TOAST classification for stroke. The other 3 being less commonly used. So TOAST classification mentions that the 5 common subtypes are large artery atherosclerosis, cardioembolism, small vessel disease or lacunar strokes, strokes of determined etiology like vasculitis, lupus, and things like that, and strokes from undetermined etiology where we think of cryptogenic strokes. So cryptogenic stroke as a diagnosis of exclusion. So as I told you, large artery atherosclerosis, it could be atherosclerotic, atheroembolic, aortoembolic from the arch of aorta. Small arterial inclusion could be a branch occlusive disease or a small arterial occlusion leading to a lacunar infarct. Cardioembolic being cardioembolic from the heart itself, or paroxysmal AF, or paroxysmal embolism, and other causes, including cancer, coagulopathy. So let me take you to the potential etiologies that could present as a cryptogenic stroke. First thing being patent foramen ovale. PFO is seen up to 25% of adults and 40% of stroke patients. PFO is an embryonic defect and is characterized by an opening in the septum between the atria. This opening provides a conduit for emboli derived from the deep veins of the pelvis or the legs. That is what we call paradoxical embolism. And the prevalence of PFO has been shown to be higher in young adults with cryptogenic stroke. Other potential, as I mentioned, occult paroxysmal atrial fibrillation. These are the various modalities of continuous telemetry, ambulatory electrocardiography, serial ECGs, Holter monitoring, loop recorders. So what is the risk of stroke in patients with AF? So ischemic stroke associated with AF is nearly twice as likely to be fatal as non-AF related stroke, well-established data indicate that AF is associated with a 5-fold increase in the risk for ischemic stroke. And in patients with AF, treatment with oral anticoagulant decreases the risk for stroke by almost 64% compared with placebo. Other potential etiologies are hypercoagulable states, where we run thrombophilia profile, protein C, protein S deficiency, antithrombin 3, factor V Leiden mutation, lupus anticoagulant, APLA syndromes. We even had a patient who had severe B12 deficiency, which led to hyperhomocystinemia, many such patients, which is also a potential thrombophilic marker. Aortic arch atheroma. So this is a cut taken across the arch of the aorta, where you can see that there is an unstable plaque. By unstable, I mean that the actual plaque, the mature part of the plaque is this hyperintense or hyperlucent focus, and the part which is hypo is this unstable part from where atheroemboli can lodge into the cerebrovascular system. Other etiologies are cardiac tumors and malignancies. One more unexplored or generally not thought of etiology could be cervical or vertebral, carotid or vertebral artery dissections, which are a very common cause of strokes in the young. Other potential etiologies, vasculitis, could be autoimmune due to lupus, ANCA, infectious due to varicella zoster, neurosyphilis, tuberculosis, primary angiitis of the brain, then neoplastic. Neoplastic vasculitis is also an upcoming etiological factor. So diagnosis. How do we approach the diagnosis of such strokes? So first we run a CT or an MRI. If it does not show any ischemic focus, then we think of stroke mimics, or we consider a delayed imaging with CT or MRI, if not done initially, and then we manage according to the etiology that we find. So other common mimics that generally we find are myasthenia gravis, hypoglycemia, hypocalcemia. They can mimic a stroke. If we find any ischemic stroke on the CT or MRI, we run the basic test, ECG, 2D echo, and we do a non-invasive neuroimaging like CT, angio, MR angio, or ultrasound of the neck vessels, non-invasive intracranial arterial imaging. If it fails, if there is no cause found and the baseline comorbidities are ruled out, then we go for long-term cardiac rhythm monitoring. Genetic stroke syndromes, we do genetic tests. We test for infectious markers. We do a TEE, cardiac CT or a cardiac MRI, and we evaluate for even other rare causes. So I already discussed the initial stroke workup, so I'll run through this slide. Neuroimaging, so as per AHA-ASA guidelines, in patients suspected of having ischemic stroke, if CT or MRI does not demonstrate symptomatic cerebral infarct, follow-up CT or MRI of the brain is reasonable to confirm the diagnosis. In patients suspected of having had a TIA, if the initial head imaging CT or MRI does not demonstrate a symptomatic cerebral infarct, follow-up MRI is reasonable to predict the risk of early stroke and to support the diagnosis. And MRI has similar sensitivity even for acute intracranial hemorrhage, and the added advantage that in early strokes, CT might fail to detect ischemic events where MRI is superior. So what cardiac testing we do as additional? When could TE be done or not be done? So TE is as an initial test we do when there is a high pretest probability of cardiac embolic source, patients with suspected left atrial appendage or left atrial thrombus, patients with a mechanical valve or post-mechanical valves, post-valve replacement surgery, and patients with suspected aortic pathology. And when TE is not considered, or TE is considered as an initial test where there is a high suspicion of left ventricular thrombus, patients in whom TE is contraindicated is esophageal stricture, unstable hemodynamic status, or patients who refuse TE. So these are the various continuous monitoring modalities, where out of which commonly or practically that we do is on admission ECG, continuous telemetry inside the ICU, Holter monitoring, where 24, 48 hour, 7-hour Holter monitoring can be considered. The other two are not that practical, where implantable loop recorders are also considered, but it is an invasive procedure and it is technically less feasible in India. So the detection of occult paroxysmal atrial fibrillation in patients suspected of having a stroke or TIA, an ECG is recommended to screen the AF and atrial flutter and to assess for other concomitant cardiac conditions. In patients with cryptogenic stroke who do not have a contraindication to anticoagulation, long-term rhythm monitoring with mobile cardiac outpatient telemetry or implantable loop recorder or other approach is reasonable to detect intermittent AF. In patients with cryptogenic stroke, stroke of unknown cause, in whom external ambulatory monitoring is also inconclusive, implantation of a cardiac monitor or a loop recorder is reasonable to optimize detection of silent AFs. So let me show you two case vignettes. So a 51-year-old woman, episode of unsteady gait and dizziness less than an hour. On admission, vitals were stable, no actual focal neurological deficit. After an urgent MRI, admitted to the ICU for further assessment. So this was the MRI picture. So there were two multifocal infarcts, diffusion restriction on the left cerebellum. So MRI of the head and neck turned normal. TT, that is transthoracic echo, showed normal echo. Subsequent TEE confirmed these results that showed that her atrial size was at the upper limits of normal, and TE showed that there was no thrombus and there were normal velocities in the left atrial appendage, a normal aortic arch, and no evidence of patent foramen ovale. A 24-hour telemetry was even negative for arrhythmia. Patient was discharged on an antiplatelet and was followed for additional 14 days with mobile cardiac telemetry. No during this period. 5 weeks after her initial presentation, she again developed similar symptoms. And this time she also had a right-sided headache with nausea and vomiting. The symptoms were almost for 2 hours. She was again admitted to the ICU. And this time she had another infarct in the right caudate, gangliocapsular region. So what could be the possible etiology? Now that we discussed so many occult causes. So it was occult paroxysmal AF. So because the initial 14-day halter could not find anything, she was subsequently implanted with an implantable cardiac monitor and discharged on antiplatelet therapy. After 2 months of monitoring, episodes of paroxysmal AF lasting for 15 to 90 minutes were detected. The patient was changed from prior antiplatelet to an oral anticoagulant. So treatment, acute therapy, intravenous thrombolysis is always gold standard in the golden hour, that is 4.5 hours of stroke, and mechanical thrombectomy wherever indicated. Secondary prevention of stroke, most patients with acute ischemic stroke or TIA should be treated with all available risk reduction strategies, blood pressure management, antithrombotic therapy like antiplatelets, statins, and lifestyle modifications, sugar control. Lack of benefit with anticoagulation in patients with cryptogenic stroke, but there is no proven benefit of anticoagulation compared with antiplatelet therapy for preventing recurrent ischemic strokes in patients with cryptogenic strokes, including those with ESUS. These are the trials that demonstrated this. I could not go because of, into the detail because of shortage time. A percutaneous PFO closure in addition to antiplatelet therapy suggested for patients age less than 60 years with an embolic appearing cryptogenic stroke who have a PFO with right to left shunt detected by bubble study. So my take home message is cryptogenic stroke is a diagnosis of exclusion most of the times. This category of stroke can be expected to decrease in size over time as implementation of recommendations for a thorough diagnostic workup becomes more widespread. Secondary prevention strategies should be tailored to the ischemic stroke subtype. It is clear from long-term monitoring studies of patients with cryptogenic stroke that between 1/5 and 1/3 of these patients have paroxysmal AF and are at risk of cardioembolic stroke regardless of etiology of the first stroke. Management of vascular risk factors remain extremely important in secondary stroke prevention of cryptogenic stroke patients, including but not limited to diabetes, smoking, cessation, lipids, and especially hypertension. Aggressive medical management, often performed by multidisciplinary teams, is usually the best, with goals of therapy tailored to the individual patient. So my teacher always told me that time is brain. So for all general physicians, surgeons, physicians of other specialties who don't deal with stroke that frequently, but I appeal to you all that wherever possible, we should try to raise awareness for early and absolutely early detection of acute stroke. For that, we generally teach the community. When we go into the community, we teach the people, the listeners, that when you spot a stroke, learn the warning signs of stroke and be fast. So by be fast, I mean check for balance, check for any eye signs, any blurring of vision, any deviation of eye, deviation of gaze, any ptosis or any double vision. Then you look at the face, whether there is any asymmetry, whether there is drooping of the angle of the mouth or deviation of the angle of the mouth. You look for the arms, whether the arms are drifting, whether there is any weakness in any particular arm, and speech, whether there is speech difficulty, and T is time to call an ambulance at as early as possible. So with the blessings of DGRHS madam, PCMD madam, and with the able leadership of MD madam, we are already on track to get a CT here, and I promise that I'll put my efforts to bring up the first, probably all over Indian Railways, first primary stroke center as a part of neurosciences and neurosciences at JRH. So this is our current objective and plan. Together we can and we will make a difference. Thank you.
Any questions? Thank you, Dr. Harshvardhan.
Etiologies. One is that foramen nobile. Second is atrial fibrillation, and third, most probably from my side, it is homocystinuria. The preventable from my point of view is homocystinuria part, because most of them, they are caused by serum B12 deficiency. So if B12 deficiency can be corrected, that will go a long way. Because other two component, the common public as well as the general doctors will not be able to address. So I think B12 deficiency, because the reason of B12 deficiency in India, because we are vegetarian country. The trend is getting changed. Non-vegetarian foods are coming in, but they are not actually that much of supportive. We have a lot many people with B12 deficiency. So you take on that, if can be serum B12 deficiency can be estimated, and after that it can be corrected. This will go a long way.
The good point, sir. Thank you for that. So actually, there are no definite recommendations or guidelines to screen the population for B12, but wherever indicated, if we find patients with anemia, and most of the anemia nowadays we find dimorphic anemia, where there could be both iron deficiency as well as B12 deficiency, and patients who are pure vegetarian who have stroke-like symptoms or TIAs, doing B12 levels is a very good idea, and it will go a long way in prevention of stroke.
Thank you.
Thank you. Thank you, sir. Now, I would request our chairperson, Dr. Krishna Kumar, sir, to present a memento to Dr. Harshvardhan as a token of appreciation. Thank you, sir. Our next speaker is Dr. Ameya Udvekar. He will be speaking on supraventricular arrhythmia, simple to malignant. I would request Dr. Ameya to come on the dais and start his speech. I would request our chairperson to introduce our speaker, Dr. Ameya Udvekar. Thank you.
Welcome to Dr. Ameya. He has done his MBBS, MD General Medicine and DM Cardiology. He is also an electrophysiologist who is specializing in cardiac rhythm disorders and pacemakers and devices. He has taken the fellowship from Australia. He has been awarded the GM Tata Endowment Scholarship for the year 2006. And he also was the winner of the Young Investigator Award in 2007 in the Asia Pacific Heart Rhythm Society meeting. He has over 45 national and international original publications. He is presently working at Hinduja and Jaslok hospitals. Welcome, please.
Thank you, sir. So, good afternoon, everyone, and thank you for inviting me today to this meeting. I'll be speaking about supraventricular tachycardia. Now we all know tachycardias can be supraventricular or ventricular, and these are very common in clinical practice. A lot of times patients come with palpitation. When you see the ECG, you have a tachycardia. So normally we will classify them as narrow QRS or wide QRS. So when you have a narrow QRS tachycardia, that means the QRS width is very narrow, less than 120 milliseconds, we carry it as narrow QRS tachycardia. Majority of the time, the narrow QRS tachycardia is always because of an SVT or supraventricular tachycardia. A broad QRS tachycardia, you can have a lot of causes, like as Saurabh rightly discussed, VT is one of them, and of course aberrancies and all those things. But my topic for today is supraventricular tachycardia, simple to management. So young lady in her 20s, weighs around 50 kgs, no comorbidities, says that she easily gets breathless, anxious, sometimes panicky, so a lot of panic episodes, has heavy menses, hemoglobin is little lowish, around 10 grams %. When you examine her, she looks a little pale, blood pressure systolic remains always in the range of 90 to 100. Okay, so this is very common, and when you see her with hyperventilation, little anxious. So extremely common in our clinical scenario. And when you see this ECG, the heart rate is fast, almost 150 beats per minute. So there is a lot of times we see patients being given adenosine, beta blockers, and other type of vagal maneuvers, and then they call us, sir, kam nahi ho raha hai, because the rate is still 150. Why? Because this is sinus tachycardia. Okay, the rate slows down for transiently for some time, again it picks up. Because here there is no abnormal SVT. This is a sinus tachycardia. Now, as we all know, sinus tachycardia is the commonest reason for tachycardia. Okay, that is the commonest type of tachycardia in clinical practice. Okay, so how do you recognize this? If you see the P wave, I think there's a marker here. Yeah, there's a P wave. I don't think there's a marker here. Yeah, so P wave, you can see biphasic P wave, positive, negative. Okay, positive and negative. That's in lead V1. Okay, positive in lead 2-3 AVF. Okay, and negative in AVR. So if you see this type of morphology, it is always, most of the time, from the sinus node. So if you see a P wave morphology, clearly, which is mimicking almost like sinus morphology, it means it's a sinus tachycardia. So as we all know, multiple causes of sinus tachycardias, okay? Starting from physiological causes, like exercise, fever, pain, or pregnancy, and medications like alcohol, caffeine, decongestants, which we use, sympathomimetics, theophylline, thyroid supplements, tobacco, alcohol, okay, and medical causes. Medical causes, you can have heart failure, regurgitation, anemia, Cushing's disease, hyperthyroidism, infections, pheochromocytoma. So a proper history, a proper clinical examination will point to some sort of diagnosis. In our patient, it was more of anxiety, which was panicking of those sort, and plus a little lowish hemoglobin, lowish blood pressure, again compensating by having a tachycardia. So in that patient, you normally would give her increased salt intake, increase water intake, try to calm her down, probably add anxiolytic with a psychiatric reference, and probably if there's still tachycardia, you may add something like propranolol or ivabradine, which doesn't reduce the blood pressure. So one of those drugs. Now second case, this is a female who is a 50-year-old. He says she has multiple episodes of tachycardia. So this tachycardia starts and tachycardia stops. So there's a sudden start and there's a sudden stop. That's why we call it as paroxysmal. When we say paroxysmal, it means sudden starting, sudden stopping. It's not slowly going up. It's not a gradual onset. It's a sudden onset. Suddenly one moment it is there, tachycardia is there, and suddenly next moment it stops. So it's a paroxysmal onset. So it normally is that when I hold my breath, it stops. When I cough, it stops. So patients, some patients, they learn that by doing this, the tachycardia is terminating. Okay, so the history itself tells you that there is probably an SVT going on because she is able to stop the tachycardia by doing a vagal maneuver. Feels giddy when the tachycardia starts, and sometimes they last for a few hours, and then sometimes they do an ECG. So here, if you see the ECG, you know that this is a narrow QRS tachycardia, and you try to look for the P waves. Now, this is the T wave, okay? Because of the tachycardia, it little peaked, but there are actually no clear P wave seen, right? If you see on this, just before the QRS, there's no P wave. It's almost like a straight line. So there's no obvious P wave. Okay, when you see this in a tachycardia, majority of the time, it is an AV nodal reentrant tachycardia. This is the commonest type of SVT. 60% of the time, when you don't see the P wave before or after the QRS, it is a AV nodal reentrant tachycardia for all practical reasons. You can have DDs, but for practical reasons, AV nodal reentrant tachycardia. What does it say? It's a re-entry tachycardia where in and around the AV node. Okay, so when you have a atria, a ventricle, you have the his Purkinje system, and there's a AV node there. In the AV node, you have something called as the fast AV node and a slow AV node. So there's a dual AV node physiology in these patients. And that's why you have a tachycardia which is around the re-entry circuit around the AV node. So something goes down the slow pathway and something comes up via the fast pathway. Okay, but both, it is around the AV node, so both atrium and ventricle is simultaneously activated. So something goes up towards the atrium, something goes down towards the ventricle from the AV nodes, because AV node is in the center. So it is always like this. So that's why you are seeing the QRS. The P wave is embedded in the QRS. So you are not seeing the P wave. So it's simultaneous activation of the atria and the ventricle. That is what you are seeing. Okay? And as I said, AV node is part of the circuit. So if you block the AV node, the tachycardia will stop. So if you block the AV node, the tachycardia will stop, because AV node is part of the circuit. AV node is taking part in the circuit, right? So how do you stop the tachycardia? Patients will themselves tell you. I do a vagal maneuver and it stops. And sometimes you can give drugs which can slow down or block the AV node. So which are the vagal maneuvers? You can tell the patient to cough or give a carotid massage one at a time. Especially young patients, very elderly, you would avoid a carotid massage. Do not give it if there's a carotid bruit. Okay. Gagging, just putting your fingers and trying to gag. Eyeball pressure, again patients for glaucoma not advisable. Valsalva maneuver, okay, that's the commonest clinical maneuver which we do to stop the tachycardia. And modified Valsalva. What is Valsalva maneuver? You hold your breath and you strain as if you are having constipation. And you strain during constipation. So something like that. So clinically, if you want, you give them a syringe and hold it ulta and tell them to blow so that the piston is pushed ahead. Okay, that generates almost 40 millimeters of pressure in the abdomen. And that stimulates the vagal nerve. And tachycardia terminates. So this is one of the vagal maneuvers. This is also called as modified Valsalva. Now this was a trial which was done in UK. I wanted to play this thing. इसको फॉरवर्ड कर सकते हैं थोड़ा? नहीं वीडियो
The REVERT trial was
modified Valsalva is where the patient is blowing in the syringe, and after that the patient is वॉल्यूम नहीं चाहिए, really don't, because उसको क्या ये नहीं कर सकते, फॉरवर्ड नहीं कर सकते. Can you see that?
Salvo maneuver for the treatment of SV.
So what they are
Get a
doing
good
here,
seal around that with your mouth and blow hard enough to make the
blow
needle,
in the
which
syringe.
modification was designed to increase venous return during the relaxation phase.
ये प्ले मत करो क्योंकि क्या फॉरवर्ड नहीं कर पाता मैं. So I'll just play this because when I go
Modification
into
was
the
designed
slide
to
mode, the
increase
whole
venous
thing I
return
can't pause
during
it.
the relaxation
So you can
phase
see he's blowing
of the
40
maneuver
millimeters
and
of
involved laying
mercury
the patient flat and
abdominal
lifting the
pressure.
legs in the air at the
After
end of that
blowing,
strain
they
phase.
take the patient head low with leg elevation. Now this is
Overall,
called
we found that
modified
patients that were
Valsalva
randomised
maneuver.
to the
Okay,
standard maneuver,
30% of the
only
time the
17%
tachycardia will
of
terminate.
patients were
Okay, it's a
cardiovascular
modified
sinus rhythm,
Valsalva maneuver. So
whereas
you
for the
can see a
modified
tachycardia which
technique,
terminates.
43% of patients return to sinus rhythm.
So this is modified Valsalva maneuver. So very easy to do in clinical practice. Tell the patient to hold a 10 cc syringe ulta with the piston and try to blow in the piston so that the piston gets pushed forward. It's generating intra-abdominal pressure. After that, put the patient head low. Okay, it's proven by a trial. It was published in Lancet. Okay. Now the other thing is the adenosine injection. Lot of times we see complaints, sir, adenosine diya, 6 milligram diya, 12 milligram diya, tachycardia is still continuing. The commonest reason is because it's not given correctly. What is the correct way to give adenosine? You have to inject fast. Okay, half-life adenosine is only 6 seconds. it has to reach the heart within 6 seconds. You can't mix it with blood because it is metabolized by the red blood cells. So when you give, there should be no IV which is coated with blood cells or blood tinged. So that means the RBCs will metabolize the drug. So you have to take a fresh 5 cc syringe, fill it with adenosine, 6 milligram or 12 milligram, keep a 20 ml flush ready so that you can push both within 2-3 seconds. So whole thing has to be connected fast and pushed, and do not mix with blood. So if you see here, so the key is that in the biwall, connect adenosine at one side, saline 20 ml at one side. You give the adenosine fast and then push it fast. So within 2 seconds, you will reach the whole thing. See, this is the biwall. It takes the adenosine, 6 milligrams in the syringe. This is not the fresh syringe, not the blood stained syringe. Fresh.
Remember, you might feel that funny
okay, there's a
feeling,
flush
hard
which
to
is connected
discuss.
both together at the same time. Now here they have a valve, so they are connecting both to the valve. So see to it that the biwall is not blood stained, and then he gives the adenosine, he pushes it within 1-2 seconds, and the whole saline also goes within 1-2 seconds. So within 5 seconds, the whole drug has to reach the heart. That is the most important step. Okay, and monitor will show you that the tachycardia will terminate. So if somebody tells me, see that, tachycardia terminates. So if somebody tells me, sir, tachycardia terminate nahi hua, the reason is because majority of the time, you have not injected it properly. Okay, so remember that. So now I'll go into the slide mode. So as I said, AV node dependent tachycardia, the tachycardia will terminate. But what if it's not a AV node dependent tachycardia, like atrial flutter? The tachycardia will not terminate because atrial flutter is in the atrium. AV node is not part of the circuit. So there you are blocking the AV node, but the tachycardia flutter will continue in the atrium. Okay, because AV node is not part of the circuit. So what it will do is basically you are just slowing down the ventricular rate. You're not blocking or terminating the tachycardia. You're just slowing down the rate. So when you give adenosine, you will see that there's no R wave, but you can see a clearly P waves or flutter waves coming out. So this is a flutter, okay? So AV node dependent tachycardias and AV node independent tachycardias. So if you have any other AV node dependent tachycardia, the second commonest type is AV reentry. So here it was AV nodal reentry, here is AV reentry. So atria ventricular reentry. So this is because of an accessory pathway, an extra connection which is connecting the A and the V. So the connection, the circuit travels from the AV node down, takes a U-turn in the ventricle, goes up via the atrium by the accessory pathway. So this is called AVRT, atrioventricular reentrant tachycardia. Again, if the pathway is connecting antegrade, what you will see is a WPW pattern. We all know this as a WPW pattern because there is a direct connection between the A and the V, short PR with a delta, which you see here, and you will see the QRS, which is little broad. So it is delta wave, okay? And case 3, I'll just take 2-3 minutes. So atrial flutter, this is the atrial arrhythmia. So the third type of tachycardia is atrial flutter, which is a tachycardia inside the atrium. So here, even if you give an adenosine or a beta blocker, the tachycardia will not terminate. It will slow down. This is called rate control. So if you want to control the rhythm, you will have to go and take something like adenosine or, Cardiron or ibutalite, one of these drugs. So I'll go to this slide. So SVT broadly classified, atrial dependent, AV node junctional dependent, and atrial tachycardia, which is independent. So if you do a maneuver like vagal or AV node blocker, you will terminate the tachycardia. It means AV nodal reentry, AV reentry. If it's an atrial tachycardia, it will not terminate. So you have atrial tachycardias, flutter, and fibrillation. But always remember
He's a DNB cardiology teacher, and he is one of the pioneers of rotablation and coronary imaging. He's been on the editorial board for Indian Heart Journal. Please listen to him. Give him a round of applause, please. We are honored to have you here, sir.
Thank you. Can I start? Yeah. First and foremost, I would like to thank the team who has worked behind this conference. I understand how much effort goes on to organize a conference like this. So, Shishir and colleagues, thank you very much for inviting me. Well, after that wonderful lecture of Amaya, let's take you to intracoronary imaging. So, this is how an angiography looks. I'm sure most of you have seen this. There is a, can I have a laser pointer? No. Which one? How?
Red dot.
So if you can see, there's a lesion, there's a balloon, stent, and that's how an angioplasty is done. So this is what it is. So please understand, coronary angiography is a two-dimensional imaging. If you ask our experience right now to understand coronaries, angiography is a very poor modality, especially in proximal vessels and in the left main. Earlier we used to do, but we used to end up in problems also. But now we are going ahead to understand what is the actual anatomy, pathology, and how do we do it. So we started doing intravascular imaging. So why coronary imaging? We have four modalities of imaging right now. One is CT, angio, I'm sure about it, all of you know about it, then angiography, IVUS, and OCT. So we have evolved. CT gives the image which is 600 microns, and as you can see, it's not very clear. Then came angiography, and you see this image gets better, but not as good. Then intravascular ultrasound. We have two ways of imaging the coronaries. One is intravascular ultrasound. Second one is optical coherence tomography, OCT, which is actually used by ophthalmologists. Then cardiologists adopted that, and then we do imaging. So you see from a high definition black and white TV, it has become a high definition color TV over here. So what you can see here is 100 microns now. OCT gives you very, very clear imaging. However, every modality has got its own beauty and own interpretation. So this is a console, how it looks. This is a OCT console. I'm not getting into all these details. How is it done? It is done like an angioplasty. The only thing is, when you put a OCT catheter, this is you can see this OCT catheter coming in now. And once you put the OCT catheter and the imaging is done, you inject contrast and then you grab the images, and that's how you get the images. So this is how a typical OCT image looks. So I'm taking you back to the anatomy days. So that is the imaging catheter, how it looks. Then you have the vessel. This is the vessel. This crescent shadow over here is the wire, which is on which the imaging catheter goes, and that is the lumen. This is the lumen of the vessel. So this is how very clearly you can see that. So if you remember, we can make out the intima. Media is the black kind of lace which you can see over here, black ring. Then adventitia is beyond that. So intima, media, and adventitia. This is how imaging looks. So then once you get these images, you start interpreting the images. So we are classified into backscatter, attenuation, composition, texture, edge. So these are the images which we see. I'm not going to get into details, but I'll show you some images and how the interpretation is done. We not even get a transverse image, we get a longitudinal image also. We get a longitudinal image. You can see these branches over here coming out. You can see the calcification, and you can see the length of the vessel. So transverse mode, and this is called as an L mode. This is called as an L mode, where you can actually see the length of the vessel, the disease segment, and where to position the stent. So imaging helps us to understand the diameter of the vessel, the length of the vessel, the morphology of the disease, and when you put a stent, whether the stent is being deployed properly or not. So all those things helps us very well. So you see the distal and proximal markers over here, and then you mark those distal and proximal markers, and then you see the depth indicator, and then you calculate your stent length, diameter, and all those things. So microstructure imaging also, the most important thing is for interventional cardiologists is calcific plaque, fibrous tissue, and lipid pools. This is the main pathology what we have to understand when we do an imaging, because everything needs a different way of addressing the case. So this is a big three. That's how, if you can see, this is like a calcium island over here. These are calcium islands. This is a fibrous tissue, and this is where there's no backscatter behind, is a lipid pool. That's called as a lipid pool. So I'll show you some images, so that will make it more interesting. Now, fibrous tissue, so how does it look? So clearly, this, if you see, this is the medial black lace adventitia, and this is intima. You can see there is a gap between the media and the lumen, that is called as intimal thickening. So that can thicken so much because, and it becomes a fibrotic plaque. That's what causes the stenosis of the artery. Calcific plaque, as I told you, is a very well-defined edge. Can you see this well-defined edge over here? It's a calcium plaque, or what we call it as calcium stone. And then sometimes the calcium protrudes in the vessel, which is called as nodular calcium. So these are the calcium in the vessels. Now there's a whole new dimension of treating this calcification in the vessels. All these things are very important because we have to choose the device accordingly. Otherwise, we will not be able to do a proper angioplasty. So if you can see image comparison between intravascular ultrasound and OCT, this is how a mild calcification looks. This is a 2-quadrant calcification or a 3-quadrant calcification called as moderate calcification. Then there is a circumferential calcium, which is 360 degrees. So you can see the acoustic shadows over here. These are calcium, and you can see the reverberations behind. So those are the reverberations produced by the imaging, and then you calculate the thickness between the acoustic shadow and the reverberation. And in the OCT also you can do the same thing. Then you can make out a well delineated boundary, which is called as a calcium arc. This is called as a calcium arc. So as I told you, this is nodular calcium, which is protruding in the vessel. This is a circumferential calcium. Look at this. The whole artery is calcified. You might have heard somebody using a cutting balloon, rotablation, and IVL, laser, all those things. So this is a circumferential calcium where I would go with the intravascular lithotripsy. And this is a deep calcium which is beyond the adventitia, where cutting balloon or some other device must be used. A lipid pool, as you can see a distinct edge over here, but there is no backscatter over here. So this is called as a lipid pool. You have to be careful not to end up your stent in the lipid pool because the restenosis is very high. So this is how different morphology look: lipidic, fibrotic, calcific, and severe calcium, which is 360-degree calcium. Accordingly, we use a stenting, compliant balloon, non-compliant balloon, atherectomy devices, and so on and so forth. We can also make out from imaging red thrombus and white thrombus. So here in this situation, we had this patient with acute MI. Red thrombus is most of the time is an acute situation. As you can see, there is a high backscatter and an edge which is very, very high. So this is called as red thrombus, which is seen in these 3 images. And in chronic situations where you can see a white thrombus, where it has got a low attenuation, and sometimes you get this lotus petal kind of recanalized, chronic recanalized arteries, which has got white thrombus. So we can make out red thrombus and white thrombus also on the OCT images. Then once you put in a stent, this is how the stent marker looks. Look how nicely the stent is embedded in the intima. And if the stent struts are floating like this, look at the struts floating like this, that means the stent is not opposed well. It is malopposed and it's under deployed stent. So you have to go take a bigger balloon and deploy the stent properly. We had earlier dissolving stent called BVS. That is to look like a box kind of appearance. box kind of appearance over here. These are called as the dissolving stent, which are not available anymore. So the stents get endothelialized, the layer gets formed over there, and there completes the healing of the stent, and then the stent sort of becomes embedded in the vessel wall. So when you follow up these patients, you can follow up, you can do an imaging, and then see how the stent is doing. Another important thing of doing an imaging is look at the dissection of the vessel. After doing the balloon, there's a big dissection of the vessel. There's a flap over here, which is going from the intima and extending all the way to the adventitia. So these are big dissections. These dissections has to be covered if you're putting a stent. So make sure all the dissections are covered. So various types of dissections. There are small intimal dissections. Then there are medial dissections. And sometimes the dissections are so huge, there can be a false passage and intramural hematoma can be formed. All can be seen on imaging. So you can see that after angioplasty, the vessel wall is damaged over here. So you need to put another stent and cover this sort of area. This is very important. It's called as TICFA, thin cap fibroatheroma. You can actually measure the layer on the plaque. If the layer on the plaque is less than 65 micron, it's called as vulnerable plaque. So in the vulnerable plaque, you have to cover it. When you're doing an angioplasty, you have to cover this. If you don't cover this, then chances of restenosis and acute events are very, very, very high. So all these things we did not know when we were doing routine angioplasties, but once the imaging has come, we have become good enough to understand all these things. This is a large intramural hematoma which has occurred over here. This is a true lumen. True lumen is getting compromised. There's a big intramural hematoma, and then this hematoma should be drained or put an additional stent over there so that this disappears. So neointimal hyperplasia. See, stent restenosis is a keloid formation. For example, if I get a cut or if somebody else get a cut, my healing can be, after suturing, my healing can be very thin disappearing line, but somebody can form a keloid. So while doing an angioplasty, we injure the vessel, we put a stent. The healing depends on particular person. So in-stent restenosis is nothing but a keloid formation inside the stent which has been injured earlier. So in-stent restenosis fortunately is a single digit right now. Is almost less than 5% in a non-diabetic and 10% in diabetic. So various type of in-stent restenosis can be seen, layered, patchy, and sometimes speckled also, where a lot of calcification occurs in in-stent restenosis. So what is the advantage of doing intravascular imaging? You know the morphology, you'll know the length of the lesion, you'll know the diameter of the lesion, and once you do angioplasty, once you put the stent, make sure your stent, there's no edge dissections, the stent is opposed well, and the stent is expanded well. So this is how morphology you can make out. You can make out the length so that you take the perfect size of stent. There's no guesswork over here. Everything the machine tells you, and then diameter also it tells you. So then you can see what is the length and diameter you can use. So it has got this program called as MLD Max, which you do, and then you can see that after doing an angioplasty, make sure there's no edge dissections, the stent is opposed well, and the expansion is good. So if you don't achieve all these things, then the restenosis and MACE, that is major adverse cardiac events of the patient, remains high. So IVUS and OCT comparison, that's how it looks. So IVUS takes a little bit of learning curve because the images are slightly difficult to understand initially for at least 10-15 cases, whereas OCT, as I told you, is high definition color TV, so you can understand it very, very well. That's how the, that's how the calcification looks, 360-degree calcification. Here you can see the islands of calcification, which is 360 degrees. Fibrotic lesions, that's how they look on both the images. And stents, overlapping stents, you can see 2 layers of stent here. Here also you can lay two layers of stent. So everything can be visualized very, very nicely. And in stent restenosis, if you can see that these are stent markers, there's a growth of tissue between the lumen and the stent markers. That is called as in-stent restenosis. I'll show you an example how it is done. So this is how the screen looks to us on the OCT. You get 3 images. One is the angiography image, one is the transverse mode, one is the L mode, longitudinal mode. This is a stent which is deployed. Now I've deployed this stent. Now I want to know how this stent is doing. So you can see all the three images start running over here. You can see the white marker moving up. That is where these two markers are there. And you can see this white marker is going up. And this is showing in both the modes. Now we come to the stent edge. I want to run this film so that you can understand. You can see the stent edge. You can see the stent edge over here. There was a small dissection at the edge of the stent. Once it goes like that, you can see the expansion of the stent. You can see the area whether it's done or not properly. So you get all these three images and it shows a perfect result whether you achieved or not. Or to make it more, this is called as like, it looks like an upper GI endoscopy. Thus, you can see inside the stent. It's called as fly-through. Now you can see inside the stent whether it is well opposed or not. As you can see, you can go in, you are seeing inside the vessel. You can see the side branches, whether they're open or here. Look at the side branches, nicely open over here because the wire is going in there. So these are fly-through images and you can see the stent from inside, outside, bifurcation, 3D bifurcation and so on and so forth. Even a complex intervention like this, you can see the side branch over here is open so that you don't have to worry. You don't have to do anything. If there are studs hanging around in the side branch, you take a balloon and open it up. So IVUS is also important for left main because ostium of the left main is imaged very well with intravascular ultrasound. OCT needs a little bit of modification. So for left main, ostial left main, I prefer to use IVUS, which can calculate the plaque burden and all those things. So this is the IVUS in the left main. We have to achieve all those measurements. I'm not going to go into details. So IVUS is important in left main intervention because it improves your understanding of the pathology and determination of the extent and distribution of atheroma, location and involvement of the ostium of the left main, and optimal stent expansion, and identify and treat complication. So, SLE intravascular imaging is see with clarity, treat with certainty. Thank you.
Any questions?
By the way, I think that this hospital has got both OCT and IVUS. Both the imaging are there in the very good. I don't think so any of the hospital in Mumbai has got both the modalities, but you have both. Thank you.
Thank you, Dr. Anand Rao.
Very good, very good. Yeah.
Now I request our chairperson, Dr. Krishna Kumar sir, to honor Dr. Anand Rao with a memento as a token of appreciation. Thank you, sir. Now I would request Dr. Ashok Kumar sir, CSS JRH, to honor our chairpersons, Dr. Krishna Kumar sir and Dr. Mansingh sir, with a memento as a token of appreciation. Thank you, sir. Now we will have Dr. Fanidhar Memorial Oration. I would request Dr. Anil to come and continue with the scientific session.
In the respect of our first DG, that is Fanidhar sir, we always and every time when we do the conference, the SAMO or any annual conference, we remind him or give our tribute and respect to him. On the memory of him, Dr. Anil is going to have few words for him.
Good afternoon, respected seniors and my dear colleagues. It is a great honor to say a few words in the memory of late Dr. Fanidhar, who was instrumental in setting up the Department of Gastroenterology at Jagjivan Hospital and making JRH a multi-speciality referral center, which it is today. Having done his master's in internal medicine from KGMC Lucknow, he worked for a few period in All India Institute of Medical Sciences, New Delhi. He chose gastroenterology as his area of interest and pursued it further by training at various institutes at the United States of America, namely Harvard, Massachusetts, and the Boston School of Medicine. He joined the Indian Railway Health Services in December 1973 and served in Western Railway for many years in various positions, namely MS, CHS, and CSD. He became the Director General of Railway Health Services in 1995 and framed the IRHS mission statement, which is and will be a benchmark for many generations to come forward. He remained in this position till he superannuated in the year 2000, and his great soul departed this world following a tragic road traffic accident a year after his superannuation. During his tenure in Western Railway, his unique style of functioning, his clinical acumen, and his way of handling the administrative matters was widely appreciated, and he was instrumental in setting the DNB program at the Gastroenterology Center in Jagjivan Hospital, and also authored various scientific papers in national and international journals and in chapters in various textbooks. Over a period of time, the Department of Gastroenterology has progressed in leaps and bounds, and today we aspire to continue his dream to achieve professional excellence and serve our patients with the best of our ability, with enthusiasm, care, and a humane touch. Thank you so much.
To this honor and to remind him, and by name of his, we are going to have oration lecture, and it not other than by Dr. N. Pratap Kumar. He is Managing Director and Chairman of Chief Intervention Cardiologist in Medintra Group Hospital. He has done maximum chronic total occlusion, that is CTO intervention in India, and has done maximum retrograde CTO intervention in India also. We are proud of him. And started his first cath lab in any ESI hospital in our country, that in 2013. Started cardiac center with cath lab in the civil hospital in Haryana, that in 2017. Started first cath lab in the country in Maldives. Trained as many as 60 to 70 cardiologists so far as the coronary intervention is concerned. Proctored in many hospitals, including 9 medical colleges and 16 states in India. Proctored many coronary intervention in 16 countries. He has been the course director for IJCTO, that is Indo-Japanese CTO Club in India, 2013. He is the chairman of National Intervention Council of India twice, the 2022 and 23, and the president of Intervention Cardiology Council in Kerala, the 22-23, and organizing secretary of SACCI 2019 and SKIP 2022. With this amount of introduction and with regards, I invite Dr. N. Pratap Kumar to deliver his oration lecture. Welcome, sir.
Respected DG, all PCMDs, the medical director of Jagjivan Hospital, and my close friend and the man behind the story of this program, Dr. Shishir Rao, and all the delegates sitting here. I have a relation with the railway hospital way back in 1995 when I was doing DM cardiology in Trivandrum Medical College. I went for a training for just 1 month under Dr. Abraham. He was the renowned interventional cardiologist in the country and a teacher. Number 2, in the last 3 years during the corona and just before, I came to Jagjivan Hospital minimum 3 to 4 times. We did a lot of training program along with Dr. M. Reddy and Shishir Rao. That is the relation started. When I was the NIC chairman, when I was doing IGCTO in the country, so we have done 4 live cases to the national meeting from Jagjivan Hospital. Along with the international operators, even I did a live case from there. And actually we are doing a national LMC registry. I just included this hospital also for the registry. With these words, actually I know that this is a mixed crowd, and CTO means chronic total occlusion. I don't want to make you boring. It is actually a talk which is actually done some activities by me in a different way. You just can look at. I just divided my talk into 3 parts, and I asked Shishir how many minutes talk. He told 40 minutes. Actually, I told that as a politician only can talk. But let me try to talk in 30 minutes without making you bored. That is what is my try. If you are actually getting bored, you just give a clap and I'll stop it. Just I will make it 3 sessions of the talk, and the first 2 sessions are basically for the non-medical people, and the last part is my own journey. The CV burden of the India and present situation in the country and my CTO journey. I don't know, the slide is not moving. Okay, the cardiovascular burden disease. It's a leading cause of death and disability in the world. It's responsible for the 32% of the all death and 15% of disability adjusted life years globally in 2017. In the year of 2017, it responds for the 27% of the total death and 14% of the total loss of life in India. It's actually a nearly 2 to 3-fold increase, annual increase from 2016 to 2019 to 1990 to 2016. It causes the major death in India. What is the problem? It's the number one cause death globally and accounts for 1 in 3 death globally and accounts for 26% of the total adult death in India. If you look at the numbers from 1996, that is a 40% growth when it has happened in the US, in nearly 110% growth happened in India. What we should look for? Actually, if you take the population of the US, it is actually 33 crores. Actually, in India, it's 142 crore. In US, they do 1 million angioplasty. If you are actually seeing in India, it is only 0.8 million angioplasty. If you take the number, if you translate the same number to US, we should have minimum 8 times the number of angioplasties what is happening in the US. That means we should have minimum 6 million angioplasty should happen in India. The exact calculation is 6.5 million. So cardiovascular burden is divided into many things, and we've just looked into this is actually the major burden. Actually, the cardiovascular disease is the major cause of death. If you look at these states, the maximum happening in Kerala, actually from I am coming, Tamil Nadu, Maharashtra, and then Punjab and some of the areas of West Bengal. So the global burden is actually 272 death per 1 lakh population, which is higher than the global average of 235. That means India has the highest death rate in the world. And if you look at the economics, we will be losing $4.58 trillion in up to by 2030, actually, which is actually the maximum loss to the healthcare in by 2030. And if you look at that data, 2.17 trillion is only for cardiac disease. And the second one is coming as the mental health, which is 1 trillion. So the CVD, actually, what is happening in India? It is actually a premature death. High relative risk burden, early age of onset, higher rate of fatality, and higher premature death happening in India. Why? We think that the rich people are affected. No, the poor are affected more. 30-day mortality attributable to the coronary syndrome was 8.2% for the poor in comparison with only 5.5% for the rich people. Probably because underdiagnosed and underreporting. And actually, why this is happening? If you look, the South Asians have a higher prevalence. A population level change or inherent biological risk may be the cause. What are the things? Epidemiologically, all states of India, with the predominance of non-communicable disease as number 1, not the communicable disease now. Demographic shift, an increase in the life expectancy of India from far away, that is also number 2. Number 3, a nutritional transition, decrease in intake of healthy foods like cereals, pulses, fruits and vegetables, but we have increased risk of meat products, processed food. That is actually happening a problem. What is really happening? We think that vegetarianism is good. No, Indian vegetarianism is different from US vegetarian. Indian vegetarian diet is rich in carbohydrate, high in fat, poor in nutritional quality and protein. When you look at the US vegetarian, they are more consistently healthier food habits intake compared to the South Asian vegetarians. What is the socio-economic status? Shifting to more industrialized country, India, and actually we will have a lot of sedentary life like Dr. Shishir and Dr. Pradap doing. So we have high chance of decay. What is the environmental transition? Mumbai, Delhi, the deteriorating ambient air quality. That means a recent risk factor for the high prevalence of cardiac death in India. Basically, if you look at the Delhi and all, we are actually doing a trial by the CSI for the pollution relation with the heart disease. The policy changes. If you put a policy that 20% extra money for the sugar sweetened beverages, then our income will go up, disease will come down. If you actually moderate reduction in salt intake, again salt, you can increase the price, the salt intake will come down. And the lastly, the smoke-free legislation, if you come, definitely the health system will be improved. What is the future direct? Establishing a robust surveillance system. India needs a better surveillance and reporting system which is not there in the country. What is really happening? You can have a primordial prevention care, you can have a preventive primary care, you can have a preventive secondary care, and you can have a preventive tertiary care and a preventive cotton in the hair. Then I go to the preventive quaternary care in the country. I will analyze the data of the National Interventional Council. This is my second part of the talk. If you look at this, you just look at the diagrams. We have the maximum number of cath labs available in Maharashtra, but it is available in 5 corners of the state. If you look at that, Mumbai, Pune, Nasik, Nagpur, Aurangabad, finished. If you look at Kerala, we have 182 cath lab with a 3 crore population. It is confined from hilly area to the sea shores. Everywhere it is there. So that is actually 2,227 cath labs, which is actually occupying 3.5 lakhs population for every individual country. If you look at the coronary interventional data, Maharashtra is number 1. Number 2 is Karnataka. Number 3 is Kerala. This is actually the like the angioplasty happening in India. That's 2022 data I'm telling. If you look at this one, actually the male to female ratio, still females are depressed or females are suppressed by the male population. They are not treated properly. 67.9% of the people are males are treated in the country when 32% is female treated. If you look at the age less than 45, age less than 40, 12% of the people are getting heart attack. Age less than 40 and more than 70 occupies the 19% of the intervention in the country. If you look at this one, the scheme, how it is people are just taking, they are from the pocket payment is only 30%. That is actually money goes to Anand Rao and the people here. And the poor people from Kerala, we get all the government insurances. We actually look at the CGHS, Ayushman Bharat and government schemes. The Ayushman Bharat actually take care of 27% of the intervention in the country. And we will think that CGHS, ECHS and ESI, that is actually a minimal number. If you look at this, diabetes actually high prevalence in India. Nearly 45% of the population have diabetes. If you look at the complex angioplasty, which totally comes to nearly 10% of the interventions in the country. These are all not important for you. Imaging, as you told, Anandra was specifying that you have an OCT and IVUS. Even my hospital has OCT and IVUS. But when I came to the railway hospital for doing workshops, I was really shocked. They have everything. And not only that, the attitude of the cardiologist to work from morning to night, that is actually a tremendous level. I will not tell that only thinking that availability is not the point. I go to many medical colleges. They will actually, by 2 o'clock, they are restless. They wanted to go home. And I was actually asking Shishir, do you have a private practice? He told, no, sir, actually, then I will be thrown out of this place. And you tell, actually, I clearly told Shishir, when you are thrown out, if I get a job like a visiting consultant and make money in Mumbai, I will be happy to come. He told he will never be allowing me. Actually, because the DG is sitting there, I think I will get a chance to work here. I will just casual statement. Imaging is available only in 6% of the intervention in India. So you just understand that railway hospital has both imaging modality. They are using nicely in this country. And you just look at the TAVR. I don't know how many TAVR they have done. The estimated number is only 2,400, which is very low in India. Now comes to the third part, which is basically showcasing my skills and knowledge to you. Don't feel bad, and this is actually, I prepared this slide. Actually, this was my slide to present, but I thought that because the crowd is different, I will show something different. I will just start my CTO journey. CTO means chronic total occlusion, which is one of the real complex situation in the country, in intervention, which is many people are not interested, and most of the people with a CTO goes for bypass surgery. I actually attempt everything, and many people ask me that you have a cardiac surgeon in my hospital. Yes, we have a cardiac surgeon, but no cardiology patient is sent by me to the cardiac surgeon. That is very important. So I just obliged to 2 cardiologists in the country, that is Dr. JRHCON. He was an excellent cardiologist, and these 2 teachers, 2 mentors who have ignited my mind and spirit. The teaching are the compass of my journey. And forever indebted for my profound knowledge and values I have inculcated into my life by these 2 great people. Presently, I am a part of all these CTO programs in the world. Not only in India, I'm actually part of almost all CTO programs. But you look at the road was outwards. In 2003, that is 20 years back, I did the first CTO intervention in my life. But my concerns, that time everybody was telling it is an unethical practice. Around my knowledge and skill, I never thought it was wrong performing CTO, even though people told they were deemed unconventional, unethical, and unfit for practice. Overcoming the skepticism, it was challenging, and acceptance of CTO procedures remained limited in the early stages of my life. That was in 2003. My journey so far, in 97 I completed my DM cardiology. I actually did my first LMC intervention in 2002, my first CTO intervention in 2003, and I did first septal ablation in 2003 again. And I did my first carotid angioplasty in 2006, my first live angioplasty at Belgrade out of India in Serbia in 2008, 2007, and my first retrograde CTO I did in 2007. Organized an IGCTO in 2016 and 17, and multiple live cases into India and out. So this is actually the I trained intervention after my training in intervention cardiology. I did my fellowship. I completed my fellowship under Dr. Jagjivan, one of the most renowned cardiologists globally and head of the interventional cardiology in Turin, Italy. A significant turning point in my professional career from non-invasive to invasive practice. And acquired expertise in complex intervention. I actually learned I was in 2001. That time, after that I never used for 15 years and then started using only for the last 7 years. Then I started my practice in medical trust where actually I have done, there was actually the first transplant in Kerala happened in 2002. Again, that patient was actually given by me to the cardiologist. But in return, he gave me the first left main angioplasty to me. Actually, the largest data on left main angioplasty was actually published by me. Luckily, this was actually in Indian Heart Journal. That is the largest number. I went to Bangladesh. You will think that Bangladesh is a poor country. People told that, why you are going to Bangladesh? I calculated the crowd. It was that time it was 15 crore population in Bangladesh. If you look at the number of 15 crore, I was asking how many people can afford treatment? 20%. 20% is actually 2.8 crore. That was actually more than Kerala population. In Kerala, the affordable people, even if you take 35% or 40%, I calculated it was only for 45 lakhs of people. And then I calculated 2.8 crore is better or 4.45 lakhs. Then I went there, I did the first angioplasty, and people thought Bangladesh is a poor country, but 20% of the people are having BMW car that time when I have only a Maruti 800 car. So in a short stint of 6 months only I did there, but I'm proud to have initiated the primary angioplasty program in that country and the LMC intervention in Bangladesh. I performed my first CTO intervention in my life actually as an independent operator in 2003. Then actually 2003 to 6, I started my career in a cooperative hospital. The first cardiologist to do any intervention in the cooperative sector is luckily me. That was in 2003. And I faced the most criticism during this period for interventions of LMC and CTO, which were told unethical at that time. And it was a tough phase, but I never stopped my perseverance as I believed these procedures brought significant benefits to patients. That's the same perseverance I see in Shishir when I come there. Actually, he is enthusiastic to do the new things and everything. And he tried to call everybody to learn. Actually, that is which I was there in 2003. That is why I like him. This was an angioplasty which was actually a double CTO, was never considered for angioplasty that time. This was in 2004. And I did both the cases. But this is actually, today I would have used a lot of new materials like microcatheters and guide wires, which was not available that time. The wires then was a Choice PT graphics, Shinobi. These workhorse wires will never be heard by people nowadays because these are all not available now. So no microcatheters, only OTW balloons were available that time. I was doing angioplasty of CTO that time with that. Then I went to the case 2, the 2005. This lady has a 100% block left main. You cannot imagine in 2005 I did this case and attempted this case without a mechanical circulatory support. Patient was very poor and there is no schemes like CASP. That CASP means Kerala we tell Ayushman Bharat is CASP because communist people, we change every national program done by Modi to our own name. So we tell it's Kerala Arogya Insurance Pathadi, not like Ayushman Bharat. So there was no CASP or ESI scheme in Pariyaram. So the surgeon was not aggressive, and we started the first scheme of doing angiogram at 5,000 that time in Kerala. So this did a angioplasty. Patient survived and discharged in a very stable situation. But I presented this case in the 2006. Then everybody told that, why you did it? I told you should have, I would have allowed this patient to die. There was no MCS, and everybody told, even after patient survived, they criticized, and they never appreciated me in 2006. That never stopped me to do that. And now I went to the Manipal Hospital, Bangalore in 2006. I should understand that actually during that period, I started training people that time. Then I did my first carotid angioplasty during that time. This was one of the cases, a short CTO segment. Actually, I'm talking about CTO, and it is filling through the other vessels. So what I did is actually, money was never a problem in Manipal. Manipal name itself is indicate there is no money problem. So I could have used any material, but microcatheter was not there even that time. So I could use anything, but then without microcatheter I finished. This was my going back to Kerala again. My first retrograde CTO PCI I done when in 2007. And performed the live case from Belgrade, which was an accidental chance that Dr. Matthew Samuel and Dr. Ashwin Mehta was supposed to go there. Since Matthew Samuel was not well, they were actually looking for somebody who can just replace him in short period. Even though they were not bothered knowing about my knowledge and skill, but they gave a chance. But I did my first retrograde CTO there. Then they started appreciating that. And I did the first live angioplasty transfer Trivandrum to Paris that time. I organized a conference called SACI, South Asian Complex Coronary Intervention, in 2009. You could see this actually, these are the people like Luwad, JRHCON, Thomas Isinger, Asakura, Vasan Udayachalam, OCA. These people are all brought by me first time in India. And this was actually inaugurated by the Marthandavarma Maharaja. He is actually the last Raja of Travancore. And you can see Yeshoda sitting there. He was actually inaugurated the charity program, for which he asked me for 2 flight tickets. So charity will be inaugurated by the politicians and the film actors, but they will ask for money for inaugurating the charity. That is the tragedy of charity in the country. So actually this case was actually I have done. Interesting part of this case, the patient has a creatinine, very high creatinine. You should understand I opened the vessel, but we should understand that this case I have done the complex CT intervention, a ostial LED CT intervention with ultra low contrast PCI. That time I was not knowing this is very important. In 2017, a person published this data. Then only I came to know that I was doing this thing for a long time. Then actually, this is actually a case where complete occlusion of vessels and anomalous vessels. And I opened this vessel. I will not go into details because you don't understand that. Only 2 CTO wires where Asahi was available, Miracle series and Congress that time. I opened this vessel and only OTW balloons were used. But the advantage of this case was actually, this was actually wiring of done. Actually, I did a wiring with from the radial artery, no catheter was going. I just managed to take this one and then the angioplasty. This case I presented in 2011 in Turin. And there is maybe knowing that Dr. Lefebvre, he appreciated and got the best case award in 2011. And many coming. You should not stop it. Continue clapping. In 2009-10, actually making, because these are all things which I am telling, I did a heroism and all, you know. So how many people can be happily tell? I always, I was given a chance of talking about the business. I run some business and run a lot of centers. So the Tata people called me in Jamshedpur to give a talk of how the business can be done by a doctor. Actually, my topic I have given in failures in business. So I was getting clapping for every slide. So the failures everybody like. Then after that, I always tell you should never present success to the people, only present failures. That is the happiness of the people. So this patient, when I did angioplasty, the patient was totally collapsed. I think Shishir can understand that. Virus opened up, everything is not there. Severe compromise. That too, the patient's sister is the nursing superintendent of the hospital. So I was in trouble. If you fail that case, the nursing superintendent will tell everybody, all the nurses there, don't send a patient to this guy and practice will go. Luckily, I started doing a lot of things and compromise, and patient came back, and this patient survived. And I actually that time and all, everybody tell that these fellows are doing wrong things and you should have no check angios. So what I do is every patient, whenever I get a chance to do a check angio, I do a check angio after that. And this patient also, I did a check angio. People usually ask for follow-up in these cases. So when you try to do something uncommon things, so I actually do a angiogram of this patient exactly after 5 months. I did an angiogram. Angiogram was perfect. And I started Mediterranean Hospital in 2009. That is my actually hospital name. Somebody pronounced wrong Shishir. Shishir name is Mediterranean. It is actually a goddess name, you know, like hygienist and all. So 2009 is an Italian name. 2009 I started until 2022 I started 18 centers. I closed 6 and only 12 running. So when you start business, you will lose some biscuits, and if you are getting some gold, you should be happy with losing biscuits. I always do that. These are some of the snaps of my centers. And then in 2000, in a 32-year-old man, 3 triple CTO I did in one of my hospital in Jamshedpur. This is actually a story. I think some of the problem with the, I should have presented from my own laptop. This is one of the first retrograde CTO intervention I have done. I have completed more than 200 retrograde CTO. That is the largest number in the country so far. I started my CTO intervention not only in Kerala, also in Gujarat, Madhya Pradesh, Jharkhand, Jammu and Kashmir, and performed maximum retrograde CTO in a single day, 4 in number, not only in India, also in Philippines. I have written a book in Malayalam. You cannot, nobody, I don't know how many people, just 25 patient stories, which is actually, it's one of the Orthodox bishop sitting there and released this book. And I started the first cardiac center in Maldives. And this is actually one of the single catheter retrograde CTO intervention. We have done one case in Shishir, actually Shishir and M.V. Reddy presented that case in Singapore Live, also the same case. This is the largest number of single catheter retrograde in the world. I have done 15 cases of these type of cases. This is a very complicated case. And why I am just telling, there are all the multiple techniques are adopted. Many new wires are used in this case. And this, I got the best case award in JIM. JIM is actually, for us, it is one of the pioneer meeting in the world. It happens in Italy. This fellow is the best cardiologist, called the Antonio Colombo, and I got the best case award in that. Then in 2011, I started doing zero contrast angioplasty. I think you know that in kidney patients, when you use a lot of contrast, they will go into a bad situation. I do angioplasty without contrast. If I see an angiogram, completely blindly I do that. I have done more than 100 cases. That is the largest number in the world. And I do even absolute retrograde CTO. Yeah. So these are all done with the imaging. Actually, that Dr. Rao told you that we actually use things by seeing, by imaging. This actually case, I got the best case award. The best case award is not only the memento given by Shishir, it was 5 lakhs rupees also there. I don't know I will get to that or not now. Madam, actually DG is sitting here, and so she actually, Anand Rao, don't go because you may get some cash prize also from here. So I'm just making your life also better here. And I think nobody is giving a big clap for that 5 lakhs rupees. And then, thank you. So these are the new wires I used. Many of the new wires in a CTO, I am lucky that I got the chance of using these things. So these are all done with the help of imaging. I'm just showing some photographs. So what is my CTO practice today? I will always use double catheters. I use a microcatheter with fine cross, Cossae, Pro XS and Coravel. Microcatheter should be dual lumen I use. Lot of guide wires I use. And I had the privilege to use Gladius, Miracle Neo, Congress Pro ST, Congress Pro XS, Sasuke for the first time in India. And these are actually thanks to my knowledge sharing with this great personality. The first person sitting is Kato. He was actually thrown out of Japan when he started CTO. And he was actually in Germany for 2 years and stayed there, then went back to Japan. And he is the father of CTO in the world. And the second person, Gerald Werner, actually came to Mumbai with us. And the third one is the maximum money-making cardiologist in the world, Martin Leon. So these are the people I could associate so far. And these are all thanks to these great personalities in the world. in every man's obligation to put back into the world at least the equivalent of what he takes out of it. That is Albert Einstein. So you should actually, I started doing some of the activities. These are the activities. I started doing proctorship programs, national and international. I did proctors. I was actually making red lines in railway hospital because I was thinking yesterday only I changed the color into red, because otherwise you will think that when I'm talking in front of railway people, not mentioning railway. Actually, luckily I just wanted to keep railway in the top because I did the first proctorship in Coimbatore. So these are the places I did proctorship in India. I proctored in 16 states in India. I just wanted to complete all the 29, but some of the states have no cath lab still now, including 9 medical colleges and railway hospital, and trained numerous cardiologists. I did proctorship in many countries, the countries sitting there, including Italy, Germany, Serbia, Vietnam. Luckily, 16 countries I proctored. I wanted to make it minimum 25. And I did a first awareness program for the public. Actually, that it's a very, now I think the National Medical Council will not allow you. I did the angioplasty demonstration to the public in May 15, 2015 from Mediterranean Hospital in Kollam. Actually, I did the first OCT in Kerala in that program to the public. And I did a live angioplasty to the public. It was transmitted to the Asianet for 1.5 million people saw that on live. I started a Mediterranean Academy of Cardiology. Basically, this was started in 2020. Why? You know, because of Corona. Corona, I thought I should be active. I started doing virtual programs. That was the first virtual program in medicine done by any cardiologist. I started within 15 days after starting Corona. Then I started regular Center of Excellence program. Actually, if Madam allows, we can do one Center of Excellence program in Railway Hospital also once. We can call 15 to 18 cardiologists. They will be standing there. We will be using some more materials than you have to provide some more materials to train these people. They will not touch the patient. Only me and Shishir will touch. And they can see these things. And that will be one of the big things Railway can do. We do regular Center of Excellence programs started from 2018. I just continue every 3 months one program. And these are the programs. I actually got an opportunity to do a grand rounds in US, which is actually not allowed by these people without a US degree. In Pittsburgh, I went and did a rounds. Again, they called me for a rounds, and now Canada people also called me for a proctoring program. I impart knowledge by educational conferences. These are the conferences which I was part of the chairman or organizing secretary. This was the NIC I did in Ahmedabad and Hyderabad, not in Kerala. I am from Kerala. And this is actually Indo-Japanese CTO club which I am talking. We started in 2013. I was the founder president and the course director of the program. Till now it is going. 9 editions are over. The last edition was in Mumbai. And I just put some effort to offer quality care in underdeveloped nations. I did camp in Kenya. This maybe people will be knowing the place called Kilimanjaro. I went to Kilimanjaro. It's called Moshi. I did a camp. This is actually, I did a camp in Moshi with the radio program. And I just go to African countries also to train people. This is actually the JKCI is the largest cardiac institute in the East Africa. I went for the 4 or 5 times there to train cardiologists, performing PCI in Tanzania. I not only stopped doing these things, I saw politicians in many countries. Everybody after discussion, they will ask you, sir, how much money I will get. So I just stopped there. I went to Madagascar, Benin, Cameroon, Ethiopia, everywhere. Then I told that if you want money, you should find out somebody else, not me. Then I come back and I go to these countries to have relations and do some training programs. I started doing subsidized procedure course to the downtrodden. This is actually the public-private partnership I did in Haryana. We have done 30,000 angioplasties in the last 5 years at a cost less than, you should not hear the number, money, because then you will reduce the grant to the Shishir, 50,000 rupees. So by 50,000 rupees, we do a stent with an angioplasty in these places. So we saved 240 crores for Haryana. But this is not known to Narendra Modi. Otherwise, I would have got Bharat Ratna. Not because other people getting Padma Shri and Padma Bhushan for doing angiogram for some VIPs, but they never look at these numbers. This my CTO journey I started in 2003 with the first CTO, and 2023 I used all the new wires. This was my CTO journey. Actually, I should express my gratitude to my parents, allowing my path. for wholeheartedly supporting my journey and allowing me the freedom to chart my own course. They never interfered in my life. Wife, for the constant presence by my side, offering unwavering support in every endeavor. Whatever mistake I have done, she supported me. Teachers, for imparting the knowledge and skills that have paved the way for my career's growth as well as my success. My children, for sacrificing their desire to be with me as I moved around with my busy life as a cardiologist. Patients, my greatest tutors, for being instrumental in my learning journey from the very basics of intervention to the intricate cases I handle today. My friends, for the unwavering encouragement and belief in me, which has been crucial for me to reach the point where I stand today. Industry, for providing insights that have deepened my understanding of modern medical technology, enabling me to evolve in my field. Finally, I should forgive. I should actually get a forgiveness. I humbly ask for the forgiveness for any lack of my knowledge, errors in judgment, or inadequate skills in my part, which may have unfortunately led to the loss of some of patients' life in my career. And thank you very much. Success is not destination. It is incredible journey of challenges conquered, dreams realized, and the relentless pursuit of one's passions. Thank you very much for the patient hearing.
Thank you, sir. You just started with a smiling face and ended with an emotional tearful eye. Thank you. This proves, sir, you are not a good cardiologist only, you are a good human being also. And believe me, the blessings are invisible. There are a lot of blessings from the patients and doctors like us who you have trained. And I wish and I pray the God to have a good success and further happy life he had. So thank you. Now, it is a great time to honor our speaker, that is ORSN speaker, that is Dr. N. Pratap Kumar, and we are lucky having with us our DG Ma'am, Ma'am Sugandhara Ma'am. I request Ma'am to come to the dais and have a ORSN award here, momented to our speaker, N. Pratap Kumar sir. I'm really thankful to the farmer that the award was scholar, getting all the pain to bring Dr. N. Pratap Kumar from Hyderabad to here only. Please have a round of applause to Dr. Award Vascular. Now I request Dr. Pradeep Rana Vijay sir to have a few words before the lunch we start.
Good afternoon. Your kind attention, please. 22 e-posters are presented by postgraduate students are displayed on the fourth floor near the stall area. I request you to, all of you, to visit the display. I'm sure you would appreciate the efforts of the PG students and the mentors. Thank you.
All are invited to go to the food court that is on fourth floor in the ward 11, 12 and 13 in the old building. And as you, the session exactly started 2:10, I'm requesting everybody along with the chairperson to be exactly at 2 p.m. here only, please, because the speakers have come. So we'll start exactly 2:10. We are stick to the time only, please. Okay, thank you, ma'am. now we are going to head our third session, and this session will be chaired by Dr. Ashish Mukherjee sir, that is, he is PCMD East Coast Railway Bhubaneswar, and followed by, she will be joining with co-chairperson, that is Meera Arora madam, that is PCMD Central Railway. And now I invite the first speaker, Dr. Ajit Menon sir, to speak on the talk, that is Rocking Inside Europe. Now I request our chairperson to introduce our speaker, Dr. Ajit Menon sir. Please, sir.
Good afternoon, everybody. And with the permission of DG Madam, I think we should start the second session. In the first session, every topic was so interesting, and it was really, I came all the way from Bhubaneswar. I'm already feeling that this is more than worth it. It was wonderful sessions previously. And now, without further delay, because there are a lot of very, very interesting sessions are there, so I'll immediately just introduce and ask the speaker to start. Dr. Ajit Menon, interventional cardiologist practicing at Sir H.N. Reliance Foundation Hospital, Leelavati Hospital and Beach Candy Hospital in Mumbai. He has over 32 years of experience in interventional cardiology. He is a proctor for coronary intervention and intravascular imaging. He is a principal and leading investigator in multiple trials in interventional cardiology. He is also a committee member of the Madat Charitable Trust, which provides financial and logistical aid to cancer patients in Mumbai. Sir, I would just request you to kindly start yours.
Will this window go off or it will be there? Yes. So, show the thing, you're not showing the wrong slides. Keep it in a single presentation mode. Good afternoon, everyone, and thank you, Dr. Sishir and the organizers for giving me this opportunity. I'm going to talk on rocking the rock, that's angioplasty in calcified lesions. How does calcium make a difference to angioplasty? Calcium basically has a impaired outcome on any angioplasty, and it makes the procedure much more difficult and much more complicated in certain situations, and the outcomes in these patients are not as good as any other normal patient with a routine angioplasty. Now, if you look at the prevalence of calcium, when you talk about prevalence, basically the number of patients who have calcium in their arteries, and that is documented by different modes of investigation. A lot of trials have shown that over 50% of our patients who end up with us on the table definitely have calcium in their arteries, and they tend to have much more worse long-term results. If you look at the pathophysiology of calcified lesions, vascular calcification is a hallmark of atherosclerosis. What makes a difference is the location, density, and also calcium exceeds the cap for a thin cap fibrous atheroma. What is a thin cap fibrous atheroma? A thin cap fibrous atheroma is when the lining of the vessel becomes very thin and it becomes prone to rupture. And these are the patients who land up in complications and acute infarcts. There are multiple local systemic factors, including hyperlipidemia and large necrotic cores, diabetes mellitus, which worsens the incidence of calcium. And you have different types of calciums. You have intimal medial calcium, you have macrophages in the vessels, you have dense vascular calcification in stable plaques, you have microcalcification, which are microscopic calcium levels in the arteries. And there's something called as medial calcification. How does it make a difference? The treatment of all of these is different in different situations. What is good for certain situations may not be the best for treating certain other types of calcium. Why is it such a big issue? Because diabetes is more pronounced in patients with advanced age, diabetes, severe dyslipidemia. If you look at the 1-year complication rates or severe event rates, much higher with an increase in the calcium severity. And when you treat acute heart attacks or acute coronary syndromes, a lot of times you see calcium in these vessels also. How does calcium make a difference? When you have calcium in an acute heart attack situation, the treatment of that patient becomes much more difficult because the devices that are used to treat the calcium may not be the best option of treatment in an acute heart attack. And when you have calcium, you'll end up with situations where the stent may not cross, the stent may not expand, the balloon may not cross, and the procedure becomes much more complicated. So how do we approach calcified coronary artery disease? You need a diagnosis and a better technique. And in terms of technique today, we have a lot of things that you can do. You have lasers, you have lithoplasty, which is the latest one, which is basically using the same concept as is used in breaking kidney stones to break calcium. You have rotational atherectomy or rotablators. You have orbital atherectomy, which is a form of, again, another drill which does debulking of the calcium. So you remove the calcium before you try and open these arteries. Over a period of time, how do we detect the calcium has changed? Previously, it was basically, we have coronary CT angiography, which you all must have heard about the calcium score on a CT angiography. It tells you the amount of calcium on the coronaries. But does it tell you whether the calcium is outside the artery, inside the artery, in the middle of the artery? No, it doesn't tell you that. It just tells you a generalized calcium score. Then you have angiography. An angiography will show you a calcification when you see it on the screening techniques. Does it pick up all calciums? No, it doesn't pick up all the calciums. Almost 50% of calciums are missed by a coronary angiography also. Intravascular ultrasound and intracoronary optical coherence tomography are two techniques which pick up calcium on a much more higher level than a routine angiography. So even there are a lot of studies which show that angiography alone may miss detecting almost 60% of the calcium, and even an IVUS and OCT is not always, IVUS is not always so sensitive in picking up calcium. OCT has a little better definition of the calcium calcium pickup and the type of calcium involved and the density of calcium involved. These are two images. On one side, you will see the on one side you will see the IVUS image. On the other side is the OCT image of the same vessel. What you see here in white is the calcium. What you see here is a thick calcium level there. What we tend to find out is not only the level of calcium, but the arc of calcium involved, the thickness of the calcium involved, and the length of the calcium involved in these arteries. So how does it make a difference? It makes a difference in terms of the modalities of treatment. Without treating this calcium, without trying to break this calcium, you will never achieve a situation where your stent can expand completely. So in OCT OCT is probably a little better imaging technique in terms of finding out the extent of calcium. So that's an imaging of the artery from inside using a catheter, which has a camera at the tip of it, and it images the entire vessel from inside. And intravascular ultrasound is an ultrasound head on the tip of a catheter. Again, it does an intravascular ultrasound from inside the vessel. Now, once the calcium is assessed, you have different types of treatment in terms of various modalities. You can use either non-compliant balloons, high-pressure balloons, ultra-high pressure balloons. You have cutting balloons. You have rotational atherectomy or rotablators, which have been in use since the last 25 years. Orbital atherectomy is just come into the country currently. Intravascular lithotripsy is using balloons, using shock waves to crack the calcium. And ELCA is a laser technique to try and open up the calcium. I'll skip this slide for want of time. Now, in terms of an OCT imaging, it tells you the amount of calcium, and depending on what is the level of calcium, you can decide what is the mode of treatment that we use in these situations, starting with direct stenting to rotational atherectomy. Now, show you a few images and a few examples. This is a right coronary artery, and you can see that there's a lot of calcium. I mean, if you look at the images here, you can see a tremendous amount of calcium even before the injection is made. So this is a critical blockage, and in this blockage, you will never be able to get anything across. So here we try to use a wire. We get a wire down. We try to push a microcatheter to get it across the vessel. Nothing would cross. Eventually, we use a technique where we cross it with a microcatheter. We just keep the microcatheter at the tip of the blockage and use a drill or use a rotablator wire to get across. Once the rotablator wire goes across, we use a rotablator or a drill to clean the calcium first. And this is a drill, a diamond tip drill, which rotates at 180,000 RPM. The speed can be controlled from outside. It runs on nitrous oxide, nitrogen dioxide, nitrogen gas. It is turbine powered, and the speed there's a console which manipulates the speed. So this is a drill, a diamond tip drill, which cuts across the calcium. And once the calcium is cut across, then your procedure becomes much more easier in terms of stenting the artery, using a balloon, opening up the artery, and then using a stent to deploy finish the procedure. And this is these are various parts of the procedure in terms of how we do it, and this is the end result where the artery is fully open. Now, another example. This is a lady an elderly lady who came with unstable angina, had a cardiac arrest while being taken for bypass surgery. Subsequently, the patient refused a bypass surgery to get onto the table and was referred to us for an intervention. As you can see, there is a tight narrowing of the circumflex here, which is probably the culprit. She had a long disease of the LAD also. She was 80 years old. So, and with this recent cardiac arrest, we decided that we'll treat only the circumflex here and relieve her of her symptoms currently. But you can see, as you can see, there's a lot of the calcium at the level of the vessel, and typically this is the calcium on the other side of the vessel. Again, use a drill to cut across the calcium, and we do an OCT. Now, what does the OCT tell you? The OCT is these are OCT images, which tells you the inside of the vessel. It tells you where there's calcium. It tells you the diameter of the vessel. It tells you the extent of disease of the vessel. So it gives you a much more better measurement. And this is how an OCT run looks like when you use a catheter from inside and you run an image from on the inside of the vessel. So this is it tells you that there is a calcium nodule over here. There's significant calcium in the rest of the vessel, and you need to modify this much better. So we use a balloon to open it, but the artery is still not opened. So we try to get a stent across. The stent doesn't cross. You can see that everything is backing off over here. The stent doesn't get down. Subsequently, we use a balloon called the IVL balloon, which is a shockwave balloon. And it gives about 10 shocks per cycle. And the pressure inside the balloon is almost at 50 atmospheres. A normal car tire pressure that 50 atmospheres will be almost, say, 10,000 psi, pounds per square inch. So that's an extremely high pressure that you're giving into the inside the vessel. So we open up the vessel, and once you put the stent across, when you do an OCT again, it tells you various factors of the stent in terms of whether the stent is well deployed, whether the stent is underexpanded anywhere, the edges of the stent, and whether there's any dissection at any point of the stent. This was the final result, but however, the patient comes back in about 2.5 months with chest pain again, and we see that the stent has re-narrowed at the tip of the catheter, at the tip of the thing. So here we do an OCT and we realize that the stent had something called as a late malapposition, where the artery grew after the stent deployment, and the stent was floating inside the vessel. So there was a clot formation, and here the only thing that we had to use was a balloon, and use what is called as a drug-eluting balloon. Use it and finish the procedure. This is another lady who came in with unstable angina, and immediately after use of a drill here, there's a significant calcific lesion in the LAD and the circumflex, tight block in the LAD in the left main here. She had refused surgery for some reason, and the moment we drilled this, she went into cardiac arrest on the table because there was no flow down the artery. On massage, we got her out. and subsequently had to use high pressure balloons here to open up the vessel. And subsequently, at the end of it, we did an OCT which showed that there was significant calcium at multiple levels in the vessel. And here, again, we had to use what is called as a IVL balloon, the intravascular lithotripsy balloon, open up the vessel at multiple levels, and put 2 stents and finish the procedure. This was the end of the procedure. And surprisingly, you'll see one area here where the artery looks markedly dilated. That means the calcium plate is fractured, and the artery looks, it looks aneurysmally dilated. This was another lady who had again undergone an angioplasty and come back with a recurrence, and we found that there was a tight block. So the slides are not running properly. Okay. This is again another OCT run that you can see here, showing it that, and all this that you see around the artery here is all calcium. So here we use again an IVL balloon, and I'll show you some images after the IVL is cracked. You can see the cracks inside the artery. This is how the IVL balloon works in terms of creating cracks all over the vessel, dilating the artery so that the stents can be deployed in these vessels. Again, this was the this was the image after stenting. Now, this is another lady who came with who was a surgical turndown, refused surgery because the patient was very high risk for surgery, markedly obese, and again severely calcific vessels with a tight block in the main artery here. Here we used something called as a laser to cut across the vessel using a laser catheter. What does a laser do? It gives an energy which cracks the calcium to a certain extent, but also creates a pathway for other balloons and other procedures to be conducted. It is not a treatment on its own. It's only an intermediary to start off the procedure and help facilitate the rest of the procedure. So here we used we used a laser to cut across the vessel. And once we did that, we used a rotablator to cut across the calcium. But you can see that the moment we use the rotablator, the whole heart pumping goes down. The heart is hardly moving in this scenario here. So we institute what is called as a impeller support, which is a percutaneous pump to support the circulation. So this is the impeller catheter going in. This is the impeller, which is basically a pump which pushes out blood at about 2.5 to 3.5 liters per minute, which basically gives you the cardiac output, even if the heart goes into heart stops, or if there's a cardiac arrest, or if there is a ventricular, if there is an arrhythmia, which prevents proper forward ejection. So this is an impeller catheter inside the vessel, inside the LV, and so the motor is outside in the aorta here. The pump is outside. This sucks blood from here and sends it back across into the aorta. So the circulation is maintained. Once the impeller is inside, we use it. We continue with the drill. We continue with the balloon, and we treat the blockages and stent the vessels. And this is the stents being deployed in the two vessels, LAD and the circumflex. And this is the final result. The good part of this lady was that she had an ejection fraction of about 15 to 20%. This is about 3 months post-procedure. Her ejection fraction is back to about 35%, and she's back to normal mobility. So basically what I wanted to show in these images, in this talk and showcase in this talk, is that calcium is one of the biggest threats in terms of intervention, and one situation where people people have a little hesitation in treating blockages. Today, with most of the available techniques that we have for debulking the calcium, the procedures have been made much more easier. But I think it pushes up the cost of the procedure because these devices are expensive in terms of the pricing of these devices are involved. Thank you so much.
Thank you very much, sir, for the valuable talk. I would request our chairperson, Dr. Ashish Mukherjee, sir, to hand over.
Can we allow some questions?
Yes, sir. Sorry, sir.
If anybody would like to ask any question.
No, there's no reason why calcium deposits itself. We find people with young age having severe calcium. We find people with elderly groups having no calcium at all. I think it's basically the calcium deposits on the cholesterol deposits in the vessels. So those cholesterol deposits get calcified. Calcium per se is not the reason for the blockage.
Any specific risk factors like lipoprotein little a? Some people say that
it's a common risk factor for any coronary disease. It's not specifically for calcium. No.
And role of vitamin K2, they say that
debatable question. We have no studies on it. There are a lot of talk in different social circles and social media about vitamin K. Whether it works or not is something which is not a medical thing right now.
Thank you.
One question I wanted to ask, I've come to Bombay and I've realized there are a lot of people suffering from autoimmune disorders. What is the incidence of calcification in such cases?
I don't think we have any data on autoimmune disorders. I'm not sure whether we have any data at all on autoimmune disorders and calcification. And I'm not even sure that when calcification occurs there are certain disorders which have calcifications in, atherosclerotic disease and calcification in the main arteries, in the vasculature. If you ask me to put a figure to the extent of calcification or the number of patients, I don't think I have the data.
Because there is an element of inflammation across the board in autoimmune disorder.
Atherosclerosis is an inflammatory disease. So I would presume that if there is inflammation in other parts, the coronaries don't remain selectively immune to it.
Thank you, sir.
Thank you. Thank you.
I would request our chairperson, Dr. Ashish Mukherjee, sir, to hand over a memento of appreciation to Dr. Ajit Menon. Our next speaker is Dr. Nimit Shah, and he will be speaking on renal denervation therapy, recent advances. I request the chairpersons to give a short introduction to the speaker.
Dr. Nimit C. Shah is a, I think half of it is not coming here. He's a consultant interventional cardiologist in HN Reliance, Saifi, Beach Candy, Jaslok and Wokhart hospitals, qualified ALS instructor to teach and train in medical colleges, experienced in right heart catheter studies, complex coronary angioplasties, coronary rota ablation, coronary IVUS, coronary fractional flow reserve measurement, OCT, axima, laser coronary angioplasty. Have implanted first leadless pacemaker in West India. I request Dr. Shah to start his presentation.
Here is the announcement. All the delegates then need to give their feedback form to the MMC. So they have to deposit the feedback form. And in this session, at the end of this session, last session, we are going to have a simple quiz. That will be MCQ type. And that is a big award from first prize, 5,000, 2,000, 1,000, whatever. But 20 questions only. So please, everybody need to participate. And it's a good one. Okay, thank you.
Hi, good afternoon. Thank you, Shishir, and
thank you, the team, to invite me to speak on this bit novel therapy. Not much procedures done in India. There are few procedures done in last few years, in fact, last few months. So I'll give a brief review about hypertension and what is this new therapy offers in treating resistant hypertension. So I'll just go through the case first, then I'll speak about the data so you would realize how difficult the case was, how do you select the case, and why this therapy is important. So this is a very interesting case. Is a 43-year-old gentleman known to have hypertension and renal stenosis. So he presented with headache, chest heaviness on exertion in few days. So he was working for a cruise. So he was lifted, he went to USA. He was detected to have hypertension for the very first time in November 2022. He required admission for 24 hours. They did all the workup, ruling out secondary causes of hypertension, very rightly so. They found that he had a right main renal artery stenosis and had a renal calculi. So he was started there on nifedipine SR 60 milligram once a day. Family history, mother had diabetes, he was non-smoker, had alcohol occasionally. When he came to see me, he was tachycardic. His blood pressure still remained high with 198 by 117. And if you go to the investigation, so he was thoroughly investigated for that. So his cholesterol was high, ECG was normal, LV function was good, there was no left ventricular hypertrophy, so there was no cardiac damage. He had a CT coronary angio as well, which showed soft plaque in the proximal LAD, not much coronary artery disease either. He underwent 24-hour blood pressure monitoring to rule out whether he's got white coat effect. So that showed his average blood pressure was 191 by 118. And he also had a PECT CT to rule out pheochromocytoma. These all investigations were done while he was in US. So diagnosis was initially, when he came in, saw me, was accelerated hypertension with likely unilateral renal artery stenosis. So what was the plan? Low salt diet, optimized antihypertensive. I changed nifedipine to combination of telmisartan and amlodipine. And I did beta blocker because he was tachycardic. Otherwise, I wouldn't add beta blocker at the first 10s. So we said monitor renal function, let's check his electrolytes, nephro opinion for the renal artery stenosis, because if you find a renal artery stenosis, that doesn't mean you stent it, right? You need to prove there's a diffusion or perfusion defect, then only you can justify it, otherwise you can leave renal artery stenosis on its own. So nephrology suggested DTPA scan, which was done. So CT renal angio showed 90% stenosis in the right renal artery. DTPTA scan showed preserved renal function with compromised perfusion. So he went ahead and had a renal artery stenting in February 2023. Presented to me in March 2023 with headache. He's on multiple medications now, CTDTM, which is a combination of chlorthalidone, telmisartan, and amlodipine. Also, he's on beta blocker, ecosprin, Rosavel, glycomet, and a clopidogrel. His investigations were within normal limit. He also was diagnosed to have obstructive sleep apnea, so he was treated for that. Blood pressure still remained high in spite of 4 antihypertensive medications. His was 190 by 110. So once the patient is on 3 or 4 antihypertensives, namely your ACE or ARB, your calcium channel blockers, and a diuretic, then you label them as a resistant hypertension. So his diagnosis was now a resistant hypertension, and we all know the next step is to give an aldosterone blockade. So that is what we did. So started on spironolactone, also added mini-press, and said, okay, fine, he need to take a CPAP very religiously, and we'll repeat his 24-hour blood pressure monitoring after 7 days. So I see him again in June 2023, no symptoms. But what I did is I admitted him in the hospital, because sometimes it's very important you check compliance of this people, because they might not be taking medications. So we admitted him, make sure that the compliance was there. We make sure he was getting supervised medication. Nurses were making sure that he was taking the pill in front of them. So now he's on CTDT-AM, 3 antihypertensive, Amifru, Minipress XL, Muxavas, Presolar, and Corandil. So he's at least on 7 to 8 antihypertensive medication. Blood pressure remains 204 by 129. So clinical impressions, initially I said this was resistant hypertension. When the patient is on more than 5 antihypertensive, still not treated, you call it a refractory hypertension. So this is resistant and now a refractory hypertension. Then we said, okay, fine, we need to offer him something, because his blood pressure is not getting under control. We've done a 24 blood pressure monitoring, is fine. We've admitted him, checked the compliance. So he was thoroughly investigated, ruled out all the secondary causes of hypertension. Then we said, okay, fine, let's try, because renal nerve denervation had recently been launched in India. So he said, let's try a renal nerve denervation. So this is how we do. So this is a stent. has developed some mild stenosis. So these are the renal artery. So you pass a wire like you're doing an angioplasty, you pass a wire there. So here he has two renal arteries. There are accessory renal artery as well. So you make sure you have to ablate all the renal arteries. So this is the catheter. So this is the one. So this is a spiral catheter. So what you need to do is you need to pass this spiral catheter in each branches and ablate it. It's okay, I'll manage. Okay, so this is the spiral catheter. So there are 4 markers over here, and it's like a spiral catheter which sticks to the wall of the artery once the wire is removed. So you ablate in each branches. I'll tell you the difference because if you have heard, the renal artery denervation was launched in 2012. Then it was taken off because there were trials showed it was not much benefit, but there's a difference. The catheter is different and how we ablate now it is different. I'll come to that later. So you ablate in all the branches. So this is the inferior branch now. So you deliver the energy, that's 10 and 5 second on and off. So this is now the upper branch. So then you make sure there's no damage done. This is very benign. There's hardly any complication of this. But before you go to the other side, you make sure the arteries are patent. There's no dissections. There's no thrombosis there. Then you go to the left side. Left side also he has a double renal artery, if you see. So again, the same thing. You pass the wire. There's a catheter going over the wire. You go into each branch and ablate it. So I'll just skip this. Okay. So after this procedure, when I saw him in April, his blood pressure average was 199. It was 166 after the procedure. His daytime was 194. It was 174. Nighttime 185, 130. So he did have quite a good significant drop with this therapy. So April in probably 3 months' time. I saw him in October 2023. His blood pressure was 80, blood pressure 140 by 80. And I became very enthusiastic. Oh, wow, let me reduce his medications. So telmisartan 40, Betaloc 25, amlodipine. He did come back to me with a higher blood pressure, so I have to introduce the antihypertensive. Probably it was too early, probably I was more enthusiastic. So you probably keep them on the blood pressure medications for a few months and gradually wean it off. So that was a learning lesson for me. So looking at the data, so why is this important? We all know hypertension is very important. It's a silent killer and it's a global crisis. 1.1 billion of people suffer from hypertension all over the world. Less than 20% have their blood pressure under control. And this is expected to rise more into 2025. And nothing surprising, in India it's even more. So as I said, hypertension control rate in India, if you look at the reviews and all, it's significant, more than 17.5%. They hardly people reach their target. Less than 1/4 of the hypertensive patients have their blood pressure under control, which was the data collected from 2016 to 2020. So what are the barriers in treating hypertension? Lack of symptoms. As I said, it's a silent killer. Very rarely the patient would have a headache. Perceived disease severity of risk. We don't perceive this as a risk. Therapy, medication side effect, complex drug regime. So people would say, okay, fine, doctor, you start me on this medication, what are the side effects? They don't ask me when I have a chips outside with the salt, and they don't ask what is the side effect of the chip and the salt, but they want to know what is the side effect of telmisartan. So patient-related factors, communication barriers, poor understanding of the illness, because if they don't have pain, don't have symptoms, then don't realize the severity of the implication of high blood pressure on the long term. Socio-economic factors, cost concerns, cultural beliefs. They'll try a few other things, non-medical things as well. Health system, lack of health coverage, so we don't have a particular hypertensive society or particularly hypertensive clinic, like we all are physicians, so there's no dedicated hypertensive clinic, which makes a difference. So initially, as I said, it was way back in 2013, it was launched by Medtronic It's a fantastic trial which is known as a simplicity trial, which showed there was significant and sustained drop in blood pressure after treatment of this procedure. And once this was proved, there were a lot of companies coming up with the same thing. Around 20 products were into development. But then what happened in 2014, there was a trial which the blinded trial did not show any significant reduction in blood pressure in patients with resistant hypertension for 6 months. So this therapy died off in 2016. Then came that was Simplicity 3 trial. Then there were new innovations. What they realized is, because the catheter was straightforward, it was not touching the wall, so probably they were not doing complete denervation. That's one. Secondly, they were concentrating only on the proximal renal artery, and then when they look at the anatomies and they look the CT and MRIs and all, it was seen that what we are doing is we are denervating the afferent and efferent nerves. That is what we need to denervate. They found those were more confluence in the distal renal arteries rather than the proximal renal artery. That's the reason the new therapy came, where you go to the distal first, then come proximal, denervate all the branches, and then come proximal. So that was the difference they saw. And then the trials, everyone showed that this is probably a beneficial treatment. So I'll just skip this. So this is how, as I said, this is sticks. These are the knobs, and it sticks to the wall of the artery, so it can denervate the nerves very well. It's very simple to use. Very simple to use. Set up, just plug. Anyone can use it. You don't have to be even a cardiologist there, but you just need to know how to get the wire down. As a cardiologist, we are at an advantage, because when you look at the branches, you have to go various branches, because we do coronary intervention, we go to various branches and all, probably we would be probably more skilled to do it. One size fits all, you don't have to have a different catheter for different anatomies. So covers from 3 to 8 millimeter of vessel. Less than 3, you shouldn't do it. More than 8, it won't work. So there was a trial. So what changed really is, so initially the trial was just ad hoc. Here that they made sure they did the trial very well. They selected the patient very well. They randomized very well. The selection was done, compliance was taken care of, and then they were randomized to placebo and the RDN treatment. As I said, this is the proximal renal artery. These are the branches, and you see the nerves configuration is more in the distal rather than the proximal. So this was a new learning, and that is how the procedure was done, and it was successful. The same diagrammatic presentations. So there are battery of new clinical studies which is revisiting the sciences. There's a global simplicity registry, GSF Dian trial. I won't go into detail, which I've shown. It continues to show effect even at 2 to 3 years. So there was a spiral HTN trial with this spiral catheter in 2017, then 2018. So there have been at least 4 or 5 trials, more than 20,000 procedures performed with this Medtronic RDN system. And it had shown that the safety was evaluated. There were no adverse side effects, and there was even they controlled with the sham. They did the study with the patient on medications, off medication, and they showed the patient the drop in blood pressure was significant. So again, there was criticism of a trial. Some trials showed there was a drop of just 10 millimeter or 20 millimeter. Even when you start your antihypertensive medication, you don't see a drop of 40 millimeter. Right? It's just a 10 to 20 millimeter. So this is just another antihypertensive medication. And again, the time would say how long. We have a data of 3 years. Whether over the years also the data, the sustained drop in blood pressure is there, we'll have to see that. So again, you see there's a significant drop in blood pressure here. Minus 26, 32 at different trials what they have done. So I won't go into the trial detail. So if you look at the guidelines now, it says the use of device-based therapy is not recommended. That was in 2018 for control of hypertension, which has now changed in 2023. Severely high quality studies, including RCTs, have been published. They confirm that BP lowering efficacy and safety. Clinical consensus document was considered necessary to inform the clinical guidelines. and this then became 2B. It's still not 2A or something, but at least 2B guidelines, especially in this patient where you have looked after everything, you have thoroughly investigated the patient. I wouldn't use this as a first line treatment, but you have thoroughly investigated, there's no secondary cause, patient is on optimum medication, you check the compliance, you've checked all the side effects. I would use this as a last resort. First, because it's an invasive procedure and it's very expensive. Thank you.
Thank you very much, Dr. Shah, for your excellent presentation. If any questions from the audience, anybody?
Hello. I think I'm the only one asking questions. Okay. But since we are in railways and our respected DG ma'am is also here, all PCMDs are also there. A lot of cases, ma'am, come, and when we refer them to the cardiologist, and sometimes they say that this is the only last resort we have, whether we should go for renal denervation. And the cost being exuberant,
yes,
and which is not in CGHS rates. So we are in dilemma whether we should refer these cases or outright go for it or not. Because right now we have two patients we had. One of our cardiologists said that we should go, we should consider this for our patient. But then I'm confused. So if a lot of administrators there,
I think I'm sure they would ask you the question. I had similar patient from ONGC, right? There's a patient who had come. And this patient had come with recurrent coronary artery stenosis. And I said, you have already put 2 stents. You cannot put a 3rd stent within the same artery. It's definitely going to restenose, right? So I advised them laser, right? They did not have an approval, so I had to write a letter, and they got an approval. So I don't know whether it works in railways.
No, but we would
to
like
get a
to know
special
the
approval.
cost and then
Yeah.
if someone...
What is the cost of it?
5 lakhs for the
5 lakh?
catheter. For the catheter.
The total cost of the procedure?
Like 5 lakhs is for the catheter, and then remaining like is routine angioplasty.
So 5 lakhs, actually we have given approval for many interventions which are costing more than 5 lakhs. So Actually advance half payment. of a crore.
See, the issue is this, that these are one-off cases. They are not very routine.
No, this is as a last resort.
As
You
a
won't
last
use this as a
resort,
resort. So you have to justify, you have to prepare a proper case report.
Yes.
And get it
So,
approval. It's not ad hoc, like, okay, fine, patient has come to me, I want to use because I can use it, just do it. I think you have to properly, as you rightly said, because there's no approval, you have to have a proper case report,
Yes, yes.
get submitted and
So
get an
you
approval,
will,
should be easy.
You will be getting approvals for advance payment because these are the end of the road interventions. So properly justified, you will get approvals in railways.
Because this makes a difference. He's a 43-year-old, blood pressure, like he's got life to live, and with this blood pressure, he would have had either stroke or kidneys or cardiac event.
For the knowledge of everybody present here, what are the centers who are offering this renal denervation therapy?
It's a mobile event, so we can do it in railways as well. Like I can come as a proctor and help. Even the cardiologist here, Shishir can do it himself.
Any center which is well equipped for cardiology intervention?
Yeah. So it's a cath lab based procedure. So
Okay.
they bring the console with them.
Yes.
It doesn't have to be in a particular cath lab. It's a console, movable console. It can be done anywhere.
Okay. Thank you.
I don't reuse anything. So this is very. Yeah. So the company says not to reuse. Yeah. We don't know. Your balloons are not effective as well. We're using balloons, aren't we? Our rota ablation is not effective. The diamond burst cooled off. We're using rota ablation. Not we, but many people in India are using. So we are using things. I don't know how effective they are. So far, there's no reported events. They have done 20,000 procedures all over the world. So far, there's no event of dissections or thrombosis. So again, very good question. So we have got a data of 3 to 4 years. So far, not. Because we do give antiplatelets after that, to reduce the inflammation. The patient are on statin. So similarly, we use this laser rota ablation in coronary arteries as well. So they can get restenosis as well. It's similar to that.
No, but it is the whole
arterial segment you are going to burn.
Agree. But so far there's no reported event.
That is limited event in coronary, the limited area, but this is the whole artery.
I agree completely, but there's no reported event yet.
Sir, I have one question. Among the trials you have quoted, how many has been conducted in India?
None.
None. So then how you are going to implement it in India? It's a different scenario altogether.
So completely agree. It's a very good question. So in fact, I would put other way around. These are all, because I have been trained in UK. I've been there for 13 years.
Right.
So I have seen both the side of the world. I have treated, I've been a cardiologist there and over here. In fact, we need it more because we have more, our diet is more salt rich. We have a sedentary lifestyle. We have more incidence of hypertension. We have more population who are untreated. We have more population who are undiagnosed. So in fact, there's a need of the hour if we have to do something. Is India requires more than the Western people.
No, sir. Sorry to, I am disagreeing with you, sir. Indian populations are not sedentary. We are sedentary. The people we are sitting here, we are the
No, I
population.
go to gym every morning. Right. I'm not.
But the rest of our population sitting here, most of them are sedentary lifestyle. The actual beneficiaries,
So
beneficiaries,
it would come eventually. See, we have our own stents now, and there are good stents because I know the stents which are used in UK now, the Indian-made stents. Tower had come. We have now Indian companies making good valves as well. So I'm sure when this is approved, this is not big. It's just a laser catheter, it's easy to make.
We'll make a Dr. Reddy and company, sir. I will fund it.
Just hold on.
Yeah.
Yes,
That's the reason I completely
With
agree.
5 lakh rupees,
I completely
we can
agree.
purchase so
I
many
think,
medicines.
so this is a very political question. I completely agree with that. Dr. Menon was speaking before me. He mentioned about laser. He mentioned about IVL. I mentioned about this. Now compared to when I was in UK, when I was doing laser, the catheter cost was 1,200 pounds, which is 1,20,000. Here it is 3 lakhs. The IVL, let me finish. The IVL cost here, the balloon cost here 3 lakhs in India. In UK it is 1,500 pounds, which is 1,50,000. 1,50,000. So I think here the system comes from above. And we doctors are blamed. We all doctors are blamed. Yeah, doctor itna mehenga de raha hai. They don't realize this is coming from upstairs. We are dictated terms. We don't fix the price of stent, balloons or catheters. This should be cheaper in India, definitely, because we have got volume. But who'll take that on? Who'll take that on?
It is not, I'm not just talking in terms of the catheter. I'm talking in terms of the procedure. Any coronary procedure, it doesn't replace a drug.
Yeah.
Here you are just providing the 6th drug with the provision that there can be a 7th drug also in terms of medicine.
This patient was on 8 or 9 drugs. There was no
But
further
but
option.
you are at the bottom line is just one drug that you say. Right in the beginning you used the word that we have added another drug.
It's just an
And
adjective of me using it. This is another
Sir,
treatment sort of,
sir,
right? It's
sir,
another treatment.
But it is going to continue, and then the provision of 9th drug, as you said, 8 drugs, so 9 drugs will be there. So how, we have not done any studies on it.
No, these
They
are
have-
studies
because
done
coronary angiography, coronary angioplasty, and everything, there have been studies and they are not replacing drugs. They're opening up channels. This is not opening up channels. This is still an experimental study all over the world.
So this, as I said, this spiral studies, they have shown there is a significant drop. The patient have come off 1 or 2 antihypertensive or have remained on the same antihypertensive medication with a better rate control, with better blood pressure control. They are not claiming that you will come off medications completely. So even medications, even like, for example, if I put a stent in, are you gonna, I might say, okay, don't stop statin, stop antiplatelets. No, stop your antihypertensive, stop antidiabetic. No. So it's like a comprehensive treatment to the patient. It's a holistic approach. So it's not that one thing, I do this, hope patient amar ho gaya. It's not like that.
Okay, sir. Thank you.
Thank you.
Thank you, sir.
Thank you, Nimit Shah.
Problem we are facing, who respond to this is we don't know. On the table only we'll come to know how much blood pressure is going to reduce or not.
Not even on the table. In fact, they say you won't see the effect for 3 months. After 3 months. 3 months.
It takes, correct.
3 months.
Responder we don't know. It may, some cases, responded cases, the drugs quantity or requirement may come down. This is not the replacement therapy. This is the adjuvant therapy.
Yeah.
But sir, all over the world the studies, they found that after 1 year the BP again comes up in most of the patients. That is what I'm trying to tell you. This is different. There's a difference between coronary procedures and renal procedure. This procedure particular.
No, study shows that there are permanently external damage occur after the 3 months. So initially in the 3 months you need to continue all the medication. After 3 months you can have tapering because the external damage starts after the 3 months. This is the message.
And as you rightly said, see, we got a data of 3 years. We don't know over the line, over the time, whether it gets a rebound hypertension. We don't know. But what do I do with this patient? With 8 medication, do I leave him with a blood pressure of 200? Fine, this might not work after 4 years. At least I've given him 3 years of better blood pressure control.
Thank you, sir, for answering all the queries very effectively. I would request our chairperson, Dr. Meera Arora ma'am, to present a memento to our speaker. Next, I would like to invite Dr. Ravi Gupta for the talk. He will be speaking on the topic ischemia beyond the coronary. I request our chairpersons to briefly introduce the speaker, Dr. Ravi Gupta.
Dr. Ravi Gupta, leading interventional cardiologist in India, head of the cardiology at Wokhad Hospital in South Mumbai, trained in cardiology at Escorts Heart Institute, New Delhi, training of peripheral interventions from Mount Sinai Hospital, New York, and got training of TAVI at Germany. He has performed more than 10,000 coronary angioplasties, including most complex and challenging cases like left main CTO, bifurcation, and trifurcation cases with minimal complication rates. He has performed more than 3,000 peripheral angioplasties. He is proficient in most cardiac procedures like pacemakers, AICD, CRT, TAVI, device closure of birth holes like ASD, VSD, and PDA. He was declared as the best young interventional cardiologist in India years 2009 and 2011. He is a national level artist and published a book on medical humor, MA Scene. I just request Dr. Gupta to start his presentation.
Thank you very much, sir, for your kind introduction. I never knew that it's so long. So I really enjoyed it. And good afternoon, everybody. And after very informative sessions by Dr. Nemet Shah and Dr. Ajit Menon, both are very dear colleagues. Although I am also primarily a coronary interventionist, but Dr. Shishir wanted me to speak something except coronary. He said that no coronary case allowed. So today, what I am going to speak beyond coronaries, I mean what we have been doing except coronaries. Yeah. Is full screen? So, can you give me a mic, something, or you move? Or yeah, give me this mic. I would be happy. Yes, yeah. This mic working?
Yes.
Yeah, good, good. So in another 15-20 minutes, what time has been given to me, I am going to discuss about the peripheral vascular disease. It may be the lower limbs, it may be the upper limb, it may be the carotids, it may be the mesenteric arteries or anything. I would be talking about few things which are very uncommonly done, like pudendal artery angioplasty in erectile dysfunction. I am going to talk about a quick cases of TAVI, TAVR, and fistulae. Fistulae are abnormal collection between artery and a vein. And I would be talking about few uncommon procedures like alcohol septal ablations, PFO device closures, treating aorta with AAA graft, and dissections of the aorta. So this is all I deal with. So I very humbly share that although I am a coronary interventionist, but I have got opportunities to treat almost all type of arteries in our body. So I always joke that to a man with a hammer, everything looks like a nail. So if a catheter and a wire, so you enter anywhere. So before I start my proper lecture, I would just quickly revise our anatomy of the arterial system. From the left ventricle, aorta would arise, and from the aorta, there are two arteries, one on the left side, one on the right side. The left is the left main, which will further divide into the LAD, left anterior descending, and the left circumflex artery. On the other side, there is a right coronary artery. When it becomes the arch of the aorta, there are three major arteries which are arising from arch of the aorta. The first one is the brachiocephalic trunk, which will divide into the right subclavian artery and the right common carotid artery. Then the left common carotid artery, then the left subclavian artery. When we go down, you will see the superior mesenteric artery, inferior mesenteric artery, celiac trunk. When we further go down, you will see the renal arteries, which are supplying the renal arteries. When you go further down, you will divide the common iliac arteries. So the aorta will divide below the renal artery into the common iliac artery. Common iliac artery would be internal iliac and the external iliac. External iliac will continue as a SFA artery after giving a branch, that is profunda femoris artery. Now give attention, because I am dealing with this part of the arteries. When you go below the knee, the artery will divide into three arteries. The popliteal artery will divide into anterior tibial, posterior tibial, and the peroneal arteries. And whenever we are dealing with diabetic foot ulcers, that time your basic knowledge of anatomy would come. So now I am coming to my topics. So see this. This is just a prototype case. This patient has come to me with a diabetic foot ulcer which is not healing. He is a diabetic uncontrolled. And you see that below the knee, this, can I have a pointer please? Yeah. I think this should work. Yeah. Yeah. See this. This is the popliteal artery and it is dividing normally into three arteries. Anterior tibial, posterior tibial, and the peroneal artery. And you will see that all three arteries are blocked. And these all are very bad CTOs. CTOs means chronic total occlusions, old blockages. And you will see a thin wire going in. I am entering into the posterior tibial artery. You will see this wire going in and coming out in the anterior tibial artery. So we enter from the posterior tibial artery, then crossing the whole arch and enter into the anterior tibial artery, dilate it, and this is what we achieve. This is just a prototype case. So when we are dealing with diabetic foot ulcers, believe me, not opening the artery sufficient, you may require so many things like good control of diabetes, infection control, and so many things. At times people would ask me that how do you able to manage these wires entering into the anterior tibial and coming out of the posterior tibial artery? The wires are not so long. Although we have long wires for the peripheral circulation, but I have my own technique, so this I am going to discuss in brief. We call it RG technique. This is reverse groin. Some people would make joke of it, this is Ravi Gupta technique, but this is actually RG technique, and I am fortunate that I have coined it internationally level, and this is my own technique. So normally what people would do, for an example, if you are treating left leg, you will enter from the right leg, enter and then go down. This is the normal technique. In my technique, the patient would lie the upside down. I mean, the head would be on the other side and foot would be on the other side. And I puncture the artery sheath looking down. I mean, I would not puncture like this, I would puncture like this. I will show you in the next slide. So my patient is lying this way, and you see, I am puncturing the other way down. I am puncturing the downside of the artery. It will make my life easy because now I am dealing the artery in the straight manner. I will save this much of length of the catheter and wire. This is very interesting case. He's around 54-year-old male coming from Mira Bhayandar. This person is practically bedridden for 4 years. He has a very, very bad stenosis of the aorta. Can you see that this is infrarenal aorta, 100% occluded? One of my catheter is coming from the radial artery and one catheter is from the femoral artery, and you will see that there is no connection in between. This is almost 4.5 centimeter long CTO. It was a real tough case, hard calcium, not able to cross any wire. We had to puncture ultimately the brachial artery because my radial catheter was not reaching up to the aorta. So we punctured the brachial artery to come closer to the lesion, and this is what we achieved in this patient. And I am very happy to share the next day. He is walking faster than me. Yeah. Now I show another case. This is a SFA CTO. SFA means superficial femoral artery CTO. Which CTO we call the worst CTOs, those with the bridging collaterals. You will see that this branch, these all are bridging collaterals. These are difficult for coronary interventionists and peripheral interventionists for both. So this is what we achieved. And we have an advantage of being an interventional cardiologist that we use the hardware which we use in the heart. This is one example of abdominal angina, and this is a tight stenosis in the superior mesenteric artery. This is the stent placement, and this is the final result. This is another patient from railway only. I mean, I treated it last week. This patient is suffering from a severe carotid artery disease. You can see the internal carotid artery is a very severe stenosis here. For carotid artery, you need to be sure that you put a filter, a distal protection device, so the the thrombus doesn't go into the brain. So first you put a distal protection device, then you pre-dilate, and then you put a stent. So here we have a distal protection device somewhere here, then we pre-dilate it with a balloon, and then it's a self-expanding stent, and this is the final result. This is another very interesting case. This patient came from a Gulf country. It's an old gentleman coming with a pulsatile swelling in the thigh. And how it happened, he had one femoral artery insertion in the groin in his country, and there was a big pseudoaneurysm. And this pseudoaneurysm in the profunda artery is so big that it is hitting the superficial femoral artery, and you can actually palpate the superficial femoral artery from outside. This is the picture of this pseudoaneurysm. It's a huge pseudoaneurysm, and we thought that we can fix it without opening the groin. So I took a covered stent, 7x60. Selectively we go inside the profunda artery, and this is what we achieve. And believe me, the next day patient was mobile and third day discharged. This is again very, very interesting case. This patient had an IV catheter inserted in the groin because they couldn't get the neckline for delivery of the drug. What happened that, and the drug was delivered for next 4 or 5 days. After 4 or 5 days, patient started developing breathing difficulty. She went into clear-cut right ventricular failure. Not able to understand why it happened. We did a Doppler. Doppler says there is a pseudoaneurysm not clearly accessible. We did the angio, and you will see a very, very interesting, very, very uncommon picture. Dr. Reddy can probably pick it up. No. This is a peripheral AV fistula. What you can see here that my catheter is from the left femoral artery. I am injecting into the artery, and the dye goes into the vein. And this is IVC and filling the right atrium. And this patient is going into failure because of this AV fistula. What we did here, again, the covered stent helped me, and see the final picture. On table, the complete AV fistula totally vanished, and patient in another 2-3 days was able to discharge. This is another AV fistula from the bronchopulmonary circulation. You will see that it's a big fistula. And filling the circulation, and this is how we blocked it by coils. The same patient actually has coronary AV fistula also. You will see a big AV fistula from the left circumflex. You will see that left main, that left circumflex, and it is opening into the pulmonary artery. So we blocked it. It was a very, very tortuous course. You can see that the way my catheter goes, and then we were able to manage to deliver the coil in the fistula, not compromising the circulation. Now I am coming to few, again, very interesting cases. Aortic dissection. This is, you remember that this is the aorta, these are the 3 major branches. The patient which I am going to show is an aortic dissection here. You will see a very big outpouching of the dye when we inject. This patient actually underwent a open heart surgery in the past, almost 2 years back. He had an ascending aorta aneurysm for which he was underwent a procedure in which they changed the valve and the ascending aorta. But this patient came to us with another dissection. I hope you all can appreciate when I inject the dye, this all dye comes here. This is all big aortic aneurysm. Now the challenge in this case that aortic aneurysm is starting just immediately after the left subclavian artery. So if I am going to treat it with a endovascular graft, I have to be very, very precise that I don't pinch the subclavian artery. So you see, I start placing the endovascular graft here. We are deploying stent, and this is what I achieved. Fully able to cover the endovascular graft, the dissection, and subclavian artery is nicely patent. Another very interesting case which has a lot of innovation. Probably you need to understand, I have to stand here to make more common with this. This patient has 2 renal arteries, everybody has. These 2 renal arteries are not at the same level, which also doesn't happen in most of the cases. One artery is slightly higher, one artery is slightly low. What happened in this patient, there is a big aneurysm which is starting in between these 2 renal arteries. And this is ending after the bifurcation. So you have challenge where to start and where to end. I hope, Shishir, you can understand what was the challenge. So in this case, we want to put a endovascular graft, and if I start from here, I will miss the aneurysm. If I start here, I will occlude both the renal arteries. If I start here, I will pinch this renal artery. We wanted to start from here. So what we did, we took the endovascular graft, and before delivering inside, we took out the graft from the delivery system. We made a hole with a scalpel, imagining that this hole would align the left renal artery. We did it. Then how would you see that where exactly the hole in fluoroscopy? So we cut the coronary catheter, the distal tip of 30 centimeter, that is radio opaque. So we asked our surgeon to sew the radio opaque tip around that hole. So when we take it under fluoro, so we would see that where exactly the hole is, and looking at LAO, RAO, we will try to make sure that this hole fits exactly in front of the left renal artery. And this is what we did it. This is the actual picture of that delivery system, and this was the final result. Another challenge was down. This was like making a pajama. So we wanted to finish both common iliac arteries. So we create a new carina that is a pajama technique. Yeah, this is also something which is uncommonly discussed, erectile dysfunction. people used to think that this is almost all psychological thing. But over the time, people have learned that as we have blood supply for all the organs, your corpus cavernosa also has blood supply. For a normal male organ erection to happen, you need to have a gush of blood supply. And if you have meager blood supply to the internal iliac artery or the internal pudendal artery, you can have the problem like erectile dysfunction. So I have been treating this almost 15, 20 years now. So you can see in this case, this is actually the common iliac artery, and now, no, this is, already entered into the internal iliac artery. This is the anterior division, and a tight stenosis here, and this is the posterior division. So you balloon it, and you place a stent here. This is, I have discussed. Yeah. This is again a very, very precious picture to me. Professor Alan Kirbier, he is the one who developed TAVI, his father of TAVI, and just few days back, we lost him. So it's a homage and respect to him. This is a picture taken long back. TAVI we have been doing on regular basis. I was fortunate to do the first portico TAVI implant in Western India. Deep vein thrombosis IVC filter, this is a simple procedure. Nothing great in this. It prevents the pulmonary embolism. This is ASD device, again, nothing very great. This is again very, very uncommon. Patient coming with stroke, we call it cryptogenic stroke. I think all of us have read cryptogenic stroke. But very, very few people have actually seen those patients. As a routine workup of CVA, every neurologist would ask for a TEE to see the PFO. But believe me, I haven't met any neurologist who has actually seen a PFO. And we were fortunate that we detected a PFO as the cause of CVA in this lady. She had DVT, a PFO through which the clot went into the systemic circulation and then into the brain, and we treated it. We put a PFO device closer in this lady. Alcohol septal ablation is again a very, very interesting thing. Probably these are my last few slides. Hypertrophic obstructive cardiomyopathy. What happens in this situation? When we talk about the ventricle, the left ventricle, the interventricular septum is very thick, and this is the cause of the problem. So how to decrease the thickness of septum? Earlier, people used to do a lot of surgeries, which we call myomectomies, and believe me, results of myomectomies are not good all over the world. Are you agreed, Doctor? My surgeon? My surgeon is, myomectomy results are probably not good everywhere. You are happy with myomectomy results?
Yeah, they're fair, sir. If you associate it with SAM, suppose the valve has to be replaced, then the results are not that good.
Okay.
But definitely, and if it is like apical obstruction or mid-LV obstruction, the result may not be that good. But HOCM, classically, which is just the valve, the septum is involved, then the results are.
So you do shave of that IVS?
Yeah, interventricular septum, we are taking the cusp separated here, and then we have to resect that muscle, at least up to the mid cavity.
Okay. So I'm happy that biometric results are good at our center, and really it has to be appreciated. And what my experience is that when you are dealing with this thick interventricular septum, you need to decrease the blood supply. If you are able to find out a septal artery, which is a branch of the LAD, you go specifically into that septal artery and we give 100% alcohol, and the artery closes and the blood supply also closes. So you see in this view a septal artery we found, although it's not very big, we have done even the better cases. My wire is inside the septal artery. We occlude with a balloon, and we, by a catheter, we inject 100% alcohol, and this is the final result. Sorry, we got some limelight also for this type of cases, and we had some songs also. Sorry. Is there any music?
We have stopped the sound, sir, because it will be very interesting.
Can you, huh?
We have stopped sound, otherwise you will look very interesting.
Yeah, I wanted to, okay. She's singing, you saved my life, oh dear Gupta.
You have saved my life.
God bless you. God bless you. She's a darling patient from one of the African countries. You are not tired after dancing?
I'm very hip, I'm not tired.
Very good. I'm very happy with this. Very happy with this.
Yes.
Take care. God bless you.
Thank you so much.
You're welcome. You're welcome. You're welcome. Take care. So these are routine things. I'm not going to show pacemakers, ICDs, CRTs. Yeah. Disclaimer, of course, all the procedures, I very gracefully share that these all procedures are done by me at Wockhardt Hospital only, and all patients are very dear and very close to us, so we try to prevent their identities largely, and I will very gracefully say that my bread and butter is actually coronaries, so that will remain the coronaries, and no interest in the device company. And in the last, I wish you very, very happy Shivratri from me, my wife, and my daughter. Thank you very much.
Who is your daughter?
Sir, sir, beautiful lady, this beautiful girl, sir. You see this beautiful girl. Thank you very much. You have any questions, comments? You're most welcome.
Thank you very much, Dr. Gupta. It was an excellent presentation. So, the next speaker, he is not there.
Thank you, sir. Thank you, sir, for the wonderful talk. I would request our chairpersons, Dr. Ashish Mukherjee, sir, to felicitate the speaker with a memento. Now I will request MD Madam, Dr. Mamta Sharma Madam, to present mementos to our chairpersons, Meera Arora Ma'am and Dr. Mukherjee sir. Now we will be having a quiz competition and tea will be served at your places. Dr. Rajesh will take over.
We'll have a session of short quiz only. We have around 20 questions of MCQ type. Each need to give an answer ABCD form. And before that, you can click.
So there will be a QR code which will be showed. You have to scan that QR code in your mobile. So it will take you to a Google form, and in that Google form only questions will be, means question number will be there and options will be there. The question will be displayed on the screen and the options will be also be displayed on the screen. You just have to take the answers in that Google form and then submit. Every question will have 15 seconds to answer, and there are 20 questions containing 1 mark each.
if there any problem, you can have a paper only. Write down your name and question number 1, your answer A, B, C, D. Any problem you are having, you can have only paper and pen and paper. Write down your name, please. Then A, B, C, D, whatever answer you write down, then just give us. We'll collect it. Or otherwise, you can collect that QR code. Yeah, you can scan this. It is very easy to do. And anybody's problem, we can. We have hard copy also. You can.
If anybody is having problem scanning the QR code, they can just raise their hands. We'll get this QR code to you.
Please go. And where there's a problem. Only it is a quiz of 10 minutes only. We have 20 questions. Write down your name, please. Or anybody, if you have any problem, you can have a plain, only plain paper and write down your name and go ahead. Is it on now? Everybody now ready to go ahead? Yes, should we start now? And nobody can use mobile while answering the question. Anybody found to use, he has to pay the award money to other. No, you can, because simple answer, they can see from the, or there's not any discussion. And cardiologists are excluded from the quiz.
They can guide.
Everybody ready? Yes, sir. No. If any problem, just have a pen and paper, you can go ahead also. Ready? Okay. We are going with question number. All the best to everybody. And for announcement, the first award is 2,000, second award is 1,000, and third one is 750. Because you are taking so much time to start, that's why. Yeah, this is the question number 1.
What does PTCA stands for? Percutaneous transarterial coronary angioplasty, percutaneous transluminal coronary angioplasty, percutaneous transvenous coronary angioplasty, percutaneous transaortic coronary angioplasty.
So, what the PTCA stands for is percutaneous transarterial, percutaneous transluminal, percutaneous transvenous. No mobile, please. Nobody can use Google because we have a CCTV camera. Camera is blowing. Has to pay, please. Anybody we found, because our residents are very smart, they do less angioplasty but do this work better. So anybody they found doing this mischief, they will be debarred. Okay. Okay, ready? Okay, next. Now we are doing a procedure, and you can see this.
In which chamber of the heart the device is present? It's
in which chamber of the heart the device is present? RA, RV, LA, LV. In which chamber of the heart the device is present? Identify the ongoing procedure, ongoing what you can helpful. Whether it is OCT, whether it is IVUS, whether it is intracardiac echo, or it is transthoracic echo. Please go ahead. Acha, there well. Okay, taking time. Okay, now. The patient is taken for PAMI. What does the PAMI stand for? Primary angioplasty in acute myocardial infarction, primary angioplasty in myocardial infection, primary coronary intervention in acute myocardial infarction, percutaneous intervention in acute myocardial infarction. What does the PAMI stands for? Patient having ST elevation MI, you can see the total occlusion of the artery taken for PAMI. What does the PAMI stands for? Don't use mobile, please. Acute coronary syndrome includes all except chronic stable angina, unstable angina, ST elevation MI, non-ST elevation MI. And one more announcement, to get the prize, at least 10 should be right answer. At least 10 out of 20. 50% correct. CPR chest compression to rescue breathing ratio in a single rescuer should be 10/2, 10:2, 15:2, 30:2, 2:2, 20:2. CPR, single operator, chest compression, and rescue breathing ratio. In etiology of cardiorespiratory arrest, what does the H stands for? All except. I mean to say, what does the H does not show? Hypoxia, hypocarbia, hypovolemia, hypothermia. Hypoxia, hypocarbia, hypovolemia, hypothermia. What is not H stands for? Question number 8. In the etiology of cardiorespiratory arrest, one more CPR question. T stands for all except thrombosis, tamponade, tension pneumothorax, tachycardia. Thrombosis, tamponade, tension pneumothorax, tachycardia, which is not a cause of cardiorespiratory arrest so far T is concerned. There are 5T, 5H. In which of the following valve, does not usually come in contact with deoxygenated blood? I mean to say, which of the valve does not come contact with usually with a deoxygenated blood? Tricuspid valve, pulmonary valve, mitral valve, Thevesian valve. You have to seek down the question number. It is question 9 we are going ahead. Question 10. In a DC shock, when it is asynchronized, is given in all except VT, pulseless VT, ventricular fibrillation, none of the above. Where we do not give a asynchronized DC shock, yeah, you can show cardioversion. Where it is not given VT, pulseless VT, VF, none of the above. Question number 11. In NSTEMI, non-ST elevation MI, which of the following is not advised? Thrombolysis, heparin, aspirin, atorvastatin. Which is not advised? Which is not advised? Question number 2. All are absolute contraindication of the TMT, treadmill test, except severe aortic stenosis, acute MI, myocardial infarction, acute infective endocarditis, acute myocarditis, which is not a contraindication, absolute contraindication. Severe aortic stenosis, acute MI, acute infective endocarditis, acute myocarditis. Question number 13. All are absolute contraindication for pregnancy to have, except severe symptomatic aortic stenosis, severe MR, myotic regurgitation, severe PH, and Eisenmenger syndrome, which is absolute contraindication except. But that means you can have pregnancy in which of the following disease? All are newer anticoagulant except ticagrelor, rivaroxaban, apixaban, endoxaban. Ticagrelor, rivaroxaban, apixaban, endoxaban. Which factor does not belong to extrinsic pathway of coagulation? Extrinsic pathway of coagulation, factor X, factor IX, factor 2, and factor 7 does not belong extrinsic pathway of coagulation. Next. All are absolute contraindication of thrombolysis except hemorrhagic CVA, non-hemorrhagic CVA within 3 years of life, suspected aortic dissection, intracranial neoplasm, which is not a contraindication. Hemorrhagic CVA, non-hemorrhagic CVA within 3 years of life, suspected aortic dissection, intracranial neoplasm. What should we avoid in this condition? What should we avoid? IV fluid, nitrate, tenecteplase, heparin. What should we avoid in this condition? IV fluid, nitrate, tenecteplase, and heparin. A 46-year male, CKD on dialysis, presented with giddiness. What is the immediate step you need to do? Immediate next step: angioplasty, thrombolysis, serum electrolyte, CT brain as quick as possible. What is the next, immediate next? Angioplasty, thrombolysis, serum electrolyte, or CT brain as quick as possible. CKD patient on hemodialysis. Question 90. Dr. Avinash is doing an intervention. What is he doing? IVP insertion, temporary pacemaker insertion, TAVR, or AHD device closure? And this is the last question, that is 20th question. Dr. Prasad is injecting the dye. Where? IVC, SVC, outer renal artery. You have to diagnose what is the, where he is injecting the dye. IVC, SVC, it is outer or renal artery. Okay.
So now submit, all of you submit your quizzes. After 20 seconds, we will stop receiving
Dr.
the responses.
Prashant and Rinita, who will collect more paper, you will get the best paper. Okay. You have to collect, you go fast, go fast. Now we are going to have our last session for today.
Coming to the last session of the day, fourth session. I would like to invite Chairperson Dr. Devesh Kumar, PCMD, Varanasi, come over to the dais and chair the session. And I invite Dr. Bhanumati Shekhar, CMS, Ahmedabad. Please come, ma'am. Chair the session. Come over to the dais. Thank you.
Devesh sir, PCMO Varanasi, and Bhanumati madam, CMS Ahmedabad. Kindly come to the chair and to start the chairing the session. And we have 3 speakers on this session.
So we have 3 speakers for this session. So the next speaker will be Dr. Brajesh Kunwar. He will be speaking about restenosis and troubleshooting. I request Devesh Kumar sir, PCMD Varanasi, to introduce our speaker, Brajesh Kumar Kanwar.
First, I would like to thank our DGRHS madam and the Western Railway, entire Western Railway, for conducting such nice full and events. And the first speaker, Dr. Brajesh Kumar, he is MD. He has done DM from the CMC Vellore. Currently, he is working as a senior interventional cardiologist at Apollo Hospital, Navi Mumbai. He is proficient in complex angioplasties. He has performed more than 25,000 angioplasties assisted by the techniques like IVS, OCT, rotablation, intravascular lithotripsy, etc. He has implanted more than 500 pacemakers and innumerable number of automated intracardiac defibrillators. He has treated multiple interventional patients from Middle East, Africa, and other Asian countries also. And he has received multiple national and international publications. So, Dr. Brajesh Kumar, please.
So, good evening, everyone. I am Dr. Brajesh. I'm working as a senior consultant in Apollo Hospital, Navi Mumbai. So, well, why this topic was selected? Let me just tell you a brief insight. So, at our level, what we are nowadays concentrating is how to prolong the life of an angioplasty. I mean, you do an angioplasty or you offer an angioplasty to a patient, the first question will be, sir, kitna chalega? फिर बदलना पड़ेगा क्या? Sir, इसका life कितना है? So all those things keeps on coming, and then of course with surgery getting advanced, you have minimal invasive surgeries, we have robotic surgeries, which very frequently we are doing in Apollo Hospital. I mean, the morbidity and mortality associated with surgeries has also come down. So now the important is how to prolong the result of angioplasty to our patients, how to get a good relief to the patient. So that is why I took this topic, which is restenosis. So when we talk about restenosis, now there are multiple factors. The most important is a patient factor. The important is how the patient is, carrying out the medications, how is the patient risk factors, whether the patient has diabetes, dyslipidemia, how he's continuing with the medications. That is, all those things are very, very important. Of course, the operator skills is also important. When you select a patient for an angioplasty, how you look into it, what are the ways in which you are doing an angioplasty, how you are attempting a bifurcation stenting or a left main stenting, all those things are important. And then the most important, the new advances, how familiar your cardiologist is with the new gadgets which are available in the market. Now, more and more gadgets are available in the market. The only purpose of using these gadgets in angioplasty is to give a very good result so that your angioplasty life or the stent life is prolonged. Now, you talk about the restenosis. There was a time when the stents were not available and we used to do only balloon angioplasties. We'll just inflate the balloon and come out. The restenosis used to be almost reaching 40 to 50%. Then come the bare metal stents, then the restenosis rate somewhere around 20 to 30%. And in spite of doing everything possible, the restenosis rate is still 5 to 10%. To define an instant restenosis, it is actually 50% more of a diameter stenosis, or within 5 millimeter of stent edge. If there is a stenosis, we call it as a restenosis by definition. The mechanism of restenosis, the stent getting restenosis is multifactorial. Some reasons are like biological, some are mechanical, some is patient related, some are operator related. Mechanical means suppose you have not nicely dilated the stent. If the stent is not fully inflated, then there's a chances of restenosis. Or if you have over aggressively dilated the stent and the stent has got fractured, then also there is a possibility that this stent will not last. Biological factors are mainly neointimal hyperplasia or neoatherosclerosis. These are two different terms which I will tell you what exactly is the difference. So there was a difference in pathogenesis between the bare metal stent restenosis, which we used to do it 20, 30 years back, and the new drug-eluting stents. So other than the problems what we have with a drug-eluting stent is it contains a polymer. That polymer produces inflammation. So this is a new mechanism by which the drug-eluting stents, they differ from the bare metal stent in forming the restenosis. So that is why when we do imaging, we find that the restenosis which used to happen with bare metal stent were pathologically different than what we used to have nowadays with a drug-eluting stent. For example, in this case, you can see that the one which is, if you see the, you have that marker? Yeah. If you see here, hyperplasia and new atherosclerosis. Atherosclerosis means all form of atherosclerosis. Let this be calcium, over a period of years. There was a classification which was used for restenosis by Mehran. I'm not going into detail of that because now it's outdated. What classification nowadays we use is a Waxman instant restenosis classification. I'm not going into details of that. Probably we have a lot of non-cardiac colleagues also in the meeting. But you know, it's all based on mechanical, biological factor, mixed and chronic total occlusion and more than 2 layers of stent. With a more and more advent of angioplasty, you may find patients with multiple layers of stent. One stent got damaged, you put another stent, all those things keeps on going. So again, coming to the most important part, what are the predictors? So you have patient-related, like poor compliance of medicines, the presence of diabetes, familial dyslipidemia, and interventions in acute coronary syndrome. If you have an acute myocardial infarction coming at 3 o'clock in the night, sometimes our main aim is to save the life. We may not be using IVs, OCTs, imaging to give the exact result, but the aim in that case is to save the life. So that is why the chances of restenosis becomes more in these patients. Then there are certain lesions characteristic and procedural variables. So what is important is whenever you have a angiogram done with multiple blockages, the best thing is to involve a heart team approach. Sit with your surgeon and the patient relative and talk to them what are the options we have. Can we have a surgery done? Can we have a angioplasty done? So all depends upon what is the length of the lesion. If you have whole vessel being stenosed, putting a 48 mm stent does not make a sense. Similarly, if the vessels are smaller in size, you cannot do an angioplasty in that. So what is important is what is the size of the vessel before and after angioplasty. Putting a 2 mm stent in a vessel, you don't expect it to last long. So that is why it is important that you rightly select the patient. Similarly, ostial lesions, they are more prone to develop restenosis. You have venous graft and your total occlusions. These are the situations in which restenosis rate is common. So again, stressing that the right selection of the patient is important. You should know that this patient, see, the cardiologist, the angioplasty is not the end of your treatment. It's probably the beginning of the treatment. It is important that the patient should follow to you in OPDs, should continue to follow over years in OPD, and you will be responsible for his restenosis rate, reprocedure rate. That is what the concentration of a cardiologist should be. So right selection of patient, vessel and stents. There are multiple stents available in the market. You need to know, you need to update yourself, which is the best, what is the special features of that. I mean, you cannot live
a decade back, ये stent 10 साल पहले use होता था, अभी भी उतना ही अच्छा है. You need to, make sure that you are updated about the current knowledge. And use of debulking gadgets. Now, suppose you have a calcium in the coronaries. I think my earlier colleague has already presented it. If there is a calcium in the coronary arteries, whatever pressure you give to dilate a stent, it will not dilate. Even if it get dilated, it will recoil. So it is important to know that, you should know what are the debulking gadgets, optimum use of imaging. Now, there are certain situations in which imaging is must. Imaging means what I'm talking about. I'm talking about inside the coronaries, we go with our wires, the tip of these wires have ultrasound or CT. So we can go inside the coronary arteries and we can image the vessels. By imaging, we know what is the size of the vessel, so what stent to be used, what is the calcium, how much length you need to be used. So all this information you have prior to putting a stent. So ultimately the result has to be good. So there are certain situations in which imaging is must, indispensable. For example, if you are doing a left main angioplasties, it is must to have an imaging. So then of course the lifestyle modification, please you have to tell your patients that the coronary artery disease is a continuous process. It's not like an hydrocele hernia that you treat it and tell the patient no need to follow up. They need to follow up with you. There are set of guidelines where you have defined target of LDL cholesterol, triglyceride, which need to be followed. This is a degenerative condition which keeps on coming. So it is important that the guidelines need to be followed. And of course, you should know about the newer medications, newer drug. We have nowadays once in 6 month injection for cholesterol. We have something known as Cybrava, where patients who don't tolerate tablets can have 1 injection in 6 months and get rid of cholesterol. So, all those things are there in the market. You need to update yourself so that you do good for your patient. So, I'll just talk a few minutes about the imaging. So these are the 2 ways by which we do imaging. One is intravascular ultrasound, OCT. Almost both the imaging modalities are almost same. They help us in dealing with treating the patients properly. There are certain advantages which are very mild, but of course any hospital which has got a good running cath lab should have an imaging system. Either of them, IVUS and OCT, there are minor details, probably only cardiologists can understand it better, what are the benefits of IVUS or what are the benefits of OCT. But nowadays, with a central IQ, imaging has to be there in the cath lab always. This is how it is. This was a patient who had an angioplasty done, and you know what happened? This patient came with a stent thrombosis. Ideally, this patient should have undergone an imaging. The imaging suggested this patient has a proximal dissection, so the stent got reblocked. So this is an IVUS imaging. You can see the calcium. Now by seeing this type of calcium, there are different calcium scoring system also. Your cardiologist will decide what is the best debulking therapy. Debulking means you need to cut this calcium. You need to make the space for the stent. You need to remove some part of calcium. Or otherwise, if you put the stent in this calcified vessel, either the stent will not expand, or even if it expands, it will recoil. So it is important that you must have imaging technique and debulking techniques in your cath lab. Now I was talking about an operator. Now a difference between an experienced operator and a beginner lies, if you understand this, this is a pipe, this is a main artery which divides into 2. So for most of the people, angioplasty is like a plumber's job. You put a stent from here to here. Now stent don't come in conical shapes. They are cylindrical. So if you put a stent like this, you are leaving a space which is malapose stent. So this space will form either a stent thrombosis or will cause a restenosis. Now what is important is if you do a cut section, you find that this is your stent and this is a malapose area. If you go with very high pressure to this stent, this part, the stent will dissect the artery. So what is important is you make sure you give us this shape to the stent. This shape to the stent. So this is what imaging helps. So imaging will tell us what is the size of the vessel here, what is the size of the vessel here, what is the size of the vessel here, and after doing angioplasty, you are sure have your stent match the size of the vessel. And also you will know whether your side branches are flowing or not. So this is the importance of doing imaging during an angioplasty to prevent restenosis. This is one thing which probably if you see, this size looks bigger than this. So you need to decide by imaging from where to where it should be stented and what is the level of calcium and how long the stent should be. These are the debulking techniques which we use it. Debulking technique is very simple. What I meant is removing the kachra from the vessel, what all things you need to remove it, what all things you need to do. So that kachra can be removed with something like a high pressure balloon, cutting balloon. This is an IVL. I think somebody already spoke about IVL. IVL, by giving a vibrational force to the wall, it breaks the calcium. I'll show you a diagram. This is a rotablation, this is orbital atherectomy, and this is the most advanced ECLL, this is laser therapy. All these techniques we are using in advanced cardiology, which were not there probably 2 decades or decades back. And that was the time when, the results of the angioplasties were not very great. So if you see, our restenosis rates have significantly come down. The only reason because of that is because of the use of these gadgets. Now this is one picture of an OCT, and this is after doing an IVL. You can see that by doing an IVL, you produce actually micro fractures in the calcium. If you put a stent over here, the stent will not expand. By creating a micro fractures by using an IVL, you are able to make it bigger, and you can put a bigger stent which will not collapse. This is a rotablation for a common people to understand. This is how it looks like. This is orbital atherectomy. This is a cutting balloon. This is how an IVL works. This is how the laser works. So when you finish an angioplasty, it does not mean that the work is over. As I said, what is important is to see this data. Only 20.8.7 patients achieve target LDL cholesterol of less than 55 after 1 year of angioplasty. I mean, is it shocking? Only 20%. That means not only our interventional cardiologist is at fault, we people who follow up these patients in OPD are also at fault. So whenever angioplasties get re-stenosed after a year, we say, "Arey, stent acha nahi laga." But are we following the guidelines? Are we aware of the guidelines? So if you see that only 20% achieve the new guideline, which is less than 55 LDL at 1 year. 80% of the patients do not achieve the target LDL. If you see the new, most recent 2022 ACC expert consent decision, that is LDL to be kept less than 55. In fact, our Lipid Association of India, LAI, is very aggressive. In a younger patient who has multiple disease, is a patient who's coming with recurrent stenosis, in a patient who has got a triple vessel disease, these patients should have, LAI says that you bring down the LDL to less than 30. So this aggressiveness is needed not only during angioplasty, post-op also. If you have LDL cholesterol reduced by statin, reach up to maximum. Still, if it is not, you are not able to do that, then get involved a cardiologist or start using injections like Ripata. We have, monoclonal antibodies, or we have something like a small interfering in mRNA, Cybrava. We have multiple medicines available. So other than that, because we work, all of us work in a very high volume center. In spite of doing everything, you may once in a while see a patient who's coming with restenosis. So colchicine also has been advised to use in patients who come with restenosis. There have been other drugs also in this, like pioglitazone, silastazole, these all other molecules which have shown that they also prevent restenosis. So that can be used when required. So thank you very much. Thank you.
Thank you, sir.
Dr. Brajesh Kanwar.
Thank you, Brajesh Kanwar, sir. I request Chairperson, Dr. Devesh Kumar, sir, to hand over a moment of appreciation.
Before that, any question from the audience or anybody we can have? This is a burning subject.
Now the session is open for question, please. Dr. Brajesh Kanwar has presented it very nicely, thought-provoking session. He has already mentioned that angioplasty is not the beginning of your, not the end of the cardiologist, but it is the beginning. And he has already mentioned that the stenosis is more than the kachra. So I think there are a lot of questions. You must have some questions. He is very nice speaker. Please.
Okay, in absence of any question, we request our chairperson to hand over a
Sir,
lab.
my question is, जैसे routinely patients OPD में आते हैं follow up के लिए, so what should be the target BP and target sugar levels for us to prevent restenosis?
Target sugar levels. So there is no target sugar levels for preventing restenosis. There are target levels for diabetes. You maintain that.
Sir,
But for lipid profile, we have specific targets for preventing coronary restenosis. But diabetic means you need to follow up with your diabetologist and keep the diabetes under control. You can have your HbA1c less than 6. You can have fasting levels less than 100. Post-fasting level less than 140, 150. So diabetic levels can be does not have a target in coronary artery disease. What is mentioned is a good control of diabetes. But lipids, it is important. Why I'm stressing again, because when you order a lipid profile to a patient, he goes somewhere and get a lipid profile report, where on the side it is written the normal values are between 100 to 130. That normal value is for a normal person, not for that patient. That patient is a post-angioplasty patient, post-MI patient. So we need to tell our patients very, very clearly that this normal values does not belongs to you. And as a looking forward, what I do is I write their target levels. So I mentioned in this thing, your target levels is this. So somebody who has got once angioplasty, LDL 55. Somebody has got twice angioplasty, LDL 30. So this is how we keep on writing about this, and this is what we need to do in the OPD. So, madam, if patient is a coronary artery disease patient and you are doing something new, for example, today the patient has come to you with a lipid profile and you added a medicine. To know the effect, I usually do it 3 months. But suppose in a coronary artery disease patient, every 6 months. For a routine person, every yearly. This is how it is. But suppose you have added ezetimibe to a rosuvastatin already on, I will do it every 3 months to calibrate the medicines further. But once you have calibrated, 6 months for coronary artery disease patient.
Excuse me, sir. Sir, indication to prescribe evolocumab based on only lipid profile or any imaging?
So suppose you have a patient who has probably developed side effects of statins, he has developed muscle pains. I had recently one patient who has a hepatotoxicity, which cannot take this thing. Patient suppose is allergic to statins. I have seen people allergic to even 10 milligram of atorvastatin. So that is the indication where and probably over a period of time, as the time process, many patients will tell you that, sir, I cannot take medicines every day. Give me something. So, injections once in 6 months or once in 3 months will probably be replacing our tablets. So it's like giving a vaccination against cholesterol. Once in 6 month injection, it's like a flu vaccine every year.
In addition to that, as the statin and ezetimibe, what is sir telling, so that will decrease your cholesterol by 50%. Yeah. So if somebody is in native baseline LDL is 250, 250, you know that this amount less than 55 I cannot achieve with statin and ezetimibe. Start with evolocumab.
So add-on therapy. Add-on therapy. You have reached your rosuvastatin 40 milligram. You have added ezetimibe. You have added a bempedoic acid, and still you find the patient has got still LDL high. Then you add probably evolocumab.
But not on the first set.
Not on the first is what I said, allergic to it, develop myopathy, muscle pain, side effects, hepatotoxicity. That time this will be the first line therapy.
Thank you, sir.
Okay, thank you, sir. Once more I request chairperson to hand over the memento. This brilliant session is sponsored by Termo India Private Limited and Concept Medical. Thank you, sir. Now we are having among us with our one cardiologist, that is who is the father of our cardiology department, that is Dr. M.B. Reddy sir. I invite him and I request our chairperson to invite to speak something about Dr. M.B. Reddy sir.
Dr. M.B. Reddy, sir, is senior international cardiologist at Apollo Hospital, Navi Mumbai. And he was Dr. N.B. Cardiology from Perambu Railway Hospital, our own hospital in the Chennai in the 2000. And he has initiated cardiology and CVTS department as well as cath lab in JRH. He has worked for more than 32 years in the JRH from year 1992 to 2023. And he is the recipient of twice Social Services Award in 1990 and 1991. He has also received the Railway Minister Award for outstanding services. He has received twice GM Award in the Western Railway, and he is the CSI. He has also received the CSI Fellowship Award, and he is, at present he is the teacher and examiner for the DNB cardiology students, and he has got published 10 publication and 5 poster presents at national and international journals on his credit. So, Dr. M.B. Reddy, sir, please continue.
Thank you, sir. Thank you for nice introduction. What I am going to talk, actually the topic was given to me, what is new in the management of the resistant and refractory hypertension. But so far what new things are occurred is towards we are moving less and less drugs, more and more interventions in the management of hypertension. But since it's going to be a mixed crowd, I'm going to talk about little general about hypertension, what exactly we are having today problem. Are we doing the right thing? What are the things one should follow up in hypertensive patients, on which direction we are moving for the management of the hypertension? How do you move this? These are slides. These are one. So what we know about blood pressure is we all know that blood pressure is a pressure exerted in the column of the blood moving through the blood vessels. By definition, it is a lateral pressure exerted by the column of blood. Normally, when the blood flows in the normal blood vessels, it is less than 120 by 80 millimeters of mercury. When this pressure goes beyond this 120, 80 millimeters of mercury, we call it hypertension. There are various classes of hypertension based on the level of blood pressure recording. Why it is so important? Because this constant pressure exerts an effect on the endothelium of the blood vessels. The endothelium of the blood vessels present all over the body can damage the blood vessels, of which more important is the organs which are very important for our sustaining life, like heart, brain and kidneys are affected, where they causes a lot of morbidity and mortality to the patients who are suffering from the hypertension. The hypertension is a risk factor which is a preventable one. It is not that it cannot be prevented, it is a preventable, but unfortunately we neglect it. We are not able to treat these patients. What is the burden? What is the real fact of the hypertension? If you look at India nationally, we have 1 in every 4 patients is an hypertensive, of which if you look at 90% of the people who are on hypertensive, they are not aware of that, or they are diagnosed, they don't want to take any treatment, or they treated, they are undertreated. This is what we are facing a problem. And the prevalence of the diabetes in all over India is about 30%. In rural and urban, little variation, that 30, 28%, of which the control is 1/3 only, or 1/4 of the blood pressure in the patients who are suffering from. If you look at, this is not only burden in our country, it is a burden all over the problem. It is all over the world. Even in developed countries, we have only 25% of the people are controlled blood pressure with a medication. Whereas in a developing nation like ours, we have only 10% of the people who are adequately controlled the blood pressure, but rest of the people are not controlled at all, or they are not aware of that they are suffering from the blood pressure. It is estimated that of the blood pressure patients, 12.5, about 13% of the patients are having a resistant hypertension. And a lot of work is done on this hypertension, why certain patients are not able to manage with an anti-blood pressure medication. Then the work has been done. It has been found that the sympathetic nervous system plays a very important role in the initiation, maintenance and progression of the blood pressure. Lot of work has been doing, they are doing now and present ongoing this on the sympathetic nervous system. We know that sympathetic nervous system has got an afferent and efferent nerves. The afferent nerve stimulation increases the water retention and also activates the renin-angiotensin-aldosterone pathway, which is mainly responsible for the elevation of the blood pressure and also causes a renal vasoconstriction. Whereas the operant activity can also cause vasoconstriction and fluid retention. So both the operant and efferent, both the systems plays a very important role in the maintenance of the blood pressure and progression. There are certain things we don't bother when it comes to the blood pressure patient. We don't know what technique, how to record and all. We are in a hurry. There are 100 patients comes to the OPD. We don't know whether the real method has to be followed to make the diagnosis. We do a lot of errors in the diagnosis. A normal person, we make him hypertensive. In a hypertensive person, we can make him normotensive. These are the things happens in our day-to-day life. So what is more important, you need to follow certain guidelines when you label this patient in hypertensive. This patient should be relaxed at least 5 minutes in your OPD, and you should sit quietly, have an empty bladder, sit with the back support. You should relax himself. You should feel comfortable. You should not be restless. You should not be talking. Or you should be going out and talking with the relatives and smoking and coming out and drinking coffee and cup of tea. Since enough time is there, I can see the doctor a little later. That should not be done. And keep cup proper size. You need to know what is the cup should be used. That is very important. A cup should cover the circumference 80% of the arm, and it should have 40% of the weight. This is very important. Ideal cup should be put, and it should be relaxed and record on patient. And this is what you have to see, that patient should sit like this. You should be calm, quiet, then you record. Then you record properly blood pressure. You know that what type of blood pressure he is having, whether a systolic or a diastolic or a combination of both, or he's got a class 1, class 2 or malignant and a severe hypertension. These various class based on your recordings you can decide. So this should be done before any patient. We tell them that they are not responding to the medication. Otherwise, you keep on escalating a medicine, because you know that the side effect of the medicine is quite sometimes so bad, the patient will never come to you and he'll never take the medication, because wrongly recording blood pressure, high blood pressure, and giving a medication, and suddenly he goes home and he gets into hypotension. So these are the things one should avoid to get the confidence of the patient and to continue the medication. Based on the recordings, you classify the patients under essential primary hypertension, that is called essential hypertension, where we don't know what is causing. Now the work is going on a sympathetic nervous system, and it is this thing related. And the secondary hypertension, which forms about few percentage of cases in adults, about 5 to 10%, where we know the definite causes of them. I'm going to tell you what are the secondary hypertension. And you have sometimes isolated systolic hypertension is more commonly seen in elderly, and you have a malignant hypertension. Based on the recordings, nowadays the blood pressure is grouped into the stage 1 and stage 2. Earlier used to have 3 or 4 stages. Now they brought down to the stage that no meaning of that staging, because unless you have a good control of the blood pressure. Now, these are the most common secondary causes. One need to know that secondary causes of blood pressure, because these are the preventable causes. Once you treat these conditions, your blood pressure totally eliminated and patient can be free of drugs. That's what one should look for. A patient who is not able to control the blood pressure, is there any secondary causes? I am treating with, look very carefully, examine patient very carefully, look for the secondary causes. If you see the secondary cause, totally you can avoid the medication and patient can be prevented developing the complications. Now these are the renovascular disease and endocrine disease like primary hyperaldosteronism, Cushing syndrome, and pheochromocytoma and acromegaly. Or some of the cases one can clinically, once you examine these patients, you can certain signs and symptoms you can make out what kind of syndrome we are dealing with. Malignant hypertension. Sometimes we can come across the patient when we record a malignant hypertension. Malignant hypertension you have to diagnose when there is papilledema is there and blood pressure is more than 180 and systolic and 120 above is a diastolic. This is very important, malignant hypertension. Sometimes we come across, we are not common, sometimes we come across this case, it becomes very difficult for us to treat, and we should know how to treat this patient. It is not the elevated blood pressure is there, you start jumping in 4 or 5 drugs at a time. It should not be done. I will tell you how to one has to be done. The systolic, in this case, again, malignant hypertension, hypertensive crisis are the terminologies used in various, depending upon both one on the same. And there are things in malignant hypertension, there is a hypertensive emergency, there is a hypertensive urgency. If you have a target organ damage, like involvement of the central nervous system or the kidneys or the heart, any of that are high, any of the targets are involved, then you call them hypertensive emergency. When there is no targets organs are involved, only simple blood pressure is elevated, more than 180 and 120, then you call them hypertensive urgency or So this is very important. And in malignant hypertension, blood pressure should be treated very carefully and in a titrated manner. That is what very important. And you should get the BP should not be brought down too much at a time, because you know that the systems are habituated a certain level of the pressure. When you try to bring down the blood pressure down, suddenly that given organ, though the pressure is on high, they could develop an ischemia. So that should be avoided. That's why one has to be very careful about malignant hypertension, and the management, you should gradually bring down the blood pressure. In a first hour, the mean arterial pressure, you bring it down about 20 millimeters. That means if the blood pressure is more than 180 and 120, you bring it down in first hour 180 and all somewhere. Then subsequent 24 hours, you bring it down to 160 and or 5 to 10% the mean arterial pressure. Slowly, gradually bring it down. It should not be done very fast. And various drugs are used, IV, nicardipine, sodium nitroprusside, labetalol, esmolol. These are the drugs which are available to IV. Most of these patients requires IV preparations for the management of cases. And before we put these patients into the label them the resistant and refractory hypertension, don't think about the only medicine is only the control for the blood pressure. We need to always emphasize on non-pharmacological way of treating this patient, because you need to stress each and every this thing for a medical condition. There is a non-pharmacological way of managing, even coronary artery disease, any diabetes and all these things. You should make them to eat less salt, less than 2 grams or 2.5 grams in a day, do regular exercise, weight control, and avoid excessive fat consumed or high, what you call the high energy calorie foods and all, and do the regular weight checks and control the overweight and all. This has to be done, excessive drinking of alcohol, all these things. So you should keep on emphasizing the patient whether he is regularly following the non-pharmacological method. Otherwise, he give the medicine, he takes the medicine, he goes and he does smokes, he eats whatever he wants, he takes a salty, highly carbonated drinks and all. This is not going to serve the purpose. It is our effort and all becomes waste. So you need to keep on stress this unless he controls the weight. Next time you should be severely warned. Unless you bring down your weight, next time your visit, you should not be allowed to visit you. That you should be strict enough. You should follow that. One side we are escalating the medicine, it has got side effects, the cost is involved. Other side, this guy is doing and all sorts of things which is not interested. That has to be, always we should stress our patients. We should educate more on them. What is the importance of the non-pharmacological way of treating the patients? Now, these are the various classes of the drugs has been used. There are 8 to 10 classes of drugs. Combination of these things are used in this. Now, my talk is given is what is resistant hypertension, what is a malignant hypertension. This is what I am going to talk about this. Now, if any patients who has not controlled the blood pressure using 3 drugs, antihypertensive drugs, to the maximum dose, long-acting drugs, including diuretics, ACE inhibitors, all these things, if they reach beyond 3 drugs, then you call them, they are resistant hypertension. Suppose if you use a 4th drug, and if it's controlled, still they becomes a resistant hypertension, because the drug requirement dose is gone more than 3 level of acting drugs. So this is very important. So you need to give a maximum dose of medication, long-acting drugs. See, make sure that he takes the medicine properly. You need to see that other things he has followed. Then only you label this patient as a resistant hypertension. Why this is important, I'm going to tell you why we are facing a problem of resistant hypertension in the refractory hypertension, I'm going to tell you. Now, the resistant hypertension is also, you need to rule out pseudo-resistance, where it's wrongly recording. Sometimes patient may not be taking the medication, or sometimes when he comes to the hospital, he will have suddenly spurious elevation of the blood pressure, what called white coat hypertension. That one has to keep in mind that these are the white coat hypertension can be ruled out by doing the ambulatory BP recording. You know that when he comes to the hospital, his blood pressure goes up, because certain persons will have a tendency of blood pressure going up, the visit to the doctor. And that can be ruled out during the 24 hours ambulatory recording, whether he is a really white coat hypertension or he is a really true resistance. Sometimes your patient may not be taking medication at all. Now you have no, he comes and tells you that I am taking regularly, but we have no way of testing that. In that case, we do our urinary examples of some of the metabolites of the drugs which are prescribed to see that whether he is taking or not. That will tell you whether he is taking. Now the refractory hypertension. Now here the resistance hypertension is 3 drugs and above. On refractory hypertension, if you take 5 drugs and above, still the blood pressure is not controlled. Now the 5 drugs you have given, various drugs acting at the different levels, still the blood pressure is not controlled, then you table this patient as a refractory hypertension. Now the resistant hypertension, refractory hypertension is very important. In these cases, quite a lot number of patients will have a secondary hypertension. That one you should be very careful about. You cannot label the patient resistant or refractory hypertension unless you ruled out the secondary causes of the hypertension. That is very, very important. Because secondary cause of hypertension, if you find out the moment you treat the secondary underlying cause, blood pressure gets cured or it will be controlled. But you need to rule out and you have to take. Why this is important? There are a lot of studies are done on this. They found that the resistant hypertension is due to excessive volume overload and salt retention, whereas refractory hypertension is mainly due to sympathetic overactivity. This is a distinction they made, and they started using the 4th drug, in this case as an aldosterone inhibitor. They found that there is a good control of the resistant hypertension, but not the refractory hypertension. Now these are various terminals. Now coming to the this is the spironolactone I told already. I will know. Now the first the lot of studies are done. I told you they prove that sympathetic overactivity and all these things. This is the studies they are done. Now I'm going to talk about. Now among the several device approaches, there are now the medication in one aspect. There are several devices are come now. How you can manage this patient. Renal sympathetic denervation, I think Dr. Nimit Shah has already spoken. I'm going to highlight which are the things. And initially it was fallen hibernation, like there was some doubtful whether it really is going to benefit or not. But subsequent studies is proved that it does affect, it does, the lot of work has done on this thing, on these studies. And this is all based on where are the devices can be used, which are the areas one can target. Now they started looking at the carotid sympathetic nerve first. They thought that can we modify the sympathetic nerve innervation of the carotid body? Does it affect anything on the blood pressure? They started working on the baroreceptors and the chemoreceptors present on the carotid arteries. Then they started whether we can stimulate the carotid reflexes and see that what happens to the blood pressure, or we totally denervate, we totally destroy the carotid body reflexes and see that what happens. This is what the work went on to look in certain patients who have hypersympathetic overactivity. The device based on the BAT, the baroreflex activation therapy, carotid body denervation, renal denervation you already heard, and you have a continuous arteriovenous CPAP, that is basically this one sleep apnea syndrome. Central venous anastomosis they tried, pacemaker, neuromodulation, pacemaker induced modulation they are trying.
Dr. Reddy sir, please cut your lecture, sir. Dr. Reddy sir, please limit your time.
Okay. Time. Now these are the things. Now carotid body reflection, they use a lot of this thing. BAT is stimulate the both carotid arteries. They found that this is the initial device they use to surgically install the electrodes there and stimulate both the carotid arteries and see that blood pressure, there is going to be significant fall on blood pressure. And the initial device was a big, and they need to operate on both the carotid arteries. There was a lot of complication. Then they started miniaturing the device. They don't know which carotid body to stimulate, the right or left or both has to be done. Then they started working on the right carotid artery is supposed to be better than the left carotid artery. They started miniaturing the more and more devices. They worked on this and they started barostem because they're also shown a good reduction in the blood pressure. Then afterwards, why do you want to do the surgery? Can we start ablating the endovascularly stimulating the carotid? Then they started implanting the self-expandable stents in the carotid body and increase stress on the carotid body, thereby the reflex activation further comes down. Then they started using the self-expandable stents. There is a good reduction. And afterwards, there is but the study has to, there is not only a blood pressure has reduced, the quantity of the blood drugs requirement is came. So the BAT and the barostem was played a role, but still requires a lot of studies on this. Now the denervation, surgical denervation, they implanted surgically, they denervated and see the bilateral carotid arteries, but it's a surgical method. Then they went on to the radio frequency ablation. Why do you want to do the surgery? We do the radio frequency ablation of the carotid body. They went on radio excision of the carotid body because surgical excision and its complication can be avoided. And there also there is a quite significant reduction of the blood pressure. And this renal denervation. The renal denervation, you already heard there is a radio frequency catheter. But in renal denervation, there is a one study, and what I'm going to tell you is, there is a ultrasonography is ultrasound also. Not only catheter based, they found the ultrasound, this is an ultrasound balloon where you amplify this thing. Because the advantage of this is, you will circumflex, you ablate the renal artery, the nerves. Whereas in a catheter, where the electrode touches that area only it ablates. It's not the entire area. Studies are coming out now. Ultrasonic ablation of the renal denervation is more superior than the catheter ablation, but still that is not available. Now, there is this is a pacemaker neuromodulation. Still it is working, but there is studies shown that high responder, but still a lot of study has to be done. Then alcoholic injection of the renal arteries, where you inject a epidural space and destroy the renal, so that is also done, but this is not a very significant distance. There is only systolic pressure come down, but it's not effective. So the take-home message is, systemic hypertension is a growing contributor to the global disease burden and the premature cardiovascular deaths. The percentage of patients achieving target BP remains a decimal. Really, we don't know. We are facing a problem. We are not able to achieve the adequate control. Hypertension is caused by sympathetic nervous system activation. It's all depending upon the age of the patient and severity of the disease. Device-based interventions have been extensively studied and are targeting the response for the sympathetic physiology mechanism involved in the BP control. And modulation of the sympathetic nervous system, like an renal denervation, carotid body denervation, and bad system, are showing promise. Really, a lot of studies required to be controlled. BP response to the device therapy can be variable. We don't know who is going to respond, who is not. And this should be performed in an experience center. That is very important, because you're going to venture into this system which is a normal. You should not create a problem. You should have a well-experienced center who was trained very well. And secondary causes of hypertension should rule out. That is very important. And early diagnosis of secondary hypertension and timely implementation of appropriate therapy procedures ensures the optimal blood pressure control and prevent the development of cardiovascular morbidity in a given hypertensive population. Thank you. With this, I'm going to stop my talk.
Thank you, sir.
Hello. I just want to add a few things.
Yeah.
We should rule out OSA. If the patient is taking NSAID, nasal decongestant therapy, patient is taking constipation relieving drugs like Cardiology-The should be asked for. And when patient is on 3 or 4 drugs, the drug spacing, dose spacing should be done. Thank you.
Yes.
So, thank you, Dr. M.V. Reddy, sir, for your presentation. Although you have covered this public health problem initially for the simple practitioner, but due to the shortage of time, you could not do advanced technique. So, due to the shortage of time,
because
I would
now I
not
invite
like to close the this session. As you are already.
I invite chairperson to have a token of love to M.V. Reddy, sir, because due to lack of our scheduled time, we are not taking any question. Now, in the session, we are having the last session by the eminent speaker of the Mumbai, that is Dr. V.T. Shah. He does not need any mic rather when he is going to speak. Anyway, you listen how the lipid is the culprit. At the end, we are going to deal the biggest enemy so far as coronary is there. So, sir. Thank you, sir. Now I invite Dr. V.T. Shah, sir, as is, today we are going to last talk, and we have our quiz result. So just wait. We'll give within 1 minute. We'll give the all answer what we had our quiz. Then following that we'll have the winners declaration. Okay.
Dr. V.T. Shah is MD and he is the trained in Germany in interventional cardiology, and he is specialist in complex coronary angioplasties. He has more than 30 years of clinical practice experience. He is the ex-president of National Society of Preventing Heart Disease and Rehabilitation. He is the director of the Classy Cardio Academy, and he has published several research papers on his credits in the international journals, including in the American College of Cardiology, European Heart Journal, Indian Heart Journal Circulation, and he has a lot of achievements. He has already shown in the brand candy, Safi, Vokat, Global, Saurashtra, KD Soumya, Rajesh Portis, Susrut, and Prince Eli Hakan. So, Dr. V.T. Shah, sir, please.
Yeah, good evening, friends. First of all, congratulations to all of you to sit till the end. My apologies for being late for this session and coming as the last. I know you are all since morning heavily loaded with lot of information regarding cardiology and medicine, especially diabetes, hypertension, and lipids now. So with that, I congratulate Dr. Shishir Raul for this holding this conference and being a success. And the other thing I would like to congratulate, he knows how to see that the speaker is at ease. As soon as I came in, he said, would you like to have a coffee? Because he knew that I was anxious how to give the speech. Anyway, friends, so now we are going to talk about lipids. And does it work? It doesn't work? Now, can you, so, okay, still not, yeah. So first of all, now shifting gears from blood pressure, hypertension to lipids. And the common question asked is, that why are we seeing so many atherosclerotic diseases or heart attacks or strokes and complications of atherosclerosis. And as you all know that arteriosclerosis is a degenerative process. Atherosclerosis is something which is related to lipids and it accelerates the same degenerative process. Now it's a leading cause of cardiovascular morbidity and mortality globally, as you know. In the Western world it is number 1. Here we have other communicable diseases also and other diseases, but still it is almost number 2 and 3. We have cancer, we have infectious diseases and diabetes and its complication. So there is higher, now the question, common question, and in an organization like yours, in the railways, you also see a lot of atherosclerotic diseases. And initially we thought that it is all because of luck, and if somebody gets a heart attack, we always say, hard luck, you got it, and it is in God's hands and it is not in our hands. So that's how you get. But now we all know that 80% of it is not God given, it is our own self lifestyle, you may say, or the habits which we have and the problems which we have. And then we all found out that basically it is cholesterol. Within the cholesterol we found out it is the bad cholesterol, which is LDL cholesterol. And you must have read a lot of theories going on WhatsApp. Cholesterol is not the culprit, it is all industry driven. Because the pharma company wants to make money, they are bringing out these molecules of statins and other drugs. And forget about cholesterol, you can have as much as you want. So please remember there is difference between cholesterol and LDL cholesterol. Total cholesterol, yes, they will say it is essential for the brain. If you take cholesterol reducing brain drugs, your brain will get degenerated, there will be loss of memory, you will get Alzheimer's and so many things you will hear and read. But that's not true. What we are targeting is the bad cholesterol, and the bad is LDL. We have tried other studies to increase the good cholesterol, which is HDL, but those have failed and the results were not good. Ultimately, we have boiled down to LDL cholesterol, which is the bad cholesterol. So you all know that, yes, lifestyle modification is the first thing which we say, weight reduction and control of diet and exercise and other things. But then came drugs, and within drugs the most powerful and the most popular and proven drug was statins. So then we said that statins, if you give, there are a lot of other benefits besides statins. And then there were people who said that no, they are not very safe, especially nowadays with Google. Can you keep quiet for some time? So, and then you hear theories, especially the young generation, their best doctor is Dr. Google. So they consult him and find out statin increases blood sugar level, it can give diabetes, it has got muscle pain, muscle toxicity, sometimes it can also destroy the kidneys. So the moment you give them a statin prescription, they'll come back, but doctor, this is too heavy. Why you are giving me such drugs? And they want safer drugs, you see. So then initially we thought that statin has also some pleiotropic benefits other than LDL cholesterol, antioxidant, anti-inflammatory and so on. But now the theory has changed. LDL reduction itself can give rise to anti-inflammatory, antioxidant action, whichever means you reduce the LDL. Whether it is statin, whether it is bempedoic acid, whether it is ezetimibe, whether it is PCSK9 inhibitor or whether it is inclisiran now. So any LDL reduction will give you benefit. So then the next theory changed is if statin has so much side effect, why not reduce the dose of statin and give something additional to that so that you get the same benefit of LDL reduction but with lesser side effects. So the first theory, statins do not have pleiotropic benefits, they only have LDL reduction, and so-called pleiotropic is because of LDL reduction, by whichever means you reduce. So now we say, okay, instead of 40 rosuvastatin, give 20 rosuvastatin or 10 rosuvastatin and add ezetimibe. Now studies have shown that if you give 20 of rosuvastatin with 10 of ezetimibe is equal to 40. And atorvastatin 40 plus ezetimibe 10 is equal to effect of atorvastatin 80. So we are going back now. So now we are saying that okay, use less of statin, add ezetimibe. Now in India we have bempedoic acid also, which also reduces LDL. So you add bempedoic acid to that and still reduce the dose to rosuvastatin 10 milligram. If all these three are given, then you get the benefit of rosuvastatin 40. And after giving this, if your LDL goal is not achieved, then you can step up on the dose of statin from R10 to R20 to R40, or if you are using A10, that is atorvastatin 10 to 20, 40 and 80. So these are the 2 or 3 new things which have come up in lipid reduction. Then what next? Okay. So failure to, just like hypertension, we have LDL goals. Now please remember that's a separate topic, but in short I will tell you. There are 2 kinds of goals for 2 sets of people. One is primary prevention, another is secondary. What is primary prevention? One who has not suffered a heart attack, stroke, peripheral vascular disease. So there is no clinical picture as such, but he is a risk factor because of high LDL levels, because of family history, because of calcium score on the CT scan. So many things, he is a risk person, but still doesn't have anything. So, or he may have diabetes. So the goals are different, and you have to remember, in primary prevention, the goal is less than 100, in a non-diabetic, in a diabetic less than 70. Hypertensive smoker but not diabetes, less than 100. Diabetic and anything else less than 70. But if he has suffered angina, heart attack, angioplasty, bypass surgery, stroke, then the reduction should be less than 55 or 50. So primary and secondary. And then if you see this, there are so many people who don't achieve that goal. In spite, either it is less compliant, their patients are not compliant, or you prescribe them medicine and then they go to some family physician who says, बहुत भारी गोली दिया है, जरा कम कर दो इसका power. And then they reduce on their own. They come back to you after 3 or 6 months, by which time the cholesterol has again gone up. So if you see here in this study hardly 18 to 33% have achieved their goals. And the reason for poor LDL control are various, as I said, will not go, but the commonest thing are two sets. In your situation, like you are working in an organization, the tablets are given free. And therefore, that cost is not a burden on them. So there should be no excuse as such as against what we do in private practice. And now, fortunately, all these drugs are off patent. Whether you talk of statins or ezetimibe or bempedoic acid, they are all available almost at generic price. So that cost now is not a big thing. The only thing is the number of tablets they have to take, and there is nothing which is symptomatic relief to them immediate. What happens? Nothing happens. Cholesterol ज़्यादा है तो क्या हो गया? मेरे को headache थोड़ा हो रहा है, मेरे को breathlessness थोड़ा हो रहा है. So now, if you have to convince your patient, and if he comes with any symptom, then you should tell him, देखो कोलेस्ट्रॉल चर्बी बहुत भर गया है तुम्हारा. इको करने के बाद में भी लोग बोलते हैं हार्ट के ऊपर चर्बी बहुत है, कम करो उसको, गोली ले लो. Easily understood, right? Hypertension, uncontrolled. पहले सर दर्द होता है, ब्लड प्रेशर कम होगा, सर दर्द गया. LDL में ज़्यादा होगा तो कुछ फर्क नहीं गिरता है. So that is the problem with LDL reduction. So first of all, you have to counsel that whatever I am doing now is long term, is not short term. And the other thing in your organization, unfortunately everywhere, I would say not only in railways, but in all organizations or in Western world where things are given free like angioplasty, bypass and anything. साहब ये रोज का गोली क्यों देते हो मेरे को? सबसे बेस्ट ऐसा है, हो गया, वापस एंजियोप्लास्टी करेंगे, शिशिर साहब है अपना रेडी ऑलवेज, कर देंगे अपने को फ्री में एंजियोप्लास्टी. So that kind of attitude if patient has, then it's very difficult to convince him that भाई LDL गोल पे जाओ तुम. डायबिटीज गोल के लिए तो सुन लेते लोग, क्योंकि रेटिनोपैथी होगा, आंखों को दिखने का नहीं होगा तो बोलते हैं अरे अरे बहुत प्रॉब्लम है. अगर पेरिफेरल वैस्कुलर उसको हो गया या किडनी फेल हो गई, क्रिएटिनिन बढ़ता है तो वो बहुत चिंता करता है, अरे क्रिएटिनिन बढ़ गया अभी डायलिसिस होएगा. बट एलडीएल को क्या है? कुछ नहीं है. और एंजियोप्लास्टी बाईपास आप लोग तो फ्री में देते हो, तो पेनल्टी किधर है? बट द ऑर्गेनाइजेशन हैज टू थिंक how much they are spending on this per angioplasty, per bypass surgery, or per stroke for that matter, or peripheral vascular. That the organization has to think. And I tell you, of course, I worked for some few years in Central Railway. If anybody is there, madam knows about it. So, so I tell them, look at the long-term cost, and the long-term cost in what set of patients? In patients who are retired, who are not giving you any benefit as far as money is considered. And on them, you have to spend such a lot. Intervention after intervention, either this intervention or that, either cardiac or stroke or peripheral vascular disease and so on. So that is a big burden. So if you think on those lines, and I tell you a classic example. In UK, as you all know, it's a Western world, so things are given free for the patients. So just like what your organization gives. Now, there, this inclisiran, which we are going to say further, is an injectable form. It's like in vaccine. You have to take only once in 6 months. The only problem is the cost. It's around ₹1 lakh. So, of course, it is expensive than statins, ezetimibe, bempedoic acid and all that what I said just now. PCSK9 inhibitor, which is also injectable, but every 15 days. Now, when all these things are given free, what is the biggest problem you have is compliance of the patient. You don't know whether he's taking, not taking. Dr. Reddy said just now. We don't know whether he's taking the blood pressure medicine. So how do you call him resistant hypertension? Right? Or somebody just now said, madam said exactly. He takes 10 grams of salt. For every cricket match, he consumed 10 packets of, what is that? Lays or what is that? Right? So much salt is going inside, and now you say my blood pressure is not controlled. How can you say that? But then who monitors that? There is no penalty, as I said. So similarly here also, so to get rid of all these problems, what the UK government did is, so there is a study trial which is going on. So they studied that if this patient come with heart attack and angioplasties, what is the cost burden? Suppose if we give them inclisiran once in 6 months in your hospital, in your presence, under your eyes, you sure that this fellow has got an injection and the LDL reduction is bound to be there. If that is the case, and if you take that for 5 years, 10 years, how much procedures will be decreased, and they calculated that the number of procedures will drastically come down. So all those high risk patients are given this injection every 6 months. Why? Because less number of procedures, less long-term cost to the organization. So we have to think, as I said, if everything is free to the patient, he takes, doesn't take, then there should be some kind of penalty. Or in short, even I'll tell you, I'm also on the panel of CGHS, Central Government Health Scheme, which this organization also almost follows that guideline. So there also is the same problem. Retired people, procedure after procedure going on, for everything there is a procedure. But I tell you, if you just say that if you do second time this procedure, you have 10% co-payment, just 10%. And immediately you will see the response, how compliant they become. Because 10% of 1 lakh is say 10,000, और 10,000 रुपया जेब, 10,000 तो क्या 100 रुपया जेब से देने का आया तो वो झगड़ा करता है, ये क्यों देने का? Even in hospitals. So what I am trying to say is that compliance has to be a big factor. You have to think of it, and especially in an organization where the complication cost is borne by the organization. Right. So this is all about, this is poor adherence, I did not go. So now coming to this special molecule, as I said, you have statins, bempedoic acid, ezetimibe. You had PCSK9 inhibitor till now, which has to be given every 15 days, and I'm sure in your organization also, some patients are really high-risk patients getting PCSK9, and that is every 15 days. But the difference between that and this is that that has to be given every 15 days. The cost is 15,000, per month is 30,000, in 6 months it is 1,80,000, whereas here it is only 1 lakh every 6 months, 95,000 to be exact. So you are saving, so in 1 year, in 1,80,000, you are covering 1 full year instead of 6 months of PCSK9. And in those patients who are coming for recurrent procedures, you should give him this kind of drug where you ensure that the fellow is having LDL reduction, definitely. Of course, so this is one step above the PCSK9 inhibitor where that is joining the receptor. This is even before that. Therefore, there are no muscle side effects or diabetes or anything of what statin can cause. And patients, I'll tell you, say for example, I have 3 primary prevention patients. They are so conscious of that statin toxicity. Of course, they are rich people and can afford industrialists, 500,000 crore people. So there's no statin, no ezetimibe. Give this drug. Even before this drug was launched in India, they were taking it from abroad, Singapore, Dubai and somewhere, and getting it and taking it once in 6 months. So that is how it is. And of course, secondary prevention. And I tell you that it's very easy to convince doctor patients. Difficult to convince non-doctor patients for this, and they are very compliant and they take it, and I tell you the benefits are far many. These are benefits versus existing therapies between statins, PCSK9 inhibitor and inclisiran. As I told you, inclisiran is just twice a year, PCSK9 is every 15 days, the cost is more if you see the efficiency, and statin of course are the cheapest, but the problem is you have to take daily, the compliance has to be there, and high dosage has to be taken with some side effects of the patient, and then GI intolerance, myopathy and so on. If you add PCSK9 plus statin or inclisiran plus statin, you can add that, the benefit is still more. And those people who can't achieve their goals despite of statins, you can add this drug. Okay. This is sustained reduction, more than 50% reduction, and there are various studies on this which have proven the safety, efficacy, just that it is injection, and so these are the trials. The only one thing which now left is the long-term clinical efficacy, in the sense reduction in deaths and myocardial infarction. That trial will come soon, but otherwise the small trials have already shown benefit with this drug. And it's a Sirna, it can be repeated. So I'll skip through all this. These are the clinical trial programs. So many trials in phase 1, phase 2 and phase 3. Now we have Victorian 1 Prevent and Victorian 2. 1 is primary prevention, 2 is secondary prevention, and I was telling you that the Victorian Prevent is the one which is in UK, which is going on, and that will show benefit in terms of not only events but also in terms of reduction of the events and money also. So it has been included in guidelines also, and I think 2 maintenance doses per year achieves effective and sustained LDL-C reduction with a generally well-tolerated safety profile as a complement to maximum. Overall, I tell you, in medicine now, things are changing more to this Sirna therapy. It is just like your COVID vaccine, okay, RNA. And now you will have injections in diabetes of insulin, which will be once a week, which will be once a month. So the compliance is going to be better, and the control will be better. So with that I end. If there are any comments, questions, please feel free. We will take them up. Thank you very much. Thank you.
Thank you, Dr. V.T. Shah, sir, for presenting such nice topic, and you have already covered its behavior and compliance aspect also. So, and you are also touched this with a new drug, but I think that will take a lot of time to come for the railway, as it is so much costly for our railway setup. So thank you again, and I think due to shortage of time, we can have the question session later. Okay. Thank
now I request chairperson to hand over a token of love for Dr. V.T. Shah. Now I request Dr. Savita Madam to give a token of love to our chairperson, both the chairperson. Now we are having our result of the quiz and the winner's name, please, now. Now we have the result. As I told earlier, the cardiologists are excluded from the award list. Okay. The question was, what does the PTC stand for? It is percutaneous transluminal. Second, where in which chamber it is? This is a TPI. We have put a temporary pacemaker lead. That it's put in the RV only. Third one is, what is this? Is intravascular ultrasound. Fourth, so what does this PAMI stand for? Primary angioplasty myocardial infarction. Acute coronary syndrome include all except chronic stable angina is not a ACS. All three are acute coronary syndrome. CPR chest compression irrespective of a single or that is 30:2. 30 compression followed by 2 rescue. The etiology of cardiorespiratory arrest these are the 5 H we are having. Hypoxia, hypovolemia, hypoxia, hydrogen toxicity, acidity, hypokalemia, and then hypothermia. No, what we had, hypocarbia, no. So 5T in ACLs, everybody should have this. As you know our name now, we should know what is 5 and what is 5T. So this is 5T, so the 5T. This is the 5T, sorry, okay. we had the choice of tamponade, toxin, tension pneumothorax, no tachycardia. And thrombosis, okay. These were the questions. Thrombosis, tamponade, toxin, but not tachycardia. Next. Come in contact with the deoxygenated blood. That means I am talking about the valve which is in the left side. So mitosis. This is a simple question. Tricuspid. It is a disease of asynchronized. So we are giving asynchronized. So when synchronized is given when you have a QRS. So VT does have a QRS, but pulseless VT do not have QRS. Ventricular fibrillation do not have a organized QRS. So it is a asynchronous shock. Okay. And STEMI, non-statistical is one. So STEMI may, in STEMI we thrombolize. In non-STEMI we never thrombolize. So all are. And what is the absolute contraindication of TMT? Treadmill test. So it is a tricky question. Severe symptomatic aortic stenosis, where the TMT is not done. Only, but severe aortic stenosis person having without any symptom can go for TMT. No. But a pregnancy. The pregnancy, we can go for pregnancy. This is severe MS, not severe MR. Myocardial regurgitation well adjusted in the pregnancy, nothing to worry. So, but pH and which is not a newer anticoagulant. This is the antiplatelet. Aspirin, ticagrelor. This is not an anticoagulant. Anticoagulant is that is no apixaban, rivaroxaban, that is apix. Which factor does not come in exchanging pathway? Is the factor X, that is 12, 10, 11. So this is exchanging, all three come exchanging. What is the absolute contraction thrombolysis except? This is all, is not within, that telling within 3 months, not 3 years. 3 years is a long time to when you will not thrombolyze. Okay, it is an inferior MI. ST elevation in the inferior leads. So usually in inferior MI we give fluid. Don't give nitrate. The moment you will give nitrate, vasodilators further follow BP will be. So nitrate. CKD patient, yes. CKD, this is a clue of CKD. So it is a hyperkalemia. So you can see dysorganized and bladder. So not angioplasty thrombolysis. No, this is electrolysis. This is a hyperkalemia. ECG was hyperkalemia. Okay, this is Dr. Avinash told. That is the HD device closure. Okay. And yes, you see what is the dye is giving and all the dye is coming back. You can see it is coming, not going up. So something related coming from heart. So this is out only, no RA, RV or renal artery. Okay. This is PDA device. In morning, so maybe hum dekhaye the. Okay. Yes. Okay. Now we are going to show the result. And Dr. Rajiv is excluded. Dr. Rajiv is a cardiologist. Yeah, this is the result. Dr. Rajiv we have excluded. He has secured 18 out of 20. Dr. Amarnath VV. And he has secured 16 out of 20. And Dr. Hasina Begum, he is 16 out of 20. And Dr. Priti Gupta. So as there is a tie between them, and so we will have first award, second award, third award. Now both will be awarded same. That is both are first and Dr. Priti second. And the award will be given tomorrow at the validation point. Thank you. Now all are invited to have the cultural activity. Truly, we are going to have a excited cultural activity. All are invited. And Bodhara Park.
After, good evening everyone. After this academic phase, there is time for cultural phase now at Badwa Park, as sir has already told. The arrangement for transport has been done for nominated delegates from various zones and various divisions. 7 o'clock.
There is one important announcement. Please give your feedback forms back on the counter. If not today, at least tomorrow. If you can give today, it's better. And for tomorrow also, you are requested to give the feedback forms. Thank you.
Delegates have been divided in various WhatsApp group, and driver results has been shared on that group. Please